सौरभ,
ये अनघा जोशी इधर कैसे आ गई? ओ अनघा मैडम,
कौन?
Vivek, good morning.
Good morning, sir.
Solid lights you got, yeah? Good day, yeah?
Yeah. Absolutely good day.
Chalo. So, Renuka is also there with you for moderation for the first session.
Yeah.
Vivek will co-moderate with you.
Yes. Vivek, what are we going to do? Who's going to introduce and who's going to field the questions? We can do it alternately.
You would be the right person.
Renuka do alternate. Yeah, or you can alternate. So Renuka can do Kirtane. The next is Vivek. You can do Janki and Renuka.
I beat your high score, by the way.
Sorry?
I beat your IELTS score.
I remember when workshop only.
I just barely wanted to pass it because I wanted to go to UK. That's all.
Yeah, no, I understand.
Scenario समझ में आ गया.
Okay, I think this works. Y'all guys will also need to announce that to keep everyone on mute. And questions, for sir, no questions because not there. But for the other two, either you can decide if they get over in time, then you take it immediately after. If they're not in time, then we'll have to remind them stop, and take it at the end of the session.
Everyone is half an hour, no? Okay.
So we have no idea. One of you guys can log in on the actual thing and just so that we know.
निशिंत सर।
हाँ जी
सर, आपने ये जो शेयर किया हुआ ना प्रेजेंटर व्यू मोड पे, इसको प्रेजेंटर व्यू निकाल के स्लाइड शो मोड पे रख लेंगे सर, क्योंकि यहाँ पे मल्टीपल्स वीडियोस और स्लाइड शो दिख रहे हैं।
अच्छा, इधर आपका ये
Thank you. Likewise.
But
yes.
सर एक पूछूं क्या? अगर प्रेजेंटर व्यू में है तो भी वो उधर से फुल स्क्रीन प्रोजेक्ट होगा ना?
yes करते हैं।
So it would be better to leave it in presenter view because then the moderators know कि कितना स्लाइड उनका बाकी है, क्या है, सब
नहीं मैडम, ऐसा वाला
टाइमिंग भी दिखता है।
वो लोगों को प्रेजेंटर व्यू में सारा जैसा अभी सर का स्क्रीन सब दिख रहा था ना, वैसा लोगों को वैसे दिख रहा है।
ठीक है, ओके।
Okay, are we ready to start?
Yeah.
Who's the
recording in progress
person? Techno person, are we ready to start?
Yes sir.
Nishit, are you going to start?
Tell me when we are live. I'll introduce you and then you introduce everyone.
Okay.
Nishit sir, we are live.
We're live, okay. So I'd like to wish everyone a very good morning. Congratulations to the Indian Academy of Otolaryngology and Head and Neck Surgery for having organized this annual event. Of course, it's been difficult for everyone in these last few years. And so to organize this kind of program, even on is a partly hybrid sort of thing, is very commendable. Best wishes to Gautam that everything runs smoothly. For us here, we are doing the pre-conference workshop on advanced endoscopic surgery. And we do have pretty much a power-packed program for you with absolutely fantastic speakers. Every one of them is internationally renowned. And I don't want to take any more time away from them because we really ask them to keep it concise, brief, and very much to the point. Our first session will actually be moderated by Dr. Renuka Bradu and Dr. Vivek Sasindran. Dr. Renuka Bradu, of course, everyone knows her. She's pioneered a lot of endoscopic surgery in India, especially with angiofibromas. And she's the head of department in Sion Hospital. And she has a fantastic department. She's also doing a lot of work, not just in endoscopy, but also in airways, and has traveled extensively across the world. Dr. Vivek Sasindran is one of our best and most promising young ENT surgeons. He's doing absolute fantastic work, again, in all the three spheres of ear, nose, and throat. He is now a professor of ENT at his medical college in Kerala. And we are very happy to welcome both of you. Over to you all.
Thank you, Nishit. At the outset, I'd like to thank the organizing committee of IAOHNS and Dr. Gautam Khand and Nishit Shah for inviting me to moderate this session. I have the very pleasant duty of speaking a few words about Dr. Padma Shri, Professor M.V. Kirtane. I'm not saying introduce because there's really nothing that we can say which isn't already known, except for the fact that I would like to say that he is a mentor par excellence. He's transgressed the label of teacher and become a mentor. And he's also the master of reinvention. He never sat on his laurels. And as he became the father of endoscopy in India, he also has become the father of cochlear implants in India. Without any further ado, may I request the technical team to start his presentation.
Right. Thanks, Renuka. So unfortunately, sir is on a flight to Guwahati actually to do a physical presence at the conference. So he's left me his presentation. So I'm going to play it from here.
While we're waiting for the presentation to start, I thought I'd share an anecdote about Dr. Kirtane. When I first started private practice, I went to him to seek his blessing. And what he told me then is, Renuka, private practice is all about the 3 A's. Availability, ability, and amiability. And I'm not so sure about the amiable part, and the available part or the ability part, but I took that message from him when I first started my private practice. So I thought I'd share it with everyone.
Renuka, I thought the presentation had already started. You can't hear it?
No.
There is no audio, sir. The slides are being played, but there is absolutely no audio signal.
I'm sorry if I've
interrupted. You're not having audio?
No audio, sir. You can see, I can see the slides, but there's no audio.
I can't see the slides either.
So it is playing audio on my system.
The slides are seen, sir, but there's no audio.
मैम आपको शेयर स्टॉप करके वहाँ पे कंप्यूटर साउंड होगा, उस पर क्लिक करना पड़ेगा, तब आपका ये ऑडियो आएगा.
Okay. Same as system.
शेयर कंप्यूटर साउंड.
स्पीकर में ना,
जब सर आप शेयर का स्क्रीन ये करेंगे ना, शेयर पे क्लिक करेंगे तो राइट साइड के बॉटम में देखिए वहाँ पे शेयर साउंड आएगा, उस पे टिक कीजिए और फिर शेयर कीजिए.
Why can't I see the presentation?
I am not getting any.
Nishit, I'll leave and rejoin. I'm not getting the presentation. I'll be back.
Yeah, okay. I don't know what is happening here. But I'm not even able to share sound, okay?
Yes, sir.
Okay. So I have to just go back and start again.
The skull-based surgeon gets...
Now can you hear the sound?
Yes, sir. Yes, sir.
Okay, sorry about that. So we'll start again from here.
Transnasal endoscopic surgery, especially anterior skull-based surgery, has
Okay,
made remarkable advances in various aspects over the past few years. I would like to share with you here some of these advances and would also like to express my gratitude to my esteemed colleague Dr. Nishit Shah for his inputs and for sharing some of his pictures. These advances have been made possible by several factors, prime among them being the easier access to information and training. The number of books and journal articles that are available today on the subject. More important is the easy access to information on the internet and YouTube video demonstrations by some very renowned surgeons. So you can see that surgical procedure performed by an expert repeatedly as much as you want to understand the nuances of the surgical techniques. There are also a number of training workshops with lectures, live surgical demonstrations by experts, cadaver dissection demonstrations by experts, and hands-on cadaver dissection. Now, this helps a surgeon to acquire the necessary knowledge and the hands-on experience to build up confidence to start doing this surgery. But a major advance has been in optics. Endoscopes of various angles of vision are a part of every operation theatre trolley now. The cameras have improved significantly from the days of the single chip camera. The 4K system cameras now available and the wide screens with excellent resolution allow a very clear visualization, and the 3D system cameras add a new dimension. Good instruments are necessary for good surgery. In the beginning, the standard endoscopic sinus surgery instruments were modified, were lengthened to use for anterior skull-based surgery. But over the past few years, surgeons have designed specific instruments, also sets of instruments to facilitate skull-based surgery procedures, thus making the surgery more precise and much safer. The availability of special drills, for example, that drill at high speed without vibration have helped shorten the time of surgery by allowing easier, quicker, and safer bone removal for access. The skull-based surgeon gets further help from intraoperative navigation, which allows him to locate the instrument inside the head precisely. This again adds to the ease and the safety of the skull-based surgery. Another useful advance is the use of intraoperative Doppler for neurosurgical procedures. This can now be used even in endoscopic skull-based surgery. Tumors tend to displace blood vessels away from their normal anatomical location. The use of intraoperative Doppler helps in locating these vessels, thus adding to the safety of the procedure. Tumor removal using transnasal endoscopic surgery involves creation of large openings in the skull base and defects in the dura. Over a period of time, surgeons have refined their techniques of repairing the dural and the bony defects more efficiently, more effectively, using allografts, synthetic material, homografts, vascular flaps, tissue glue. The incidence of post-operative CSF leaks and therefore of meningitis is now significantly reduced. The standard accepted practice of the rhinologist and the neurosurgeon working as a well-trained, well-coordinated team has made significant differences in outcomes. Raising a pedicle flap inside the nose, the bone removal to approach the target area are usually done by the rhinologist, whose familiarity with the nasal surgery helps in doing this quickly and spending less time on the exposure. The neurosurgeon can now proceed with the tumor removal. The repair of the defect can once again be taken over by the rhinologist. However, with time and practice, both the members of the team, the rhinologist and the neurosurgeon, get familiar with each other's techniques and confidence to overlap their surgical roles. Besides the advances in imaging by CT scan and MRI, intraoperative navigation, virtual reconstructions of the operative field allows the surgeon to anticipate what difficulties or situations may be faced during surgery and can help the surgeon in planning the surgical steps. The technology of 3D printing of models can give him a model of the tumor as it is located inside the skull with the surrounding anatomy, so that he becomes well aware of what to expect and has a 3D impression of the pathology in his mind when he starts his surgery. Now, besides these factors, the use of specific lasers for certain situations, the development of suction aspirators that allow safe debulking of the tumor without damage to the surrounding blood vessels have added to the ease and safety of endoscopic skull-based surgery. But all these surgical procedures are possible because there is an anesthetist standing by taking care of the anesthesia part of the patient. And I think when I said the team includes the neurosurgeon and the rhinologist, I would like to add here that the anesthetist also becomes an integral part of the team who knows exactly what is required during the procedure. Safe anesthesia techniques have... The transnasal endoscopic surgeon ventured from doing his routine sinus surgery to beyond the sinuses, starting with the transsphenoidal pituitary surgery, and then slowly ventured tackling other pathologies. But today, it's no longer anterior skull-based surgery because with the transnasal endoscopic surgery, the surgeon is able to tackle pathologies not only in the anterior skull base starting from the posterior wall of the frontal sinus right up to the sphenoid sinus, pituitary fossa, but also lesions in the middle and even in the posterior cranial fossa by a transclival approach, and pathologies even at the level of the cervical vertebrae 1 and 2. So what started off as just endoscopic nasal and sinus surgery has now developed into a complete science of transnasal endoscopic surgery of the anterior, middle, and posterior cranial fossa. And now the transnasal endoscopic sinus surgeon is also looking at tackling lesions in the orbit, not the ones just medial to the optic nerve, but 360 degrees within the orbit.
I don't know. Can we mute everybody else?
Sir, all are mute, sir.
No, there's a lot of background noise here. Okay, I think is the end of the presentation. Vivek? Vivek?
Hello? Yes, sir.
Yeah, that's the end of the presentation.
Can you hear
now.
me?
Yeah, we can hear.
Okay, sir. Yeah.
I'm
so
going
I
to
think,
stop share.
Yeah. So Dr. Keetan has given us an overview of endoscopic surgery. Rather, I would say the changes in technology, the advances that has happened over the years. And I think in the subsequent talks, we will be touching upon each and every aspect of endoscopic skull-based surgery in detail.
You lost your voice, Vivek.
Am I audible, sir?
Yeah, now you can hear you.
Yes. So what I said was, I think Dr. Keetan has given a brief introduction on the history of endoscopic skull-based surgery. Again?
Yeah, now you can hear. No, you're good. You're good. Carry on.
Yeah, and he has touched upon the advances in technology, the expanded, just a brief overview of expanded approaches, which shall be subsequently covered in detail during the coming sessions. So I think with that, we can move on to the next talk.
I think you can start with the next.
So the next talk is by Dr. Jankiram. So I think Jankiram sir requires no introduction. And he, to me, I would say that he has been a wonderful surgeon, a wonderful teacher, and someone who has always been innovative with lots of ideas and concepts. And here he would be touching upon the anatomy of skull base, which is one of the keys to a successful surgery. So I would like to invite Dr. Jankiram to deliver his talk on anatomy of the skull base. Over to you, sir. Hello. Is sir in?
We are a little ahead of time, so.
Acha, okay. But sir is logged in.
Sir is logged in. Could you give us 2 minutes? 2 minutes.
Yeah,
sir.
no problem. Yeah, we are ahead of time. Don't worry.
Yeah, thank you so much. 2 minutes, sir. Thank you.
Actually, this is a good meeting because
It's
I
not
remember
always
the first time that we met Janki was at Dr. Vivek Sasindran's workshop. This was what year, Vivek?
Sir, if I'm not mistaken, 2009, I guess. 2009, 10, 11, then we subsequently kept meeting. Yeah, it was in 2009.
2009 or 10 must be, I think.
No, 2009, 10, 11. So 3 years
9.
we had, yeah.
Okay.
Yeah.
So that was the first time that Janki was unveiled to us. And we've, of course, been very good friends since then.
Namaskar.
Sir,
welcome,
good morning, sir.
Good morning, namaskar, Dr. Guruji, Madam Guruji, and Dr. Vivek. Oh, Vivek. Hare, Vivek. Great.
Sir.
Great. Yeah, very nice. Actually, I'm not keeping
Nishit sir was just,
that's why I came late, a little late.
What? Acha. Okay.
So, are we live or what are we actually? We are live?
Yes, you're live, sir. Only waiting for you to start.
Okay.
So we just gave an intro. Nishit sir was just recollecting that first time he met you at our conference in Kerala. And way back in 2009.
Yes. Before that,
so he was just recollecting that and then.
No, before that I met him, but we met with you in 2009. I met him in Bombay in 2009 itself. He doesn't know.
Okay.
Many people don't know that I met Dr. Renuka also I met, but she doesn't remember. I met Dr. Hetal, Mafatia, then I worked under her for some time as a fellow. Okay, shall we start? Okay, so I'm sure
sir,
that,
yes, sir, we are waiting for your talk.
Dr. Nishitji would have told good words about me. Thank you for your nice words. And madam, thank you very much for being there. I always, I look up to you for many things. And let me start sharing screen. Okay, so the topic given to me is endoscopic anatomy of skull base, and both the sagittal and the coronal modules. Time given to me is half an hour, right, Dr. Vivek? Half an hour.
Yes, sir. 25 minutes.
25 minutes. So you stop me when I have to go on. Right. First of all, I would like to thank a few people. The first person I want to thank is Dr. Mohan Kameshwaran. In fact, he is the one who is the brain behind this whole conference. And nowadays, I derive a lot of mentorship from him. In fact, he's helping me morally and mentally. And so thankful to you, Dr. Mohan Kameshwaran, sir. No words. I also thank Dr. Nishit Shah. I think he was the one who laid the foundation for me to start my skull-based work by actually teaching me, also bringing Professor Amin Kassam. Third, I would like to thank the organizers, especially Dr. Gautam Kaund, who actually phoned up to me and invited me for this conference. Okay, without much ado, I want to start this lecture by a funny video. Of course, a funny video sometimes can convey a lot of message. So now the surgery is going to start. The surgery is going to start. And the surgeon is, imagine, is unaware of anatomy. So we always say anatomy, anatomy, anatomy is the background for skull-base surgery. Now, let us start this. Now, here starts the surgery. And he is the surgeon. The one who is with the black pant is the surgeon. And the disease, that's the disease. And he goes and hides behind his referee. And then once he touches an organ, there's a complication, immediately he goes and catches a hold of his teacher or whatever. And the disease is trying to say, come on, let me out. But then, okay, he doesn't know how to do that because he doesn't know what is the anatomy behind it. So believe me, unless you really know the anatomy, there is no point in venturing on to doing any surgery for that matter, be it skull base, be it rhinology. So I want to thank my mentor, Professor Dharamveer S. Sethi. Why should I especially thank him? Because he was the one who actually imported a cadaver from America, and he brought it to Singapore General Hospital. And me and Shilpi operated on this cadaver for, I think, 3 days continuously. And he kept it separately in a room. He said, do as much as you want. And then we produced a book with him as the co-author. So no words to thank him. All the pictures which I'm showing here, most of them are our pictures. Some of them are maybe from Google or something else, but most of them are our pictures. So this great gentleman is the one who actually helped me do that. He had a lot of confidence in me. Now, this is a very famous slide of Professor Amin Kassam, also the Pittsburgh group. It's there in the article, so I had the liberty to take it. So if you go to the sagittal, so youngsters who want to venture onto the skull base, actually start doing sphenoid parietal. Hello? Is there somebody wanting to talk to me? Hello? Hello?
No, sir, please. No, sir, please carry on, sir.
Okay. I am sure that many young surgeons, they just want to hop onto the pituitary or CSF leaks, but it is not the right thing to do because pituitary is level 2 skull base surgery, and even CSF leaks for that matter is level 2 skull base surgery. So what is level 1? I think even the neurosurgeons or ENT surgeons should get conversant with the anatomy of the nasal cavity, because that's how you're going to transgress and go into the sphenoid sinus or, for example, into the skull base. So the first thing, please, my dear friends, learn good frontal recess surgery. I know of several people who can't do a proper frontal recess surgery, but they say that I am a skull base surgeon. This is not the case. You should properly do a proper front, even the type 4. If you can do a draft 3, these are all the level 1 surgeries. You have to do a sphenopalatine artery ligation. All this level 1. And the sagittal module starts from the frontal sinus, cribriform plate, and then the planum, the tuberculum, the sella, and then clivus going till the level of the odontoid. Well, the anterior skull base, if you look from inside, has got 3 bones. The frontal bone, the ethmoid bone, and the sphenoid bone. You remember in our anatomy lectures, we always read osteology. So how many of us actually, before venturing on to doing skull base surgery, have a good knowledge of the bones of the skull base? This is very rare. I have not seen people having bones in their hand. In anatomy, they have. After that, they forget to have the bone. You can see in our hospital, we have all the bones here, and we read the bones first before we add soft tissues to it. Now, the anatomy of the sphenoid bone should be properly deciphered. And you know, that's a sellar region, and the parasellar region, and of course, that's a lateral region. So we'll have to read the base of the skull. So always have a skull. I have seen Amin or Professor Amin or Professor Karao in his theater will have a half head, and he'll be going on looking at it. Where is the foramen ovale? Where is the foramen spinosum with respect to the foramen ovale? Where is the foramen lacerum? Where is the foramen magnum? Where is the hypoglossal canal? From above, below, above, below. So this is very, very important, my dear friends, for all the people who want to venture onto the skull base, don't go and put your hand onto anatomy. So you have to have this bone. This bone is so important. This is the ethmoid, and actually you should have a knowledge of the crista galli. You should not have a knowledge of the cribriform plate, the ethmoids, and you should also look into it in various directions, the perpendicular plate of ethmoids, and where is the middle turbinate attached to it, where is the superior turbinate attached to it. At least if you, some people say I don't get chances in theater and all this stuff. I don't believe in it, because if you can get into some bones and try to start dissecting, bones are available in any anatomy hall. Go there, study the bones. This is another bone I always have a beautiful opinion about. This is the palatine bone. See how complex this palatine bone is. And if you look at it, you have 3 different parts. You have the parietal part, you have the ascending part, you have 2 beautiful processes through which the sphenopalatine artery comes out. So I think all the professors, all the students should concentrate on osteology as a class before even 2-3 classes. They should be able to tell which part this is, which part this is. So this is with the postgraduate, they finish it off. No. After the post-graduation only, we need to see all this. The sphenoid bone. This sphenoid bone is the mother of the whole skull base. You have to know every inch of it. If I show this one here, what is this? They should be able to say. You show this one here, they should know what to say. This is what, sometimes they say this is a greater wing and this is a lesser wing. So you should know what is what wing. And you should also try to recognize all the foramina. There are so many foramina inside the pterygoid wedge. So we are talking about pterygoid wedge so often. And have you actually drilled any bone to see how the pterygoid wedge unites with the os sphenoidale? And if you look, I have also dissected when I started pediatric sphenoid bones. So just take the pediatric sphenoid bones, you'll find a lot of cartilage. And once you've dissected, you will know where the ossification centers are. These are all the things, maxilla, you know where the ossification centers are. These are all the things, believe me, which are not very much discussed in lectures. And I honestly believe that unless you have a very thorough knowledge of all this, there is no, see, I'll tell you, there is no point in saying I did a supra-major case. Okay, I'm talking about a junior. Of course, seniors can do that. You have to convince me by saying, I know where the foramen of, versalis is. So you should show me the foramen of versalis. So all this is what I honestly believe is real knowledge. So here we are looking at sphenoid at in a different angle. If you look at it, you see how many things you can actually decipher. If you do this rotated 360 degrees, you get the same orientation which you will see during surgery. You go to the close-up, you see how beautifully the anterior clinoid process. See the anterior wing, the posterior wing. The anterior wing forms the supra-optic recess. If it gets pneumatized, the inferior wing or the posterior wing gets into the optic strut. And how the optic strut divides the optic, superior orbital fissure, the carotid, and the optic canal. And you see how beautiful this sphenoid articulates with this frontal bone or the ethmoid bone. So this is what, honestly, I believe that's a carotid canal. This is the posterior clinoid. If you want to go, you can add a lot of soft tissue now. And see, when you're drilling the posterior clinoid, I will immediately ask, what is the structure which will come here? So then you have to say the third cranial nerve. So this is how I think your anatomy should have a base. There is no point in saying, this is tuberculum planum. That is not anatomy. Anatomy starts from basics. Basics is foundation. Please understand, that's a foundation. And you should also know about the rings of the clinoids, how it can form a complete ring, half ring. What is the significance of a complete ring? What is the significance of a half ring? If you do a MOCR drilling and then try to remove it, you can avulse the carotid. You know that? So that is very important. So people talk about MOCR, but they never know that is a complete ring, then you might actually avulse the carotid. So you look at various specimens. This is something which I want to insist. This is another bone which you have to, apart from the maxilla, this is another bone which you have to be thorough about, the atlas. The atlas, you should know where the condyles are, where is the anterior tubercle, and what are the ligaments attached to the anterior tubercle, and what is the foramen transversarium, and then how the dens comes here, and what is the relationship of the axis to the atlas vertebra. This again and again and again I say, this is the foundation to anatomy of the skull base. So this is part one of my lecture, which I always say, learn basics, basics, basics. Don't jump and say, oh, I can do a sort of an inverted papilloma or so. I don't want all that. Can you identify the foramina? That is very important. Now you add soft tissue to it and then go for endoscopic anatomy. Then you will see the sphenoid sinus when you open. You will see the planum, the tuberculum. And this I want you to say with respect to the bone. Where is the superior intercavernous sinus in an osteology specimen? So this is what I would like to say. What is the clivus? So for example, I several times ask the juniors who say, yes, I'm getting pain in skull base. Just tell me the boundaries of the clivus, the upper, mid, and the lower. And there they actually falter because they actually do not know with respect to the osteology. I ask them with respect to osteology, with respect to the soft tissue, how do you divide the clivus? So from the posterior clinoid till the foramen of Dorlos canal is the upper clivus. From the Dorlos canal till the jugular foramen is the mid clivus. From the jugular foramen till the hypoglossal canal is the lower clivus. So you should be able to show that in the skull. So then you can actually go and operate on the upper clivus, mid clivus, lower clivus, and nothing, you know, by saying I am doing a clivectomy. What is the big deal in that? So now if you look at the nasopharynx, you add that soft tissue, the eustachian tube here, and then you see the anterior tubercle of the atlas, and then you have the anterior longitudinal ligament, and you should know what are all the ligaments attached to what structure of the atlas. So if you look at the atlas, you have beautifully designed ligaments. You have the central ligament, anterior longitudinal ligament, you have the cruciate ligament, you have the dentate, you have the posterior longitudinal ligament, the tectorial membrane, all that in relationship to the bone. And then comes the next step. This is part 2 of my lecture. So you have to see, most of us, what we do is when we start with endoscopic anatomy, we forget that we may, in some cases, try to actually see the anatomy from above as well. Like the neurosurgeons forget to see the anatomy from below. So I honestly believe that go to the neurosurgical theaters. If you want to be a good skull-based surgeon, you don't have to do anything. You just don't have to sit down and operate or anything like that. But you have to get oriented to how the optic nerve looks from above compared to optic nerve looking from below. So when I do a pterynodal approach or a FTOZ, and how the carotid looks, how do I do an anterior clinoidectomy, where is the anterior clinoid with respect to the carotid, all this is what I honestly believe is actual learning. So go to the neurosurgical theater, get the anatomy from above, get the anatomy from posterior, get the anatomy from anterior, and then you start doing. So now, of course, these are all things which we all know, the draft 3, you actually do a draft 3, and then you take off the interfrontal septum. So this is the first module actually. And then you have the frontal sinus opened, and then you have the anterior skull base. And once you do that, that's the view of the anterior skull base. You have the fovea, and then you have the anterior ethmoidal artery, the posterior ethmoidal artery. And this is the perpendicular plate of the ethmoid and the attachment of the middle turbinate, the medial lamella, the lateral lamella. And of course, if you add soft tissue to the bone, then comes actually your orientation. So now you have 3 kinds of anatomy. Number 1 is the bone anatomy. Number 2 is soft tissue added on to that, having a normal anatomy. And third is a pathological anatomy. So the pathological anatomy should be imagined Where will the anterior ethmoidal artery be pushed if you have a tumor here? So this is something which you will read on the MRI or the CT scan. So here we are. I'm just showing you the anterior skull base, anterior craniofacial resection. That's the optic tract. And then I'm resecting the optic tract. You have the fibers here. That's the frontopolar vessels, and you should be able to even talk about the perforators, the small perforators. You might ask, why should I do it? Because the neurosurgeon is going to do it. No. You should know, if you are a skull-based surgeon, this is all skull-based. You should know what is basic anatomy. So I recommend you to read a book called Chushit. There's a beautiful book called Chushit. I used to read it like Bible when I started doing skull-based. There are so many books on neuroanatomy. Brace also is very good. Read it before you go and venture and say that you're a skull-based surgeon. Here we are. You have beautifully the fox. You have the superior sagittal sinus. You should not say that, okay, my job stops here, but then suppose something happens, then you might have to get involved in the surgery, and medico-legally, both of you are involved, not only you, but you and the neurosurgeon. So you should be able to guide him. He should be able to guide you. And where is this sinus draining into? This sinus is draining into, what is the superior sagittal sinus, the vein of Galen, transverse sinus, everything should be properly studied. Now, of course, this will be discussed in so many talks, the superior turbinate being pushed, the sphenoid being shown, and of course, the owl's eye appearance. Everybody talks about it. So there's nothing big about it. My carry-home message to you was, there are three kinds of anatomy. The first is the bone. How many of you study the bone? Number two is, how many of you visit neurosurgical theaters to see the anatomy from a different perspective, and then come to your endoscopic perspective so that you can correlate everything, like, the head completely gets oriented. That's how I learned. That's how I became a complete skull-based surgeon. Okay, so that's the shoulder osteotomy done for opening up the sella. And then there are intrasphenoidal septum. All this will be routinely dealt with in so many textbooks. You can read our book. Also, which we published, and that is quite a very interesting book. You can see here that's a sellar floor, a classical, picture of planum sphenoidale, the tuberculum, the superior intercavernous sinus, the sella, and of course the clivus. Which part of the clivus? It's the mid clivus, not the upper clivus. The paraclival carotid, and the carotid having a loop, the genus of the carotid, lateral opticocarotid recess, and the optic nerve. This is a very standard textbook picture, which actually Professor Sethi allowed us to dissect in Singapore. That's medial opticocarotid. Please understand that medial optic, many say, I saw the medial opticocarotid recess. Medial opticocarotid recess is not an anatomical structure. It is a concept. It is not a structure. Middle clinoid is a concept. Medial opticocarotid recess is just when the middle clinoid or something like that gets pneumatized. It gets pneumatized. Very rarely have I seen a medial opticocarotid recess. In fact, in 1,500, 2,000 cases which we have operated, we very rarely see MOCR. We only have it as a concept. I don't know why people say that maybe the area where the optic nerve goes inside, that is intracranial, and the carotid goes intradural, that area which is lateral to the tuberculum, that's the lateral tubercular strut, is called the MOCR, but there is nothing like the anatomy of the MOCR. That has been clearly told by Professor Amin Kassam. Now here is the planar dura, the tuberculum, and of course you have the Dandy's ligament here, and then you have the superior intercavernous sinus, the sella, and the clivus. Okay, that is the superior intercavernous sinus. I always say that when you do a cadaver, don't do a cadaver like a dead body. Do it as if, use all the instruments. This is the problem again. You see what happens is that they give you a cadaver, and then they give you some 3 instruments. That is a Blakeslee and some pulling instruments. And what you do is you just want to open up the sphenoid and just pluck, pull, and then you say, yes, I've opened up the sphenoid. That's exactly not the way to do it. You have to do it like you do it in the operation theater. So there's no point in doing a cadaver without the proper instruments, without the proper camera. So I have never done any dissection without a Kassam scissors. I have never done any dissection without a pituitary elevator. So I've done around 65 dissections in various parts here, at least, and all of them have been with simulation to the body. So whatever I do in the body will be replicated there. So this is something which I want to say, and this is actually the optic chiasm, the optics, and then you see that superior hypophyseal artery. And when you handle a superior hypophyseal artery, you should be as if you're handling the live specimen. That's more important. See the finesse which you show. That's anterior circulation, which is suprachiasmatic system. You can see the anterior ACOM, and then you have A1, A2, A3, A4. You should know where the A4 goes. What is the callosal segment of the anterior cerebral? You should know everything about what you're trying to do. And then you have the retroinfundibular system, and what are the structures, what is the pre-liliquist, post-liliquist space, and then of course, how do you do a pituitary transposition by a transdorsal approach, and that's drilling off, and then you have the posterior clinoid, as I said. When I drill the posterior clinoid in live, I've done several pituitary transpositions now, at least 4 of them now, and most of them done for cranios. But when you do the drilling of the posterior clinoid, you should be able to clearly understand that the third cranial nerve is very close to it. And that's how you look at the interpeduncular system. Of course, this is normal anatomy. You will have pathological anatomy. You'll have a lot of tumor here. And you can see that's the P1 perforator. Another important thing is you should always concentrate on perforators. The PCOM has 18 perforators. The P1 has 4 perforators. I can even dissect every perforator, perforator to the cortigeminal plate, the posterior thalamoperforator, choroidal perforator. So you should be able to dissect every perforator. Of course, it's not needed, but sometimes you may need to do that. So that's very important. So that's the choroid plexus, the lateral ventricle, the foramen of Monro, foramen of Monro. This is the aqueduct of Sylvius down below. The hypothalamus is below. So that's the third ventricle. Of course, then you start doing the transpodentoid approach. See the longus capitis muscle, the midline raphe, and you know how beautifully you can open up the lower clivus, and then you see the vertebral arteries. That's the 6th cranial nerve. The VBJ is directly related to the 6th nerve. There are 3 nerves which have a constant relationship with arteries. The 3rd cranial nerve is marked by the SCA, PCA. The 6th cranial nerve is marked by the VBJ, vertebrobasilar junction, and the 12th cranial nerve is marked by the pica. Okay, now that's the dissection which we did. Of course, this is not a complete dissection because you get what is called the flower vase appearance. That's a flower or appearance. I can still more go, but the lateral dissection is limited by the condyle. So that is very important. You can see how beautifully the jugular foramen is seen. You might ask me, what is the use of doing a jugular foramen dissection in I went to Cebu. I remember I went to Cebu and they asked me to do a chordoma going on to the jugular foramen, and transnasally we did it completely, and the neurosurgeons were awestruck. Oh my God, going and showing you 9, 10, 11 cranial nerves endoscopically was something new for them. Okay, so that's the dolichocephalic vertebral artery, and then of course you see the 12th cranial nerve. Well, it's a ventral nerve. The 12th cranial nerve is the most one, and then you can dissect the anterior spinal artery. And then you can see all the other spinal cranial nerves. And then this is the carotid. So please understand that you have to know everything about the carotid artery. You have to know the parts of the carotid. Try to drill off the petrous bone and then get the neck. And then from the neck, go parapharyngeal, petrous, and then foramen lacerum. And you should always look at the FCL and then go paraclival, and then you have the cavernous clinoidal. You have see here, that's a dural ring. That's the proximal ring and the distal dural rings. You have the ophthalmic artery going like that, and that is the intradural part. The first intradural branch of the internal carotid artery is the superior hypophyseal artery. That is the pituitary. You can see the basilar circulation. You have a communication between that, which is the circle of Willis. So, of course, I can deal with the coronal planes as well, but I am not going to do that because of lack of time. Just wanted to convey a few concepts to you so that the juniors can work on it in future and actually get to know more of the anatomy. Thank you very much, Professor Mohan Kameshwaran, sir. You're a mentor, guide, and whatnot. Professor Vivek Sasindran is my very close friend. I had great time with him in several occasions.
Dr.
Thank you so
Jankiram.
much, sir. Yeah. Yes, ma'am.
Dr. Jankiram, thank you for an absolutely mesmerizing talk, as all your talks always are. And I'm so happy that you discussed osteology before you discuss the soft tissue anatomy, which really gives a three-dimensional knowledge of the skull base. And we look forward to your further talk. And thank you so much for keeping to the time. It's very good of you to do that. We will go on now with the third talk. This is to be taken by Dr. Gaurav Medikari. Dr. Gaurav Medikari is one of the leaders of the Young Turks, the upcoming rising stars in ENT service. And he has done a tremendous amount of learning before he began to teach. And I think I'd like to speak about the various fellowships he's done. He's done a fellowship at the St. Paul's Sinus Center in Vancouver. He's also been at a one-year surgical fellowship at Liverpool in the United Kingdom. He did a 6-month fellowship in Seoul, Korea. He's also worked with Satish Jain for a short period of time. He's also been at the St. John Medical College and Hospital in his earlier days as a student. He was awarded the gold medal for securing the highest marks in the ENT final exam, which is no surprise. Gaurav, it's a really illustrious CV that you're building, and I'm sure we're going to see many more feathers in your cap as the years go by, and I look forward to seeing your phenomenal growth in the field of ENT. And I ask you to start with your presentation.
Very good morning to all of you. My name is Dr. Gaurav Medikari from Bangalore, and today I'm going to be talking about radiology of the skull base. First of all, let me take this opportunity to thank Dr. Nishit Shah for giving this platform to talk to you about this topic. And secondly, I'd like to thank all of my teachers who are actually present here today, whose work I've been following very closely, and this lecture is actually a result of their work, specifically Dr. Renuka Pradu, Dr. Satish Jain, Dr. Janki Ram, and Dr. Nishit Shah as well. So with that, we're going to start today's lecture. So the skull base is actually quite a complex area. So you can see that the skull base is divided into 3 categories: anterior, middle, and posterior skull base. Whereas the bottom of the skull is actually an even more complicated and complex area with a lot of undulations, which makes radiology very important in order to study the pathology very well. We have 25 minutes for this lecture. I'm going to do the best that I can to cover most of the topics that we have to. In most of the cases, we have 2 types of scans that we predominantly use. The common one used is a CT scan, whereas MRI is usually used only if there is a pathology which is crossing or surpassing the sinuses. So in CT we have, as we know, the coronal sagittal axial scans, which are commonly used. Certain times we use an oblique scan as well. We may or may not do it with contrast. Whereas in MRI you have T1 weighted, T2 weighted, T1 with fat suppression, flare images, 3D sequence, and many other such sequences which are specific to a certain type of pathology as well as to a certain type of anatomical structure that we use. We may or may not use contrast again in this case. So just to brief you, T1 weighted image will actually highlight fat, whereas T2 will highlight fluid anywhere in the body. So if you want to differentiate grossly between pathological fluid and physiological fluid, of T2 flare would help you. A 3D CIS sequence is basically, CIS stands for continuous interface in steady state. What it tries to do is basically gives you a very good signal to noise ratio and actually highlights certain structures like nerves against the backdrop of a brightly colored structure like CSF, so that you can identify these cranial nerves or structures very easily. Contrast is usually used to identify if a tumor, its extensions, what is the size of the tumor, whether it's vascular or not, that sort of thing. And certain times you can also figure out the blood supply to the tumor if possible. So when we talk about skull base, because this is purely a radiology of skull base lecture, I'm not going to really be discussing on the sinus aspect of it, because I presume that anybody who wants to do skull base surgery would already know sinuses in and out. So there is no point in discussing sinuses. So what we're going to talk about is some of these topics, whatever 25 minutes will permit us, because it's a very vast topic and there are varied pathologies in each of these categories. It's almost impossible to discuss everything, but we will do our best to cover most of this. So common things that we need to know about when you're a beginner is pterygopalatine fossa, infratemporal fossa, masticated space, orbit, orbital apex, supraorbital fissure, these foramina, cavernous sinus location and pathology and structures, Meckel's cave, base of skull, that is from anteriorly till posteriorly, sella and clivus. So here you're not thinking within the sinuses, but you're thinking outside of the sinuses is what we're going to be predominantly discussing. So let's just understand the basics of MRI. The first step, if you want to interpret an MRI image, is to correctly identify the T1 and T2 weighted as well as the pre and post contrast images. So T1 images can easily differentiate fat from water, fat and water from other common intracranial tissues. Like fat appears brighter and water appears dark on T1. Whereas T2 weighted images, they have a similar capacity, but they have opposite features. Fat appears dark and water appears bright. So a simple way to remember this is T2 and H2O. H2O is water, so anything with water will appear bright on a T2. So within the head, the most common T2 bright object is actually CSF. And this is particularly evident around the cisterns, which surround the cella actually. So in practice, if you want to direct one's attention immediately to the lateral cerebral ventricles, what you can see here, so you can easily tell whether this is a T1 or a T2 image. So this is very clear that this is a T2. Whereas here, if you look, this is appearing dark. So this has to be a T1 image. That is how you differentiate between a T1 and a T2 image. Now that you've done that, whether it's T1 or T2, the next step that you want to do is to interpret whether this is an image which has contrast or no contrast. So certain pathologies, it is obviously very evident whether it is with contrast or not. But in a situation like this, when you don't have a lot of contrast uptake, your attention should immediately go towards the turbinates. So if you look at the turbinates here, you can very nicely see that these are enhanced. Okay, and if you look at the palate as well, you look at the posterior part of palate here, this is also enhanced. So whereas if you compare it to this side, this appears a little darker. Correct? So when we were doing muco cases, there was a lot of confusion amongst our residents. They would say that this appears dark despite there being contrast. But you need to also check whether or not contrast has been administered. And secondly, it will be usually mentioned on the series or on the film as well, whether this is an image with contrast or without contrast. That's another way to look at it. So if the highly vascular areas, that is turbinates, are appearing bright, that means this is a scan with contrast. If there is no uptake, it does not necessarily mean that this is without contrast. It could be a case like mucormycosis or something where contrast uptake is not happening, but also correlate this with the image sequence, whether it is a contrast image or a non-contrast image. But most of the time, this should work for you. If you look at an image like this is actually a patient of mine, 5-year-old girl, who's got a huge sellar and clival mass, which is extending, and actually it is causing compression symptoms on the pons here, if you can actually see that. This is a very vascular lesion. We are yet to find out what it is. So as soon as we give contrast, within about 15 seconds of contrast, tumor has taken up a lot of it. So what this gives us an idea as to is that how vascular the lesion is, and you should expect significant amount of ooze from this tissue is what we need to know. So this is how you differentiate contrast and no contrast. Now, if you actually want to know how contrast imaging happens, so this is how it actually looks. So if you observe, this sella area is absolutely dark to begin with in the beginning, and as soon as we give contrast, it starts to highlight. So this is called dynamic MRI imaging, where as soon as we give the contrast, the area which is quite vascular will take up that contrast. So here you can see just in between the carotids, that is the pituitary stalk there. So this is the area of the cavernous sinus actually here, cavernous carotid. So that is why it is taking up so much of contrast. Now let's come to our first topic that we want to discuss in detail, that is the pterygopalatine fossa. So this is an area which is behind the posterior wall of maxilla and anterior to the actual skull base. So this is a very complex three-dimensional space, and it's very important to know about this because mainly from the perspective of a lot of common tumors which originate from here, that is predominantly juvenile angiofibroma, adenoid cystic carcinoma, squamous cell carcinoma. So these tumors also have a propensity for perineural spread, predominantly adenoid cystic carcinoma. And ACC, usually the primary treatment of choice is surgical because unless it's c-KIT positive, radiation or even chemo is not going to work against it very well. So surgery becomes the first choice in these sort of tumors which have perineural spread, and this is a richly neurovascular area. So if you look at the image here, there is a lot of communications with other parts of the skull. Medially it communicates with the nose, anteriorly through the maxillary sinus, through the floor it goes to the pterygoid canals, laterally through the pterygomaxillary fissure it actually communicates with the infratemporal fossa, posteriorly through the lesser wing of sphenoid, foramen rotundum, median canal, nerve of palatovaginal canal, and it also communicates with the inferior orbital fissure through the sphenoid, greater wing, part of the greater wing of sphenoid. So this becomes very important for us to understand what are the communications and how we can actually identify where the tumor is going, or even for that matter identify normal structures. So this is how actually the pterygopalatine fossa looks in 3D. So if you see this, these colors, what they indicate. So basically this blue color, what you're looking at here is actually the foramen rotundum. The yellow one is the pterygoid canal or the median canal. The red one is the palatovaginal canal. So this is medial and this will be lateral. Okay, and below you have green and purple. So green one is the greater palatine canal and purple is the lesser palatine canal. So this is how it is actually oriented in real life. And if you want to understand, sort of the anatomy a little better, then we can actually just go through this video here. So what you're looking at is the body of sphenoid and greater and lesser wings of sphenoid. This is the lesser wing, greater wing, body of sphenoid, pterygoid plates. Here you can actually very well see, we have the median canal, foramen rotundum there. That is the sphenoid os, rostrum of sphenoid. And this area here is where it communicates with the superior orbital fissure, and this is the inferior orbital fissure below, that is the optic canal, and the optic nerves going through the canal and becoming the optic chiasm. So this is the area of importance, and this is what we are going to start studying now. So if you look at this image here, you'll be able to see very easily as to why we highlight so much on this space. The reason being that it's quite easy for any kind of tumor to spread to all spaces in the skull just by attacking this one space. So let us see the first image here. What you're seeing is actually, this is the maxillary sinus. There is a mass within the maxillary sinus, and behind that we have this canal here, or the area here, which is basically a pterygopalatine fossa. Now this is communicating medially through the sphenopalatine foramen. Here it is actually narrowed, but on the other side it's actually quite broad. And this is the partition or party wall. This is called as the pterygomaxillary fissure, where it communicates with the infratemporal fossa here. And if you look at this image, there is a opacity within the maxillary sinus posterior wall, pterygomaxillary fissure communicating with the infratemporal fossa here, the superior orbital fissure, and this is the junction, that is the inferior orbital fissure, and sphenopalatine you can see is actually quite widened on this side. If you look through the sagittal view is best to give you a view of the whole of the greater palatine canal. So this is the canal which communicates from the pterygopalatine fossa to the palate, so which contains the greater palatine nerve and vessels. So here in this patient, this is a case of adenoid cystic carcinoma which had perineural spread. On an MR, you get to see a little more muscular and nerve detail. So if you very closely observe, you'll actually see fat-filled space in the pterygopalatine fossa. So obviously this is a T1 image what you're looking at, and this is non-contrast because there is no enhancement of the turbinates. So this area will look fat-filled, and you will also see certain small structures I'll discuss with you in the next slide. This is also basically the pterygopalatine fossa, fat-filled space communicating. This is the greater palatine canal there. So on the CT again, you get to see these bony canals carrying certain nerves. So the one which is medial is actually the greater palatine canal, and the one which is lateral is actually the lesser palatine canal. You can see the pterygoid plate. This is the medial pterygoid, lateral pterygoid, and this is the lateral pterygoid muscle here. So what we also need to sort of understand in this scan here is this is actually the second scan. What you're seeing is a oblique cut. In the oblique cut, you can very well see this greater palatine canal. You can see the whole longitudinal course of the greater palatine canal. Actually, the canal is slightly oblique, and that's why you need to take a oblique reconstruction if you want to see it from the apex till the its termination. And another thing of importance that you would want to actually study is how to identify these nerve structures without any doubt. So if you see this scan here, the third one, so this is the maxillary sinus, this is the pterygopalatine fossa, this is the pterygomaxillary fissure infratemporal fossa here, sphenopalatine foramen, and if you look closely, you can actually see a canal here. Now, how do you identify which canal this is? It is very simple. You have to trace it backward and see where it's going. So this is obviously the horizontal petrous carotid that you're seeing, or the foramen lacerum segment, which starts off in this, just below this cut. If you see a nerve or a canal which is going towards this carotid, then you know that this has to be the Vidian canal. Whereas if you look in this image here, there is another canal which is opening up. If you look at this area here, so if you see a canal which is going to the middle cranial fossa, which is basically this whole space here, middle cranial fossa, and you can also see a segment of carotid here. So this happens to be the V2 segment, or the maxillary division of the trigeminal nerve. So that is how we can identify whether or not this is Vidian canal or maxillary division of trigeminal nerve. So let us discuss one patient with a common tumor in this area, that is the nasopharyngeal carcinoma. So this is a patient of ours actually presented with NPC. So you can see there is an enhancing mass in the right side of the nose, and it's coming into the medial half of the right pterygopalatine fossa via this area here, which is basically the sphenopalatine foramen. So this is how it actually extends from the nasopharynx into the nose and then into the pterygopalatine fossa, and from there it can actually virtually travel anywhere that it wants. So if you look at the second image, again there is an contrast enhancing mass which is sort of extending into the left nasal cavity, and there is bilateral involvement of the pterygopalatine fossa. In fact, you can even trace from this area here. There is a very thin nerve which is going here. If you look at this space, and it's going up to the foramen lacerum segment. So this actually this is how a perineural spread would look like This is how perineural spread would look like in a patient. This is a nasopharyngeal carcinoma. So that is how we need to identify if there is perineural spread or not. This again becomes, of course, the primary modality of treatment in NPC is supposed to be radiation. But if there is a radiation-resistant tumor, then surgery will obviously become a primary, second line of management. In those cases, we need to know where all perineural spread has happened. Now let's talk about the infratemporal fossa. So infratemporal fossa radiologically is divided actually into 5 zones. So let us just discuss very quickly. This is actually the first zone. The first zone is basically known as the retromaxillary space, which lies between the posterolateral wall of maxilla and the muscle complex, that is temporalis, pterygoids, etc. Zone 2 is a little high space. Basically, it is if you take the pterygopalatine or infratemporal fossa and you look at this muscle here, this is basically the lateral pterygoid muscle. What you're looking at, it has 2 heads, that is superior head and inferior head. So zone 2 goes through the level of the superior head of the lateral pterygoid muscle. So this is the upper part of the ITF. So here you have V3, foramen ovale, and other structures which come into this area actually. So the zone 2 is again quite important for us in terms of perineural spread, because these are the important structures which pass through this area. And zone 3, if you look at it, it is nothing but the inferior interpterygoid space. So you have the inferior head of the lateral pterygoid muscle, medial pterygoid, and the temporalis muscles which are present in this area. Zone 4 is the temporomasseteric space. Basically, it is a space which is lateral to the temporalis muscle, and this mainly contains fat. This again becomes important, like in cases of mucormycosis, this was quite an important space for us. Even in cases of angiofibroma, this becomes quite important. And the last zone is basically the tubopharyngeal space. This contains the, here you can see this area here. So this contains the eustachian tube, tensor and levator palatii muscles, and basically structures within the upper parapharyngeal space are contained in this zone 5. So this is how we can categorize the infratemporal fossa, and pathologies which are invading these zones we can identify and decide how we want to progress. The other space which is quite important is basically the maxillary, the masticator space. So here on this, this is a coronal CT. If you look at, so this is the mandible here. Whatever is lateral to that muscle is actually the masseter. Medial to the mandible here, you have the lateral pterygoid muscle above, just below the skull base, and below that you have the medial pterygoid muscle here. So this is quite an important space again. Certain tumors can spread to the masticator space, which we shall see a couple of them. So one of the important things that a scan would help you with would be to understand whether or not there is pathological involvement even before you actually venture out into surgery. So this is one case where radiology actually helped me. What you're looking at here, this structure, is actually V2, where it's giving down certain branches to the pterygoid plexus, nerve plexus, and below that, the structure that you're looking at is actually so that is the V2 there, the arrow mark that is pointing, going through the foramen rotundum, and this structure that I'm teasing right now is actually the IMAX. So although the IMAX looks pretty much normal, this is the third part of the IMAX, the thing is it is actually not. So if you have a contrast enhanced image, you'll be able to tell why, because when you cut through this vessel, there is absolutely no bleeding in this vessel at all. So if not for imaging, we would not have known whether or not this is involved, because intraoperatively it looks pretty much normal. So if you look there, there's a black muck inside the IMAX blocking it. This was a case of mucormycosis. So this is how imaging can actually help us identify pathologies even before we venture out into surgery. Angiofibroma is another common issue that we come across in this in this area. That is a pterygopalatine fossa happens to be the seat of origination of the angiofibroma, and it can extend into a variety of situations. So here you can actually see this is one of our patients. So when you give contrast, as in when we're going down, you start seeing an enhancing mass which is starting to appear in this area, and you can very well see behind the maxillary sinus, this is the pterygopalatine fossa. Through the sphenopalatine foramen is coming to the nasal cavity and nasopharynx. Another important thing that we also need to study in case of angiofibroma is understand how to study the MR angio or CT angio. So this is a angiogram where you can see that the branch of the external carotid, when it was dye was passed through, it actually this is a fluoroscopic image actually, but it basically gives rise to blushing or filling up of the tumor. So that tells you where the this thing blood supply is coming from. So this is another angiofibroma in a 14-year-old. It's important for us to know where all the tumor is going, because you saw that there was a defect in the skull base at very close to the V2 actually, and this sort of correlates surgically as well, where when you remove the tumor, you see this huge defect in the skull base with the brain bulging out, and that is the V2, which is going interdural actually, between the two layers of dura, between the medial temporal lobe dura and the lateral wall of the cavernous sinus. Actually, inferior lateral wall of the cavernous sinus is where it goes. And we can actually even trace that nerve further towards the Meckel's cave if required. Now let's discuss about the orbit as such. So one of the most important structures that we usually pay a lot of attention to is the optic nerve. So optic nerve is approximately about 5 centimeters long, and it is divided into 4 segments. You have the various segments being, this is the intraocular segment, which is roughly around 1 millimeter, very small. The intraorbital segment is the longest segment, and this is about 2.5 centimeters. So this nerve is technically not a nerve, it's an extension of the brain is what we say, because there's a communication between this subarachnoid space around the optic nerve with that of a suprasellar cistern as well. So that is why we don't call it as technically it's not a nerve. The third part is the intracanalicular segment, which is the most dangerous part here, what you're looking at in this area. So the intracanalicular segment, the problem is that one is it comes at the very close to the sphenoethmoid junction. That is a posteroethmoid and sphenoid junction. The second issue is that this area is very rich in pile vessels. You can actually see one of the vessels which is going from the carotid to this area. So the pile vessels, what happens is in the canal, there is no space for the nerve to expand or to hold any kind of blood. So when you even crack the bone, if the pile vessels are sheared, then you can cause optic nerve compression almost immediately in this sort of case. So that becomes very much important. And the fourth part is seen in the cut above, which is basically the prechiasmatic segment. So this is an intracranial segment which is in the suprasellar cistern. So whenever we do an optic nerve decompression, we don't have to decompress this part, that is the fourth part, because it's within a cistern and usually there is no pressure on that part. So that is important to know. This is basically how a patient with optic neuritis would look like to you. If you compare with the opposite side optic nerve, there is increased uptake of contrast and thickening of the nerve. And if you compare on the coronal scan, you'll see that the nerve appears much brighter compared to the opposite side, and it appears much larger as well. So this is a case of optic nerve glioma, which was presenting with slowly progressive vision loss. She was a 40-year-old or 42-year-old lady. So this is a post-contrast image again. You can see because lab criminal has taken up some of the contrast. So you can see this enhanced sort of bulbous mass, which is around the orbital segment and intracanalicular segment of the optic nerve. The orbital apex again is very, very important to study because it is again a very richly communicating area. So in this image, if you pay attention closely, you'll be able to see that there is a difference in the appearance of this area here and this area here. So there is a mass lesion which is presenting at the orbital apex, and if you observe again posteriorly, this is actually V2. So there is spread along V2 into the Meckel's cave through the foramen rotundum in this area. So that is again an important area for tumor spread. So this is another patient of ours who presented with a very rare tumor called phosphaturic mesenchymal tumor. This was actually a mass. The way he presented was he used to have multiple fractures and he was actually bedridden for almost 2 years. So very rare tumor that presents. Basically, it's a PNET where it secretes a hormone called FDG, so FGF, that is fibroblast growth factor 23. Basically, it reduces calcium, phosphates, and vitamin D. So supposedly happened to be in this area, and the blood supply was coming from the ophthalmic artery, which we had to ligate before we took the tumor out. Another case where orbital involvement we saw was this 5-year-old girl. She had a traumatic meningoencephalocele, which you can see here. So she fell from the second floor of her house and developed an intraorbital meningoencephalocele with CSF leak, which was happening intermittently. So we decided to do a transorbital neuroendoscopic approach where we made an incision in the eyelid, and you can see as soon as we elevate the periorbita, you can see the defect in CSF draining out there. So when we went inside with an endoscope, you saw a huge defect and a meningoencephalocele, which was reduced, and we used Duragen and used osteomesh as well. This is what it looked like before, where you can see that meningoencephalocele, and here you have a mesh which has been placed, and the repair has been done post surgically. So skull base involvement. This is an adenoid cystic carcinoma, 40-odd-year-old, 50-odd-year-old guy who presented with a massive adenoid cystic carcinoma. Unfortunately, he had metastasis to the thyroids as well. So here you can see the level of involvement of the skull base. It's quite gross. So whenever we talk about skull base, we need to know one of the most common things is the sphenoid anatomy, especially if you want to do cellular tumors. So there are actually 4 types of cellular pneumatization. So the first one that you're seeing is conchyl, where there's absolutely no pneumatization. Second one is where the pneumatization happens from the anterior wall of sphenoid bone till the anterior part of the cella. So this is called as a cellular type of pneumatization. Between these 2 varieties, there is one more where the pneumatization is up to the posterior wall of the cella. So from the anterior wall of sphenoid till the posterior wall of cella, this is actually called as this is a precellular variety, and this is cellular variety. So this is precellular variety, and this is cellular variety of pneumatization. And when this pneumatization actually crosses the posterior part of the cella, then it becomes a postcellular variety of pneumatization, which is what you're seeing here. Now, normal pituitary anatomy, again, very important to know. Here you can actually see the pituitary gland, the stalk, the optic chiasm, and above this is the cavernous sinus. And above this, you can actually see a glimpse of the third ventricle, and along that adjoining area, this is the hypothalamus, which you're actually seeing. That is the lateral ventricles there. So in this first image also, you can see the pituitary gland, which is nicely taking up contrast, and the stalk going to the hypothalamus there as well. Let us now discuss about pituitary lesions, the most common being a pituitary macroadenoma. So if you look at this first image here, this is obviously a T2 image without any contrast, because the nasopharyngeal mucosa is not taking up any contrast. Here you can actually see a large cellular and supracellular mass, which is basically extending cranially, and it has displaced the optic chiasm here, which you can see very well. So the mass, this is also extending laterally into the left cavernous sinus, and if you see, this is quite a heterogeneous appearance, because there's an area here of differential uptake, probably because of necrosis. It definitely doesn't, you will have to correlate if there is any pituitary apoplexy clinically as well. It doesn't look like it, although. So, and a second image, if you look at, this is a T1 image, because there is no, highlighting here. But if you look here, there is increased, brightness. So this is probably a contrast enhanced T1 image. So you can actually see that same area of heterogeneity that you're seeing. There's an area of non-enhancing necrosis, and this tumor appears to incompletely encase the carotids here. And actually on this contrast enhanced image, you will be able to actually assess better the extension into the cavernous sinus will be much better, because there is a little bit of narrowing of this left side carotid if you compare it to the right side. So this you can actually appreciate much better on this T1 contrast enhanced image. So this appearance is typically called as a biker on Harley appearance or a snowman's appearance. This is what is normally the pituitary macroadenoma is appears to look like, especially when there is a supracellular extension. Again, on the sagittal scans, you can actually identify the same mass, large cellular supracellular mass. Then this, on the sagittal scan, you can actually see the whole optic chiasm being elevated upwards very well. You can see the whole course of the optic chiasm there. And pretty much also you will get to see if there is any posterior extension, towards the brainstem as well. Certain cases it may not be a pituitary macroadenoma, but some other cases you might see an extension posteriorly. That again becomes important. So when you study tumor extension, there are multiple grading systems which are present for tumor extension. So if you to look at superior extension, if there is no tumor extension into the anterior cranial fossa, then it is a grade 0, and if there is extension into the anterior cranial fossa, it is grade 1. So this is basically for anterior tumor extension. With regards to posterior tumor extension from the sella, grades 0 and 1 are distinguished from each other in the sagittal plane. If there is no posterior or inferior growth of the tumor behind the clivus, it is called as a grade 0. Okay. Whereas if the tumor growth is there behind and inferior to the dorsum sella or clivus through the diaphragma sellae, and if it goes into the prepontine subarachnoid space, then this is called as a grade 1. So this can extend anywhere posteriorly, then that might be a grade 1. Sometimes there might be even complete destruction of this dorsum sella that we might see in grade 1 tumors. Now if you look at lateral extension of tumor, this is very, very important for us. This is called as Nosp-Steiner classification of paracellular tumor extension. So if you draw a line through the medial part of the cavernous ICA, and if the tumor is within this line, inside of this line, then it's called a grade 0. If the tumor is coming up to the midline going through the two internal carotids, then it's a grade 1, or this is called as the intercarotid line. Now if the tumor is coming up to the lateral margin of the internal carotids, this is called as the grade 2 tumors. So and if the tumor is beyond the lateral margin of the it is crossing this line, then it is actually a grade 3. That is, the intra and supracavernous internal carotid arteries are actually crossed, then it's a grade 3. And if it is completely encasing, going all the way up to the lateral wall of the cavernous sinus, then it happens to be a grade 4. So whenever you're assessing extension into the cavernous sinus, there are 6 questions that you want to ask yourself. First thing is whether or not there is an asymmetry of the cavernous sinus that you're seeing. So here you can see there is definitely an asymmetry of the cavernous sinus. Second question that you want to ask is there any lateral displacement of the lateral wall of the cavernous sinus if you compare it to the opposite side? Definitely there is a lateral displacement of this lateral wall. Third is if you see a displacement of the carotid artery. So that again tells you that you have to be careful because the carotid is outside of its more or less normal course. Fourth question is there more than 50% encerclage of the carotid? That makes your surgery a little more difficult and challenging because you have to peel the tumor off of the carotid. And fifth is there any increased amount of tissue interposition between the carotid artery and the lateral wall of the cavernous sinus? Because you will have to go into that area to clear it out, which makes your surgery a little more challenging. And sixth question is, do you see any obliteration of superior venous compartments which are coming and draining into the cavernous sinus? So these are the 6 questions that you want to sort of ask when you assess any patient who's got a cavernous sinus involvement. When you talk about infracellular tumor extension, we again have 3 grades. Grade 0 is there is no erosion of the floor of sella. Grade 1 is you see an focal bulging into the floor of the sella. Basically this is an indication or an indirect sign that the dura has been perforated. And grade 2 is when the tumor penetrates even beneath the sphenoid sinus. So this is basically a grade 1 infracellular tumor extension, what it looks like, because it is not crossing the floor of the sphenoid sinus. And when you talk about supracellular extension, again there are 5 grades. So grade 1 you will not see any bulging at all. Grade 0 you will not see any bulging at all. Grade 1 you will see that the adenoma bulges upwards into the the supracellular cistern, but it does not reach till the optic chiasm. Grade 2 it reaches the optic chiasm, but it does not displace it. Grade 3 is when it is displacing it and it is actually it stretches the chiasm to a certain degree. And grade 4 is when it causes foramen of Monro obstruction or obstructive hydrocephalus of one or both lateral ventricles can be caused because of this extension. So this is a classic example of a grade 3 supracellular extension. You can see very clearly that the optic chiasm has been displaced more so towards the right side as compared to the left side, and the carotid arteries are also actually quite encased in the tumor. Another common tumor that you see in this area is the craniopharyngioma. So you can see that this is a T1 scan because lateral ventricles are not highlighting, and there is increased intensity of the lesion, which goes to show that it is rich in cholesterol crystals. That is the reason why it highlights on a T1. You will pretty much see heterogeneous opacification on certain scans because of a mixture of calcification as well as cholesterol crystals in these sort of cases. So here you can see there is this is a T1 scan again. So there is heterogeneous opacification in this sort of cases of craniopharyngioma. Most of the time you will require actually a combination of what we have just learned. Like for example, this is a case that I had done where you can see that this is actually an adenoid cystic carcinoma, which was presenting in the clival area and with extension up to the base of skull. To the base of the brain actually, involving the sella as well, but there was no supracellular extension luckily. So both the ICAs are sort of encased, and the basilar was being touched by the tumor. And if you look at the coronal MRIs, you have the cavernous and the supracavernous segment of the ICA which are in close contact with tumor. That median nerve is quite thickened, and it was extending all the way to the foramen lacerum, which we had to drill out. There is a significant right side infratemporal fossa component as well. So this is how we sort of handled it. The IMAX was clipped. We wanted to do the most simple part of the surgery first. The pterygopalatine fossa component or infratemporal fossa component was first removed. Then we went to the left cavernous, peeled the tumor off the clivus from the sella. Patient presented with blindness in the right eye. Optic nerve was naked. Immediately after surgery, vision was restored. Median was drilled all the way up to horizontal ICA, basis sphenoid, clivus, everything was, the tumor was peeled off all of these areas and completely drilled out. Towards the end, I came to the cavernous ICA where the tumor had a firm attachment. So we created a plane of dissection between the tumor and the ICA. And we actually did sharp dissection to cut the tumor off of the ICA. And there you can see that pretty much no more tumor left. And this is what it looked like before and after. It becomes quite important to image these patients after surgery to sort of keep an eye on if at all you've left anything behind, especially a PET scan would help. This patient, it's been about a year now and patient is doing very well. So here you can see, like, even completely endoscopically, you can remove such tumors, which were quite a challenge before. And again, adenoid cystic, like I said before, there's no other option except for surgery in these cases. Last thing we want to discuss is actually Meckel's cave. Meckel's cave is basically, a dural recess in the posterior-middle portion of the middle cranial fossa. Basically, it acts as a conduit for the trigeminal nerve between the cavernous sinus and the prepontine system. So very, very important, especially I found this to be very important, more so in patients who are having mucormycosis, because most of the time this was through the infraorbital vessels and nerve used to go through foramen rotundum, and disease used to enter this area. Became one of my most favorite areas after mucormycosis actually. So here you will be able to study how to trace the Meckel's, the trigeminal nerve in the coming from the brainstem. You can see that as soon as it comes through the brainstem, this is actually the Meckel's cave. A, B, C is basically V1, V2, V3. And if you trace it, then you actually start to understand how they sort of come from posteriorly, anteriorly, just at the inferior part of the cavernous sinus, and they split into three nerves. The ophthalmic, the maxillary, and the mandibular division. Ophthalmic goes to the superior orbital fissure, maxillary goes to foramen rotundum, and mandibular goes to foramen ovale. One of the rare things that we found when we were imaging a patient is a persistent trigeminal artery, which is a congenital anomaly. The reason why it's important to identify this is because it is a communication between the basilar artery here, as you see, and the internal carotid artery. So any pathology here, and if you find something like this, becomes very important. I didn't know of it until recently that this is actually one of the most common persistent fetal carotid basilar anastomosis which can be seen. So this is quite close to the Meckel's cave. So if you're operating, this is also something that you need to know about. So one of the cool things that I actually started doing is consulting for a VR firm in the US. So what I use VR for now is basically to sort of do a preoperative planning where we pull up patient scans onto the metaverse. And once in the metaverse, basically sky's the limit. You can even perform something called as a virtual surgery, where you sort of decide your angle of attack, you decide where all the, how you want to tackle this tumor. You can even superimpose this image or the tumor imaging onto the patient who is lying on your operating table, and even perform a CT guided, or you can perform a guided biopsy on these patients without having to resort to CT scan guided biopsy anymore. And you decide what windowing you want to see, what sort of bony landmarks that are available for your perusal, what is the blood supply. You can even superimpose an angiogram onto this. So basically, this is what I'm using, technology and incorporating technology to provide a better or a holistic sort of healthcare solution in a complex situation such as skull-based surgery for these kind of patients. So this is one of the patients that I just showed you, the adenoid cystic carcinoma, which was involving both carotid areas. So I think the time has come for us to sort of incorporate these high-end technologies, or like I would say tools, to make our surgical skills and surgical planning a lot better. And when they are there at our disposal, why not use them? So thank you so much for giving me this opportunity once again.
Vivek, would you like to check whether there are any questions. While we're waiting, Gaurav, thank you so much.
We're not seeing any questions.
Okay, thank you so much for taking us into the web stream and showing us amazing stuff. Thank you.
Gaurav, that talk was so good, we didn't feel like stopping you at all. Maybe we want to take over the next few sessions as well.
No, sir. Actually, I have a whole lecture
super.
on 3D, the imaging. What we are now planning is basically surgery in the metaverse. I have a whole lecture on that. Maybe some other time, if I get the chance, I would love to talk about that. But yeah, for now, this would be good enough.
Absolutely, we would love to hear it. If Vivek is still there, Vivek is actually on holiday, so we can't hold him up for long. But if he's still there, then we can do his talk next, because I know he has to leave. If he's not there,
yes, sir. I'm around,
sure.
Sir.
Vivek, you're there for half an hour?
Yes, sir. I can hold on for half an hour. Okay.
So can I request the organizers to play Vivek's recorded video, please? Then we can do Vivek first. Before we do that, while the organizers setting them up, let me thank Dr. Renuka and Vivek for moderating the session. Renuka, please don't go away. We need your input for all the sessions. And please feel free to ask questions at any stage. I will be happy to introduce our next session moderator, who is Dr. Narayan Jaishankar. Narayan is, first of all, just a wonderful guy. I've known him for many, many years and spent lots of time with him. He's also doing fantastic skull-based work, both anterior and lateral. And I think a lot of his lateral skull-based work as well is quite amazing. He's at Nanavati Hospital in Mumbai. And Narayan, we may have a little problem in this session because I've just got a message from Satish saying that he's got a bit of an emergency and may not be able to do his talk. We are still trying to get him on if he can. If he can't, then I'll do his talk for him, the CSF talk. But maybe we can start with Vivek's talk if the organizers can help us with that.
Thank you, Nishin. And good morning to you, Dr. Brado, Vivek, everyone.
Hi, sir.
Hi, nice to see all of you. I think Dr. Renuka can do the honors of going ahead and inviting Vivek for his talk.
Thank you so much, Narayan. I'd just like to add one more thing to whatever Nishit said, is that you've got this excellent book now, which is a 360-degree surgical experience of the skull base. And I'd very much ask people to have a look at that book. May I now request Dr. Vivek, we've been eagerly waiting for your talk, and thank you so much for taking time out from your holiday to be here with us. So can we start the talk?
Yes, ma'am. Sure. A very good morning to you all. So I would be talking on two topics. The first half of my talk would be on modified endoscopic Lothrop, and subsequently I would be touching upon the endoscopic transcribriform approach. Now, coming to modified endoscopic Lothrop, it's also known as the draft 3 procedure.
Give me 1 minute, please. 1 minute.
The other names include the median drainage procedure or a
What happened, Renuka?
I just wanted to just say this, that we're not getting any questions. So whether we can tell the audience that if they have any questions, to please type them in the chat box. That's all.
Yes, yes. All questions are welcome. Please put your questions in and we'll convey it to the speakers. Thanks, Renuka.
Yes, thank you. Sorry for
let's restart the video, please.
A very good morning to you all. So I would be talking on two topics. The first half of my talk would be on modified endoscopic Lothrop, and subsequently I would be touching upon the endoscopic transcribriform approach. Now, coming to modified endoscopic Lothrop, it's also known as the draft 3 procedure. The other names include the median drainage procedure or a frontal drill out. Now, this is a modification of the original procedure described by Lothrop in 1914, which was external approach. This was later popularized by Draft and P.J. Wormold. Now, in this particular procedure, the interfrontal septum, the superior part of the nasal septum, the floor of the frontal sinus is removed all the way laterally till the orbit. Subsequently, what it exposes is the posterior table of the frontal sinus, and it helps us identify the level of the skull base at the anterior most extent. Now, surgically, one has to understand the relationship of the frontal sinus and the rhesus to the frontal process of the maxilla, the nasal septum, the middle turbinate, the lacrimal sac, as well as the olfactory fossa. So how the frontal drainage pathway and the frontal sinus is related to these structures holds the key to performing a successful Lothrop. The frontal beak actually forms the anterior wall of the frontal rhesus. So during this procedure, this part is drilled out. So anterior to the middle turbinate, the frontal process of the maxilla continues to cover the lacrimal sac. So again, when we go laterally, we expose the lacrimal sac or the skin above the level of the lacrimal sac. Similarly, the posterior limit would be identification of the first olfactory neuron. So a landmark here would be what is described as a frontal T, which in other words is the middle turbinate attaching to the skull base at the anterior end of the olfactory fossa. So once we identify this point, from here we can actually look out for the first olfactory neuron. And this forms the posterior limit of your dissection. Now, the surgical steps, although the initial description involved removal of the mucosa over the frontal process of the maxilla, both superiorly as well as lateral to the axil of the middle turbinate. Subsequently, there have been a lot of modifications because one of the problems with modified endoscopic Lothrop is the chance of scarring and restenosis. So subsequently, there has been attempts to preserve the mucosa and then reposition it back at the end of the surgery. So these are modifications that have come up with time. The second important concept during this procedure is creation of a septal window. Now this is important so that you get adequate binostril access so that you can work four-handed using a four-handed technique. Now, although frontal trifine is something that was popularized by P.J. Wormold, it is not something that is mandatory in order to perform a Lothrop procedure. Now, definitely in cases like revision cases where there is extensive scarring of the frontal rhesus, this probably may be helpful, or probably during the early stage of your career, a frontal trifine probably could help us in identifying the frontal drainage pathway. Now, bone removal. Now, this is probably the hallmark of a modified endoscopic Lothrop. It is predominantly all about extensive bone removal. So this bone removal, as we remove the bone of the frontal process of the maxilla, we need to stay anterior to the middle turbinate, and we need to keep drilling superiorly and lateral to the axilla. The lateral limit of dissection would be identification or exposure of the skin or the lacrimal sac. And as I had already mentioned, the frontal tree. So frontal T is basically the attachment of the middle turbinate to the skull base. Now, once you identify the anterior-most attachment. So once you identify this point, from here, we can actually trace the olfactory fiber, the first olfactory neuron, which is few millimeters behind it. And then lower the bone all the way flush to this first olfactory neuron. Now, just to give you an example, now this is a case, a revision case. This is a right nasal cavity. Now, this procedure has been was described initially for inflammatory pathologies, and subsequently now it has its role in expanded endonasal procedures. So now here this is a right nasal cavity, and I'm just outlining a flap over the lateral nasal wall extending onto the septum. So we just elevate and preserve this flap, and subsequently that entire mucosa is just pushed down, exposing the frontal process of the maxilla and all the way superiorly, and also the nasal septum to the midline. The same incision is carried on the left side as well. So the incision is started off from the nasal septum, extending it all the way laterally. And then this mucosal flap is pushed and preserved inferiorly. Now, once this is done, a septal window is created. So this septal window has to be made roughly in the size of around 2 into 3 centimeters, and it has to be anterior to the middle turbinate. An adequate septal window should provide access or should provide visualization of both the axilla and the frontal process of the maxilla. Subsequently, using a 400 technique, now you can see us drilling the frontal process of the maxilla. The key here would be to drill the bone all the way laterally. Now you have different approaches. That is, one technique that has been described is to go all the way laterally, identify the skin, and then come medially. Or you could probably even go from the midline, stay anterior to the attachment of the middle turbinate, drill the bone all the way superiorly and laterally, and enter the frontal sinus, and subsequently you could drill all the way laterally. So it could be something like a lateral to a medial approach, or it could be something like an inside out. From midline you could go all the way laterally. Now this is a right side, so we are drilling out all this bone. So this is basically the frontal beak. Now you can see we have already opened into the frontal sinus, but that is a drainage pathway behind. Now once we identify this, subsequently drill open, drill it wide with adequate irrigation, and we should be able to get access into the frontal. So that is actually the view of the frontal sinus. Now the same procedure would be repeated on the opposite side. So same way, keep drilling anteriorly, keep drilling superiorly, keep drilling laterally. So that should be the direction in which you use your drills. And now we have a view of both the frontal sinuses, that is the right and the left, and subsequently drill across from one side to the other, joining both the frontal sinuses. So we are also taking part of the interfrontal septum down here. Now you would require skull-based drills, you would require endonasal drills for carrying out this. There are specially designed angled burrs which probably are useful when performing a lothrop. So there has been a lot of irrigation to reduce the heat generated. So once we keep drilling all the way, now this is the angled burr that is used for the last part. So to finally polish the anterior most part, which is generally difficult to reach with a straight burr. Now this gives us a view of the frontal, so we can see the discharge there. This is a case which was operated multiple times, but this is an inflammatory pathology. Now this is the identification of the first olfactory neuron. So roughly where the middle turbinate attaches to the skull base, once we reflect the mucosa posteriorly, we would be able to identify the olfactory neuron. So once we identify the first olfactory neuron, we know that we can actually drill this bone all the way flush to the olfactory neuron. So this gives us a maximum anterior-posterior dimensions. So subsequently drilling out all these. Now we have used this approach successfully for dealing with even inverted papillomas with attachment or extension into the frontal sinus. So polish out the interfrontal septum and get the maximum possible opening for the frontal sinus. So this is how the cavity would look, and this is a view with a 0-degree scope. So you can identify the olfactory neuron, and now this is where we reposition the flaps back. So at least we could cover some part of the raw bone with mucosal flaps. Now another indication probably would be dealing with CSF leaks. Now the same kind of an approach has been done here. This is a post-traumatic leak from the posterior table, multiple fractures. So you can actually have a look at the olfactory neuron. So you're identifying the posterior limit. And here there are a couple of defects. So this is one defect here. The bone is being removed. And here subsequently, in the left frontal sinus posterior table, there is a bony impingement. And this is basically glyosed brain tissue which is herniating through that defect. And we used a piece of cartilage to cover that defect, push the glyosed brain tissue back in, and subsequently did a multi-lead closure with fat. So this is one of the defects being plugged. Now there are modifications of Lothrop like semi, hemi, mini Lothrops where you don't go to the extent of doing a complete Lothrop, but then that is beyond the scope of this talk. And this is again a fascia onlay graft, and then finally we bring in the nasoseptal flap, and we are able to cover the defect and at the same time maintain the patency of the frontal sinuses. So now modified endoscopic Lothrop is also done as a step in endoscopic transcribiform approach. So coming to endoscopic transcribiform approach, the exposure extends from the crista galli to the planum sphenoidal, across the roof of the ethmoid sinus to the orbital roof. So you get such a wide exposure. Now this approach is primarily described for closure of CSF leaks from the cribriform area, for dealing with encephalocele, meningocele, for endoscopic craniofacial resection of sinonasal malignancies invading the skull base. And it also has been an approach for benign intracranial tumors like olfactory schwannomas or olfactory groove meningiomas. Now, what are the boundaries of this approach? So anteriorly, the boundary would be the crista galli along with the anatomical differentiation would be the crista galli along with the posterior table of the frontal sinus. The posterior limit would be your planum sphenoidal, whereas laterally on either sides, you have the lamina papricea. And while dealing with the transcribiform approach, one of the key points would be to deal with the vessels that run along the fovea. Now we have the anterior ethmoidal artery as well as the posterior ethmoidal artery running across the skull base. When we talk about the surgical steps, now although this approach is referred to as a transcribiform, now ideally speaking, a transcribiform approach should be confined or should be limited to between the middle turbinate and the nasal septum. However, in most of the cases, what we end up doing is an extended transcribiform or a transcribiform transethmoidal approach. So invariably, along with the cribriform, the ethmoidal roof is also exposed, drilled, and the dura exposed, and subsequently the approach is carried out. So it can be a uninostril approach, a unilateral approach, or it can be a bilateral approach. So depending on the type of approach, if it's uninostril or binostril, we decide on doing a bilateral or a unilateral ethmoidectomy. Again, coming to frontal sinusotomy, so I had already mentioned that it is an integral step. Modified endoscopic Lothrop is one of the steps that we do in a transcribiform approach. Now the extent and laterality varies according to the extent of the disease and the exposure. So if you have a skull base pathology which is lying anterior to the anterior ethmoidal artery, obviously we would have to do a Lothrop procedure so as to prevent stenosis or closure or narrowing of the frontal sinus. However, if the tumor is placed way posteriorly, we may not require a Lothrop. So it depends on the extent of the pathology. Now again, it involves removal of the cribriform plate bilaterally, again with removal of the fovea in most of the cases where it becomes a transcribiform ethmoidal approach. The crista galli has to be dealt with, it has to be drilled and removed. And one needs to be careful when dealing with the crista galli because it has attachment to the falx cerebri. And again, inadvertently using drills on the crista galli could sometimes lead to a vascular injury, especially from the superior sagittal sinus. Now, just to show you a few examples, now the simplest of the approaches that we generally see would be, now in this particular case, this is the left nasal cavity, you have a meningocele. So if you see the meningocele, this is medial to the middle turbinate and also there is extension into the ethmoidal sinus. Unfortunately, I couldn't put up the scans here. So I'm just truncating the middle turbinate. So there is a pneumatized middle turbinate with the meningocele herniating into the middle turbinate as well as the ethmoidal sinus. So once we truncate the middle turbinate, reflect the middle turbinate downwards. Now this is the bulla that is being opened up, and on opening up the ethmoidal cavity, I'm able to appreciate the entire wall of the meningocele here. So you can see the meningocele occupying the ethmoidal sinus. So subsequently, this wall is elevated, and then the walls are debrided away. So you can also see the thinned out portion of the middle turbinate posteriorly. Now this whole, so that is a defect actually. You can see the entire wall of the meningocele. Now this is debrided away to define the defect, the bony defect. So what we get to see here is, this is the fovea, this is the defect here, this is the anterior ethmoidal artery. So the defect is actually in the cribriform, the medial cribriform. Again, through the medial cribriform, it has extended to the lateral cribriform into the ethmoidal sinus. Subsequently, the entire area surrounding the defect is the frontal sinus opening here, and a nasoseptal flap is harvested, and then we do a multi-layer closure. The first layer with Surgicel. Subsequently, we use a layer of fat on top of it, a layer of fascia, and finally a nasoseptal flap comes into position. So this is how we have repaired a cribriform, a large meningocele in the cribriform area. Now, another example. Now, this is actually a case of a olfactory groove meningioma. Now, the patient already had anosmia. And this was a progressively enlarging tumor because she also had an acoustic neuroma. So we did a staged procedure, managed the acoustic first through a translab, and subsequently on serial imaging, this tumor was seen to grow. And because she had anosmia, we decided to go for a transcribiform approach. So for benign tumors like these, generally transcribiform is not the first line if olfaction is intact. Now, if olfaction is already gone, then probably we are justified. Now here we have done a bilateral ethmoidal exposure, the anterior ethmoidal artery, the entire fovea is delineated. That is a frontal sinus on the left side. Similarly, on the right side, the entire exposure of the skull base. So all the way from the frontal, all the way posteriorly, we have delineated the skull base. Now, subsequently, what we do is, in this particular case, because the pathology is way behind the area of the anterior ethmoidal artery, there was not significant anterior extension. So we decided not to do a Lothrop. Now we are drilling out the base of the skull. We would be delineating, thinning out the base of the skull, and then identifying and cauterizing the vessels along the skull base. So that was anterior ethmoidal artery, which was cauterized and truncated. Now this is one of the advantages of the endoscopic transcribiform approach, especially in cases of olfactory neuroblastomas. You can actually devascularize the tumor early. So here, now we are drilling all across. So this is what I was talking about. This is what I was referring to earlier, the anatomical anterior extension. So the fovea on either sides, the bone along the posterior table with the junction of the crista galli. Similarly, the area of the planum sphenoidal posteriorly. So all these areas are drilled out all the way around, and then subsequently the dura is incised. Now, once the dura is incised, there will be egress of CSF, and then using special instruments, the dural incisions are extended, again adherent to the principles of microsurgical resection. This is on the left side, and now what we are reflecting is basically the olfactory tract. And you can actually see the blood vessels in relationship to the olfactory tracts. So one has to adhere to the principles of microsurgical dissection, and now the tumor comes into view. So at this point, I would dissect the vessel away from the tumor. So you can see that is the vessel being mobilized away from the tumor. Now try to preserve the arachnoid planes and dissect around it. So gently elevating the vessel. Similarly, a cut is made on the right side, that is a dura that is reflected. And we do send few pieces for biopsy initially. And subsequently, we start our dissection, resecting the dura all around to get a complete view of the tumor. So these, as I had mentioned here, we have not done a Lothrop. So this is a modification because the tumor has not extended all the way anteriorly. And at this point now, there is a crista galli that is being dissected off. So one has to be careful that is dissected all around and then mobilized. And the last bit of dural attachments are being trimmed away. And subsequently, we develop planes all around the tumor. There is a plane between the gyrus recti and the tumor. And this is actually the fox cerebri, that is a fold of dura mater separating both the hemispheres. And with the help of patties, we develop planes by dissecting the arachnoid all around the tumor. And once the dissection process is completed, we are able to deliver out the tumor in toto. So after dissecting all around, now that is the entire tumor that is being delivered out. And then subsequently, this is a view of the cavity, complete removal, and finally a closure. So here now we resort to a inlay. There is a layer of fat, another layer of fascia, and finally the flap comes into position. Another case, now this is a case of a unilateral nasal tumor. This is basically an olfactory neuroblastoma. The patient already had a biopsy elsewhere. Now there's a left nasal cavity, so you can actually see the tumor remnants here. The middle turbinate is missing. This is a olfactory fiber that is coming out here. Now this patient did not have a frontal sinus, so which actually makes our job much more easier. And this is a septum that is in view. Now here the idea was to get a complete negative margin on dissection. So the same way we proceed with the exposure. However, there is no involvement of the opposite side. So after complete ethmoidectomy, what we have done is we have drilled out the entire fovea here. So we are drilling out the entire ethmoidal roof, thinning it out. We have already cauterized the blood vessels. Now the same way we carry out a dural incision. Once a dural incision is carried out, you can actually see the planes being elevated all around. And that is a view of the olfactory bulb. And subsequently, using a single nostril, a uni-nostril, a four-handed technique, so that is olfactory bulb that comes into view. Using a four-handed technique, uni-nostril approach, we are delivering the entire tumor along with the dura. So there is a bulb which is dissected with a specimen. As you go posteriorly, you'll be able to see the olfactory tract. So we do get all these margins, send them for frozen section, and make sure that we get negative margins all around. Finally, what we do is, so that is the last bit for our posterior margin. And subsequently, there is some hyperosteotic bone surrounding this area, which is drilled away for ensuring complete tumor clearance. And then finally, again, a multi-red. So that is again the branches of the frontopolar artery that you can see, and the gyrus recti. So this is a unilateral exposure. And finally, again, a multi-layered closure, obviously with inlay fascia, Surgicel, and a Haddad. And subsequently, These are the scans which show the flap in position and the patient free of tumor almost 5 years down the lane. So basically, when you talk about these expanded endonasal approaches, I mean, the creation of surgical corridor minimizes the need for neural and vascular manipulation. And in most of the cases, we require bilateral exposure. In selected cases, like I've shown, you can resort to a unilateral exposure. And we prefer the four-handed technique. Now it's a surgeon's choice. It's a team that decides what works best for them. A septictomy aids cross-cut access. Principles of microsurgical dissection, selective coagulation of vessels, and similarly in case of malignancies, management of the resection margins with optimal visual control. This is what endoscope actually offers. You have to have the whole array of technology by your side, starting from drills to debriders to navigation system, everything, because these are complex procedures and definitely you are bound to land up with complications if you are not well equipped. Lastly, a word on team approach. I would say that working as a team actually improves the operative efficacy. It also improves the visualization. You are better when it comes to decision making. And similarly, you are better off when you land up with a complication. So I think the way forward would be a team approach. Again, a word on shorter surgery time. I think this is not your should not be your first concern, because usually when you start operating as a team, initially you take longer periods of time, and subsequently with experience, you may be fast. Shorter duration of stay, provided you don't have complications. One of the most common complications that we encounter with these endoscopic approaches is persistent CSF leaks. So plan your surgery, plan your reconstruction. That should be the key. So again, as I had already mentioned, the incidence of decreased brain parenchymal injury and minimal neurovascular manipulation. These are probably some things which actually goes in favor of an expanded endonasal approach. So I think I've touched upon the modified endoscopic Lothrop as well as an endoscopic transcribiform approach in detail. And thank you so much for your patient listening.
Thank you, Vivek. That was an amazing talk. Glad you could still hold on. Narayan.
Yeah, hi, Vivek. First of all, compliments to you. I think very elegant talk, very elegant dissection. And I have seen some of your videos that you have posted, and I must say, excellent work. Keep it up.
Thank you, sir. Thank you so much.
So just for the benefit of the delegates, I'll ask you just one or two questions, which
Sure.
you was throw light on for the delegates. So now there's a lot of talk on very lateral modified Lothrop. Generally, you get a very wide exposure of your frontal, but some diseases which require you to go way far lateral, and you can't really get access with the endoscopic Lothrop. What would you do in those cases?
So again, sir, I think it would depend on the type of pathology that you're dealing with. Yeah. Now, for example, when you talk about a pathology like mucocele, which extends far laterally, obviously the options that you have are sometimes it can be multi-compartmental. So in those kind of situations, now what probably gives you added exposure would be adding on something like a orbital transposition, deroofing the lamina, pushing the orbital periosteum. So that gives you slightly more access laterally. Now, however, now if you are talking about, for example, now an inverted papilloma, which is attached far laterally in the frontal sinus, in those kind of situations, I would probably think of putting up an additional port, an external port in the brow area, and probably make a couple of openings down there, introduce the endoscope, have a visualization of the attachment, the site of attachment, and then try clearing it off from there. Or even again, when you talk about some leaks from the posterior table of the frontal sinus, which are fairly high up on the posterior table, again, trying to cover that defect with a flap from below may be technically difficult, in the sense you may not be able to push the flap all the way up. So again, I would probably prefer an external port. So these are add-ons, like, things that probably in situations, as you rightly said, one of the limitations of Lothrop probably is when you have a far laterally pneumatized frontal sinus or pathology which is located beyond the mid-pupillary line. So that obviously remains a challenge. And I think these are things that you could probably resort to in those situations.
Thank you. I think perfectly
you could consider an you could consider an orbital transposition also.
Yeah. Yeah. Yeah.
Yeah. So that's also called the medial and superior orbital decompression. That's exactly what.
Yeah. So either, or if you're doing it endoscopically, either a transposition or an external port. Correct. Yeah. One of the two.
Perfect. And just one last question, again, for the benefit of everyone. You showed fantastic videos, but during your learning curve, anything that you found difficult or any complications that you would want to share with anyone?
So I think complications, I mean, obviously, you're talking with reference to Lothrop and...
Yes, with reference to Lothrop, any difficult situation or any complication or technical difficulty you would want to share with the audience?
The technical difficulties, as I had already mentioned, when you start working as a team, right? Obviously, there is a learning curve, the time that you take to get adjusted to each other. That is always there. And if you don't have a constant partner, I mean, because I work in a medical college, so we have people changing, we have residents coming, going. So it's, every time it keeps changing. So to train someone is always a challenge. And obviously, when visualization is not good, that is when you generally land up with complications. So that is part and parcel. So I think the most important aspect is to be aware of complications and to know how to deal with a complication when you land up with it, rather than being totally unaware of complications and not knowing what to do. So before you venture into these features, I think you have to be well versed with, I think Dr. Jankiram had already mentioned, talk about the different levels. So basically, when you're talking about an endonasal craniectomy, one of the important challenges would be to repair a CSF leak. So unless and until you're kind of well or confident dealing with a CSF leak at almost all these locations, do not venture into a endoscopic expanded endonasal. Vascular injury is something that we have to keep in mind. So I think, again, the use of bipolar cauteries, you should have the right tools at the right place, because when you don't have your conventional bipolars are technically difficult to use in the in transnasal approaches. So you have to have endoscopic bipolars. Obviously, we have had orbital bleeds. Yes, we have had CSF leaks, which we had to go back. But then these are, I would say that these were probably during our early stage. Yes, but then over a period of time, the incidence of complications do come down.
Thank you very much.
I have one question, Vivek.
Yes, ma'am.
Besides the Haddad, have you needed to use any other flaps for reconstruction?
Ma'am, reconstruction in the sense, in what context, ma'am?
I'm saying when you're closing the defect in the brain base skull, you show most of your repairs with the nasoseptal flap. Have you needed to use lateral flaps or an anterior base flap?
Ma'am, you're talking about the anterior ethmoid artery base flap?
Yes.
Yeah, no, no, I have not used that. I mean, I have colleagues who have tried that, but then I find it a technically very challenging thing to do, to raise a anterior ethmoid artery base flap. We have done lateral flaps, but that again too in revision cases when we have not had the option of a nasoseptal flap. I mean, otherwise, as far as nasoseptal flaps are available, I really haven't thought of any other options.
You prefer that. Okay. Yeah. Thank you.
Thank you, ma'am.
Excellent presentation.
Thank you.
So Nishit, you want to talk about Satish's presentation, or how do you go about it?
Yeah, I think I'll have to, because we still haven't got any news from Satish. So if you can say a few words about Satish, and then I will do a small talk.
So I think I can see Janki also. Hi, Janki. Okay. So anyway, to introduce Satish, I think there's nothing much that we need to say. Everyone knows Satish, and Satish is obviously one of the legends of India today. And I think we all get to learn a lot from him, from his technique. I'm sure he's got his own views, and that's primarily because of his huge workload, as well as the fact that he reads so much. And it's always nice to chew on his brain as well and try to figure out what he thinks about a particular situation. So I think Satish requires no introduction. Nishit, to save time, we can just go about and carry on with this part.
Okay. So we're going to miss Satish for sure, but if he can log in later, maybe we can ask him some questions. And I'll try and do a very quick talk on CSF and hopefully try and put some of the views that Satish would have done for us. Thanks, Vivek. We'll let you go now. Right. So for me, of course, I practice in Mumbai, primarily at the Bombay Hospital. Now, I'm going to skip the etiology because everyone's aware of all the causative factors. Diagnosis, of course, often is just based purely on history and the fact that you have a unilateral watery discharge, which increases on bending down. You can subject this fluid to a beta-2 transferrin or a beta trace examination, which is quite diagnostic. You can also do a sodium fluorescein endoscopy. But finally, of course, you want to do radiology because your CT scan is going to show you the bone defect. Now, initially, we were sort of pretty used to having CT cisterno as the gold standard because one, it confirmed without doubt that there is a CSF leak, and two, it showed you the site of leak. And today, I think it's been in a majority of cases replaced by a combination of plain CT with an MR2 weighted sequence so that you avoid the lumbar puncture and the need for this thing. For the need for sorry, I have a little disturbance at my end. You avoid the need for a lumbar puncture and the need to inject a dye. Now, the areas where I still feel a CT cisterno is useful is especially in multiple breaks or like bad trauma cases where you might see 2-3 areas of breaks on a CT, but maybe only one is leaking. And in those situations, a cisterno is sort of useful because you don't need to then address all of them. Brain scans, very important, especially in spontaneous leaks, to ensure you don't have any other SOL causing the increase in pressure. Right, so just very quickly looking at the advantages of plain CT against cisterno, MR, and a radionuclide. Each one has the advantage, and ideally we want to combine CT with MR. In some cases, we'll do a cisterno. Radionuclide was good because it sort of gave you a 24-hour delay in picking up leaks. So intermittent leaks, patients who didn't have sort of a nice leak to pick up on a cisterno or an MR cisterno might do well, but by and large, it didn't gain popularity. Okay, so I'm going to go very quickly with this. Venography has also been suggested in certain places where you find that the transverse sinus was occluded in spontaneous leaks. Now, there is a bit of controversy here because you weren't sure whether it's the cause or the effect. So is it the occluded transverse sinus causing the raise in pressure, which then caused the leak? Or is it that there is an increase in pressure and that has caused the occlusion? So we've seen some patients who after the leak, actually the sinuses have opened up. So again, it's one of those things you can do, but we're not sure how useful it is. Right, so again, a situation where you might expect to have some amount of brain, like a meningoencephalocele, you must have a MRI because you want to see how much of it is meningo, how much is encephalo, and if there are any vital structures accompanying this into the defect so that you can truncate it at the attachment or you need to spare something. Just some examples of a CT cisterno showing the dye coming into the nose. Again, similar for the sphenoid. So for traumatic CSFs, generally the management is conservative and you don't need to do much. We would think of surgery in those situations when there's an increase in the CSF. So it's not reducing over the next few days of post-trauma despite conservative, or there are large breaks which you don't feel will respond to conservative treatment anyway. Then you would go in a lot quicker. For spontaneous CSF leaks, on the other hand, the treatment is always surgery. There is no point in trying diuretics or lumbar punctures, because this is something that has happened over time because of a raised pressure and with a defect in the bone. So we always do surgery. So we go into imaging, confirm CSF, and then we plan surgery. Material for repair, earlier days, we used to use muscle a lot, but if you heard Dr. Kirtane's lecture earlier, and I must say that Dr. Kirtane was a pioneer as far as optic nerve and CSF leak endoscopic repairs were concerned. And really, we owe a lot to him for the present status of endoscopy being advanced beyond just sinus surgery. That muscle would sort of become a fibrinous reticulum. It would sort of be liquefied, whereas fat remains fat. And as many of us know, is often difficult to lose. So today we prefer fat. We would combine it with fascia. And prior to 2007, the days of the Haddad flap, we would do a multi-layer repair using fat, fascia, and sometimes cartilage or bone. Post-7, we've now switched to using more and more of pedicle flaps, almost always with the addition of tissue glue, which by itself is not a repair material. It is only an additional insurance to try and get your original repair to stick in place. We also tend to use a bit of Dura substitutes as well for skull base especially. Vivek has made this job a little easier because he's shown you a CSF Lothrops and CSF repairs using a Lothrop for the frontal sinus. I'm going to skip that. Supraorbital is far easier because you have a limited sort of cavity that you can operate in. You don't have a very big frontal sinus pneumatized where you have to remove all the mucosa. So it's a lot easier to get into a narrower cavity. Of course, you need to do a good ethmoidectomy. You may need to do a little bit of an orbital transposition if you find it difficult. Angled instruments, scopes, and drills are again required to get into that narrow niche so that you have all the mucosa out. It's not just taking the encephalocele. So you see the frontal sinus opened widely above that, and that is essential as well because you don't want to close it when you do a repair of the lower part. You see the anterior ethmoid artery below you, and between the frontal and the anterior ethmoid is the supraorbital. So as you remove more and more of that encephalocele, you see the bony defect. And once you have a good identification, you want to then get inside and clear all the mucosa before you want to obliterate and close this space. So you can see also I had to do a little bit of drilling of that orbit so that I could ensure that I could go inside, see that last bit of that recess and clear the mucosa. Once that was done, then of course we could put in a small fat plug, we can put in a fascia and then buttress that fascia with a little more fat. You want to be careful that you're not blocking the frontal sinus when you put this repair in. And therefore your exposure has to be wide. Okay, I'm sorry, I'm going to go a little quick because I don't want to eat into Narayan's time. And just in case we get Satish back, we can ask him to show us some examples. Another very common example, and I want to show you this, is the medial cribriform spontaneous defect. The typical area is the junction of the middle and the superior turbinate, and you'll often see a small meningocele like that. What I would do to repair this is just a medial approach without removing the turbinate, provided, of course, that is just a small defect in the medial cribriform, unlike the one that Vivek showed you, which sort of transgressed all the way to the ethmoid as well. So we would open up the sphenoid a little bit just to ensure that no material sort of slipped down and blocked that sphenoid sinus. We would lateralize the middle turbinate completely, coagulate that meningocele, mark the area around it that you need to debride, that you need to freshen. And then you take a curette and freshen the mucosa around that area. If you have a CSF leak at the end of that cautery, we would fat plug it. If there is no CSF leak, then I don't want to increase the defect in this cribriform area. So we would then, in that case, just do an overlay fascia repair. Here, because we did have a leak, we put in a small fat plug. And on top of that fat plug, we put in a fascia. Once that's done, if the defect is a little anterior, you can actually bring the turbinate back and suture it to the septum, and you don't need to pack at all. And these patients can be mobilized quite quickly. So this is the way to do a medial cribriform. Now, we'll go a little quicker. Lateral cribriform, you've already seen with Vivek. You need to do, of course, an ethmoidectomy, identify the defect, and only then can you repair it. So we'll skip this. I'm going to skip this as well. Posterior ethmoid, this was a rather large defect. I remember this well because it was post-traumatic large defect. It was one of those times that Janki was visiting us in Mumbai, and he happened to be in the theater when we were doing this. So ethmoidectomy done, defect identified, and because it's a large defect, planum and posterior ethmoid, we decided to use a flap. So I'm just going to go a little quicker here. So here you're at the orbitex area. This is the defect in that planum ethmoid junction. And again, in all the CSF repairs, there's two very important things. Define the bone where there is a defect. You have to be at that bony defect. And two, you have to clear the mucosa around it so that your repair material can adhere, can stick. If you don't do that, the repair is not likely to succeed. So define your defect well and clear the area around it completely of mucosa. So you can see that we are putting the flap laterally onto the planum and the posterior ethmoid, and we actually managed to do it with keeping the middle turbinate intact, which is not necessary, of course. You could have taken it out as well. Iatrogenic CSF leaks usually happen when there's a lot of blood and the vision is not good. So you're a little lost. It can happen in revision cases, especially when the prior surgeon has not put in good notes and you don't know for sure if there was an exposure of dura in the first surgery. Of course, in those cases also the anatomy may not be normal. So what do you do when you have a CSF leak? This is one of those cases. The debrider burr had just been introduced to India, and I was using it to sort of polish off just to see how it felt on the middle turbinate. It slipped, and you saw it was an aggressive burr and created a small hole in the cribriform. So you want to, at this point, when you've seen an iatrogenic CSF leak, you want to, one, establish that, yes, it's a CSF leak. Two, you don't want to panic. Three, you want to finish the rest of your surgery, clear the pathology. And four, get good hemostasis so that you have now, again, pinpointed the point of defect, clear the area around it. Once you've done these things, then you repair it like a normal CSF leak. It's always a good idea to find and repair an iatrogenic leak at the time of the primary surgery. To try and hide it and hope that it sort of heals in the post-op period may work okay, a traumatic leak, but if it doesn't, you're in trouble because you've then sometimes not even informed the patient. He has a leak 4 or 5 days later. You have to go back, and now all the tissue is edematous and it's difficult to find the site of leak. So in this case, we have small plug of subacute tissue from the inferior turbinate area. And then we use the mucoperiosteum of the middle turbinate concha bullosa, which I had removed as an intact piece. And so I didn't need an extra additional incision on the thigh or the stomach. Okay. So, and then of course, be honest. So here's where it's important that you take a good informed consent for every patient of FESS. Then you're sort of more mentally relaxed, and post-op, always inform the patient that this has happened, I've taken precautions, I've done what is necessary, and mention it in your operation notes. Right. So I'm just going to skip through all these, and we'll go to one last thing of, we'll do a sphenoid lateral wall, because these are interesting, and especially after Gaurav's very informative and impressive talk on anatomy with the pterygopalatine, it's sort of a good refresher. You have a defect in the right lateral recess, very, very lateral, as you can see. This here is the V2, so it's lateral to the V2. And all these so-called Sternberg leak canals are actually lateral recess leaks, because an actual definition Sternberg canal leak is medial. So we just call them lateral canal or lateral recess leaks. Now, what we would do is, of course, to do an ethmoidectomy here, because you want to communicate the sphenoid with the ethmoid, you have to amputate that middle turbinate so that you can join the two. It's nice to do it bi-nostril, though you can do it uninostril. So you can take incisions on the septum. You can either take a flap, but sometimes the flaps are not long enough to reach, because it must come from the opposite side. On the same side, as you can see, we are opening up the pterygopalatine and ligating or cauterizing the internal maxillary, so that you can do a trans-pterygoid or a trans-maxillary approach. So the flap on the same side has no vasculature. The flap on the opposite side must reach all the way across. If it's well pneumatized, that's tough. So what we sometimes choose to do is to take a free mucoperiosteum on the same side where you lost the vasculature. And on the opposite side, we just do a rescue flap, so that we have the access for a binostril and also the option to do a Haddad flap should it be required. So I'll go quicker on this part. So as you can see, we've just taken a free mucoperiosteum flap from the same side. We've opened up the maxilla, we've cauterized the internal maxillary, we've opened up the sphenoid. On the opposite side, we're just doing a rescue flap, and we'll do a posterior septectomy so that we can do a binostril or a forehand surgery. The rostrum is then removed, and the sphenoid is well exposed both sides, so that you have clear anatomy here of the sella and the clivus. Now you already see that with this wide opening of the sphenoid, you still can't see the lateral recess. You still can't see the encephalocele. You remember the earlier principle, unless you define the bony defect, don't attempt the repair. So we need to remove this entire posterior wall of the maxilla along with a little bit of the pterygoid. So we need to start drilling and removing this bone. Only then can we see the recess behind it. So that's what we are going to do, is to remove it. Inferiorly from the pterygopalatine will come the descending palatine. And you can sometimes save it, because just behind it are the greater and lesser palatine nerves. And sometimes you need to sacrifice it if you don't have enough exposure. So once a lot of that bone is removed, you can then see inferiorly a little bit of that lateral recess and an incomplete septation, just the start of the meningoencephalo. We start drilling the pterygosphenoid junction. The first structure you will see is the palatovaginal canal and the artery that goes into it. And as soon as you cut that, you will then laterally see the Vidian nerve. So that then is, now we've drilled below that. So we're just going to cauterize the artery of the palatovaginal and cut it. And because we've already removed bone under and lateral to it, you will see the Vidian nerve coming into view. Now, the Vidian nerve leads you straight towards the carotid, right, at the junction of the petrous and the clivus. And the lateral recess is behind this pterygoid. So you can see the probe, we're just checking. So once we drill that whole bone under it, and I'll go a little quicker here, you can see that we're opening into the lateral recess. Yeah. Okay. So this is then the upper limit, of course, Vidian nerve, you can see now we've drilled below it, above it. And this Vidian nerve will have to be sacrificed for us to get easy instrumentation. So we'll sacrifice it. Your upper limit is V2, and you want to be careful not to damage that, so that you don't have, that's V2 and foramen rotundum. So that's your upper limit. And you want to punch just till there, but not damage the nerve there. So once that's done, you have no view of the entire meningoencephalon with a 0-degree scope. It's a head-on view, which really makes surgery a lot easier as compared to using a 45, 70-degree scope with angled instruments, which is a possibility, which is what we used to do in the old days. And if you don't have the right instruments. So find the defect, clear the mucosa around it, plug it with a cartilage piece. On top of it, we use that mucoperiosteum that we got from the septum. And it's a nice, thick, robust piece of material. So it works quite well. We didn't feel the need to put, or we didn't feel the length of the flap will be long enough to get across. A little bit of fat on top, tissue glue, and a pack for 4 to 5 days. Right, so I think we won't do too much more here. There are cases where you have, cases like this. Now this, as you can see, is not traumatic, is not spontaneous. This is a congenital defect. You can see the walls of the two sphenoids are well formed, so right and left sphenoid, and the whole planum is sort of down. Now, the problem with this kind of leak is that it's not just an encephalocele. You have vital structures. You have the optic nerves being dragged down. You have the floor of the third ventricle with the hypothalamus dragged down. So when you have this sort of situation, there's very little you can do either from up or from down. And all we could do is sort of layer it, just scratch the mucosa off it and layer it with a fascia. And hope that it did well. This was a 32-year-old lady actually who had married, had a child, and then had symptoms of DI because of the drag on the stalk. And that's how she got scanned and discovered with this. So these are, of course, extremely difficult cases. Okay, so I don't want to take Narayan's time away, but just in the end, fluorescein, we don't use it routinely. But in cases where we don't have certainty of where the leak is, or you have sometimes more than one defect, fluorescein works very well. So this was a young boy we had operated earlier, 4 years before, still had meningitis. All cisternos done, refused to show any kind of leak. A plain diagnostic refused to show any leak. So we went in with fluorescein. Now you can see that we are seeing sort of diffuse fluorescein. So we need to keep localizing. We need to keep focalizing on where it could have come from. And we start taking all the mucosa off with a coblator. And I must thank Janki Ram here for giving me the confidence and the familiarity to use the coblator in the nose. We did it together at a workshop for the first time. And so we sort of traced it and found that it was through the pterygoid at the lower extreme point of where the original defect was. So one, we could of course confirm that yes, there was a CSF leak causing the meningitis. And two, we could trace it right to its point where it was sort of coming out, narrow the defect down, and then plug it with fat and fascia. So that's the final repair. Post-op, you tell all these patients to be careful with straining especially, and you want to follow them up for checking. Just an acknowledgement to Dr. Kirtane, from whom I have learned all my endoscopic surgery, both basic and advanced. And really, I think all of us in India in some way or the other have benefited from his teaching. Again, thank you very much. I'm sorry I had to take over at very short notice this talk, and we would have loved to hear Satish Jain talk on it. But I hope I've been able to give you some kind of impression about CSF leaks.
Thanks a lot, Nishit, for your lovely talk. I think there's so much in CSF leak that we can just keep talking about. But I think it was a very nice lecture which covered different sites of leak and the basic principles of how to cover the leak. And I think that's what's the message was very well taken, and you drove home the points pretty well. So thank you for that. Dr. Renuka, are there any questions that we want to ask?
I'd just like to say,
sorry, it was.
At what point would you consider having a pericranial flap?
A pericranial flap you would do more in skull-based surgeries when you have lost the possibility of having nasal local nasal pedicle flaps, be it the Hadar flap or a lateral nasal wall. The couple of situations we've used it are in revision cases of aesthesio, where we've not had any septum, and we've had some tumor also going intracranial. So we've had access both from below and from above. And then the pericranial flap works beautifully. I'm not sure if we have time to show you that, but maybe later in the session, if you have time, I can show you a video of a pericranial flap. But it's like a reserve flap.
I think you have a talk on reconstruction, if I'm not mistaken, right?
No, I think that it was going to be covered as part of this and with your talk on transphenoid.
Okay.
So if you have time, we'll do it. But we are trying to concentrate more because hopefully many people are listening, and to try and keep it more basic and not go too high for an understanding. But of course, we are happy to have questions, and anyone is interested, we can also communicate with them at a personal level later.
I think your reconstruction talk, as I always tell you, is wonderful. So, you know, all these flaps which you have described so well, maybe if there is time, you can talk about it at the end, whenever there is time. I mean, you can take a call on that. But
okay.
Thank you very much for a lovely talk as usual. And Nishit, you always call Dr. Kirtane the father of endoscopic surgery. But I think you were into endoscopy well before any one of us probably. And I think, you know, you also deserve great credit for actually pushing pituitary surgery and, you know, taking it to the level that it is today. And I think personally, I mean, I know a lot of people would vouch for that, but personally, I think I have learned a lot from you. You're a very dear friend of mine and you know that, but you know, even I tell you that there's a lot to learn from you every day. Thank you.
Thank you, Narayan. And now it's Dr. Narayan himself who is going to talk to us on transphenoid surgery.
So again, thanks a lot for giving me an opportunity here. And I think my job is made very simple by all the talks that have already taken place thus far. I think you've seen some really elegant talks and elegant surgeries. And I think I've got the simplest job, which is transphenoidal surgery, meant basically for as the first level of surgeries that, you know, people go with. You may subsequently hear further talks on Meckel's cave and so on and so forth, very advanced talks, you know, transcribiform by Prathamesh, etc. But this is where we all started from. So before starting this talk, I'd like to say a big thank you to Dr. Rajan Shah and Dr. Suresh Sankla. I've worked with a lot of neurosurgeons, but I think I've worked most with these two people, and I thank them for the huge caseload and the huge case experience. And I think the good, bad, whatever I learned in my life as experiences is thanks to all the support that they gave me throughout the last 15, 20 years. Sorry, 1 second. Okay, so beginning with, I'm just going to lead you people into the sphenoid signage and then tell you where the, you know, these are the basics of any surgery. You've seen a lot of surgeries which are concentrated on the sphenoid. Of course, Nishit has dwelt on a few points of how to expose the sphenoid, but I'll just go quickly onto the basic sphenoid exposure, followed by where all we can go. So very quickly, this is the right nasal cavity. As you can all see, this is the middle turbinate. The middle turbinate usually is attached to the skull base at the junction of the lateral and medial lamella. And of course, it has a free edge over here. The posterior edge is attached to the lateral wall of the nasal cavity. And what I do in all cases of pituitary is I take off that middle turbinate, as I'll show you further on. Okay, when you shift the middle turbinate laterally, then you start seeing the superior turbinate. Now, superior turbinate, the inferior end always sort of obscures the sphenoid ostia, which will lie directly posterior to it. So if you want to identify the sphenoid ostia, you really need to decongest this area, keep pushing the lateral, keep pushing the posterior end of the middle turbinate laterally and create this space over here. So follow the choana, go vertically upward, maybe look at the superior turbinate, go posteriorly, and this bone which is facing us is the rostrum of the sphenoid, and that bone is has its convexity facing us. So the minute you take off that take your instrument, run along this convexity, where the convexity ends at its upper end and it dips for deeper in, there usually you will find the sphenoid ostia. So different ways of identifying the sphenoid ostia. Idea is you must convincingly identify it, and you must not be injuring the pedicle of this area that I will show you further in sphenoid surgery. So here you see the sphenoid ostia. You could see it as an opening, or sometimes it's covered over by membrane. And gently, if you take a suction or a small Freer's elevator and just gently push in on it, your suction will actually go in and will open up the huge sphenoid ostia in that region. So that's how you identify it. Now, how do you gain maximum exposure to the sphenoid sinus, especially in skull base? I'm not talking of simple surgeries like polyp surgery, etc. This is skull-based surgery where you require a huge exposure, where you require a binostril access, and this is how we do it. So you see, I already told you that I take off the middle turbinate over here, I cut the upper end and I cut the lateral attachment. I do not go too close to the lateral border here because I do not want to cause any injury to the vasculature or the sphenopalatine artery, which would have its origin somewhere in that region. So I leave behind this little bit of stump of the posterior end of the middle turbinate and just bipolarize it over here. Similarly, you leave the most superior aspect of the middle turbinate as a landmark for further surgery. So this is the superior turbinate that you can see. You can see an ethmoid cavity over here. Again, a surgery can be done by just shifting all these structures laterally. But I find specifically this has helped me through my career. And this actually I learned from Professor Karao. I don't just do a partial ethmoidectomy. I actually go about doing a complete ethmoidectomy right up to the lamina peperissia. Now, what that does is if you just push these structures laterally, you're placing your endoscope and you're bypassing the structures to look into the sphenoid cavity. And you would put an instrument and there you would have a light cable, light source over here. But if you take off the ethmoid and the superior turbinate, of course, later, which I'll show you, you can place your endoscope far more laterally towards the lamina peperissia, far more proximally, that's more towards you rather than to bypass the structures towards the sphenoid, and you would still get a very wide exposure. Again, you see here, this is a lamina peperissia. Not in all cases that you really require it. You really require it in extended or far lateral approaches, but I do it as a routine in every case. And this helps us to gain, see the orbital apex, the optic nerves, etc. And it's a big panorama. It's anatomically, it gives you a big, huge lead, or you say a jump start into the anatomy of the sphenoid. And also it gives you the added space, which is advantageous when the neurosurgeon is moving about and you have three instruments on the right nostril of the patient versus one instrument on the left nostril of the patient. So this is all done only on the right side of the patient. On the left side of the patient, we generally leave the middle turbinate intact and we just laterally push the turbinate laterally and just take off the inferior half of the superior turbinate. So you can see once you come to the sphenoid ostia, just gradually use a debrider and widen the sphenoid ostia. Once you have the sphenoid ostia in view, the next step you need to do is preserve this pedicle. Okay, so you take a cut starting laterally and swinging upwards onto the septum over here. You can't take it way upwards. You have to keep roughly at the level of the horizontal limb of the middle turbinate. If you take it way upwards initially, you will cause damage to the olfactory fibers. So you see over here a gentle upward curvature over here, but you go swing very much upwards only after you cross the anterior end of the middle turbinate. So that is in preserving the Hadad or in creating the Hadad flap. In here, what we do is we are preserving the pedicle and we harvest the Hadad flap only if necessary and if we have a CSF leak. So it would suffice at this point in time to start the incision laterally and extend it onto the septum almost in a horizontal plane, but just maybe a 10-degree upwards slant over here. Of course, the lower incision is taken just at the level of the choana and we extend it onto the nasal septum. It is important to take this flap downwards to expose the rostrum of the sphenoid. So once you expose this rostrum of the sphenoid, this bone needs to be taken off. And before punching or taking off this bone in any way, you're preserving the flap on both sides. So this flap is preserved. It's called the reserve flap or the rescue flap, which we actually preserve on both sides, and then on go about widening the ostia. The area of the olfaction, we just shift that mucosa superiorly to help us take off the bone and do a posterior septictomy. We do not damage that mucosa. So again, very quickly, the rostrum of the sphenoid exposed on both sides. You generally see the owl-eye type of appearance, the sphenoid ostia on both sides. This bone, if you do not take off, you do not get access to the floor of the sphenoid. That impedes surgery. So I do generally use a quick chisel hammer, make cuts on both sides, a shoulder osteotomy, and then quickly tease it out. As you see, you take off the rostrum in a big piece. However, in many cases, you may not be getting a smooth base to the sphenoid. So it's essential to use the drill, either cutting or a coarse diamond bore, and then widen the sphenoid ostia, take off this posterior part of the septum, take off the rostrum, base of the rostrum, go on to the lateral walls, and actually drill out all these walls till you can access the lateral wall of the sphenoid on both sides. You see here, the lateral wall of the sphenoids on both sides beyond the carotids. So I have seen people trying to only keep a smaller exposure and only thinking that the carotids are the lateralmost limit. I think it's a good habit that you can actually, sorry, 1 second. Go back to this. It's a good habit just to go back here and identify the lateral walls of the sphenoid on either side. You see here, the drilling is done here so that you can actually identify the floor of the sphenoid sinus. This is the area of the clivus, and you have enough amount of space to work even beneath the sella. Similarly, superiorly, when you go, all the drilling is done to expose the tuberculum as well as the plana. So again, all that is the exposure of the sphenoid. Now coming back to the sphenoid itself, what are the landmarks that you can see in the posterior wall of the sphenoid? So this is again a slide courtesy the Pittsburgh group, cadaveric dissection specimen. Of course, here you see the sella. All of you all know sella is bounded by the 4 blues. One is the superior intercavernous sinus, the inferior intercavernous sinus, and on either side you have the cavernous sinuses. This bulge that you can see here is nothing but the carotid, of course the cavernous carotid, and the vertical limbs that you see are nothing but the paraclival carotid. So this, when we look at it, we are looking at it in a 2-dimensional way, but when we are operating, you must remember this anatomy in a 3-dimensional technique. So the carotid siphons are not placed exactly facing you. They are faced slightly laterally, but they are more towards you, these carotid siphons, than the paraclival segment. So if you go in sections from front to back, you would encounter this a little anterior compared to the paraclival segments. The sphenoid septa are usually attached either to the carotid or to the optic nerves, and that's why we say do not twist and pull on these septa. You have to really drill it down to get a good exposure. Laterally, of course, you see the orbital apex, and then on you see the optic nerves here well within the bone. The optic nerves lie in the superior part of this sphenoid here, and they all go on meet in this area, suprasellar area, where they form the optic chiasm. You can see over here a deep recess on either side. That's the pneumatization of the optic strut. They're called the lateral OCRs or lateral opticocarotid recesses. It's not often that you would find this lovely picture. This is what you say the most idealistic picture. Many a time you would find that this is not really that pneumatized, and you would really still have to identify your optic nerve, the carotid, and know that this is the lateral opticocarotid recess. More important is also the medial opticocarotid recess, which lies roughly in this area. And why is it important? Because you really need to uncover the medial opticocarotid recess when you're taking off the bone or over the sella. So again, to get a maximal exposure for, say, a pituitary, for example, let's start off with that, which is the basics. And that's what the level 1 surgery is. You need to have a good exposure of the sella. I've seen, again, many people just making a small bony opening over here. You have a wide exposure of the sphenoid, but make a small bony opening over here, make an even smaller incision on the dura, stick to the center and remove the tumor. That's really not the idealistic thing. You really need to make use of the limits. So you see over here, in true surgery, what we have done is we have drilled out all the bone around the sella, taking off a big, the bone over the sella, and then on you can go on using the drill and widening the sella almost to the cavernous on all the 4 dimensions. So you will either see the blue, or make sure that this is this is the paraclival carotid, and the cavernous sinus lies over here. You can see this big bulge of the pituitary over here. So many a time you would feel very tempted to make a smaller opening and keep curating this. But if you do that, then you're not going to get exposure to the lateral most end of the tumor. And you're losing the basic advantage of using the endoscope. Now with the endoscope, what we do is we have got a maximal bony exposure. We take a maximal dural opening. So you make a very wide dural opening, and that helps you to look in with a 0-degree endoscope within the sellar cavity, go up, look towards the diaphragm, go laterally, look towards the cavernous sinus, and still go about doing a fantastic job by having a maximal bony and a dural exposure. Again, this is extended transcellular approach. So again, sphenoid is the basis. The exposure remains the same, but very firm fibrous tumors. You may not be able to gain all the get all the tumor to descend down with just an exposure of the sella. So in those cases, we take the tuberculum also down. We drill out the tuberculum and get a more straighter trajectory, and allow the tumor to descend down. In some cases, you will see that you have the frontal extension of this tumor over here. If that's the case, then you would go about remove a little bit bone over the plenum as well to get a more straighter orientation and allow this tumor to descend down. So you can decide depending upon the extensions of the tumor how much more bone you need to remove. So sometimes when you go towards the cavernous sinus, if you want to remove tumor from the medial cavernous sinus, at times it is necessary to even decompress the carotids, move the carotid with your suction and then go about and curate out or take off the tumor of the medial cavernous sinus. Lateral cavernous sinus, I won't discuss that right now because the philosophy, the use, and when we really go about, removing tumors from the lateral cavernous sinus, that's a completely different discussion. So again, how do we extend this transsphenoidal? You've seen the basic pituitary surgery. We extend this further more anteriorly, and that's where we go to the transtubercular, transplanar approaches. And transtubercular, transplanar approaches, again, what we need to understand is the anatomy and what we need to expose. So depending upon the location of the tumor, you need to decide on what you really need to expose. So if you see again, you have the sella, you have the tuberculum, you have the plenum much more anteriorly, and inferiorly, of course, you have the clivus. So again, the basic exposure of the sphenoid sinus, you need to drill out, as I told you, this and expose this planar bone over here. I told you again how we take off the bone over the tuberculum, because tuberculum bone, if you take off in a very rash way, you'll injure the superior intercavernous sinus which lies behind it. So again, when you do these transplanar approaches, you drill the bone over the sella, you drill the bone over the plenum, take off the bone over both of that, and then go about and drill this bone and then gradually tease off the last remnant shell of bone over this, because that's where you have the superior intercavernous sinus. So again, you see exposure of the plenum, exposure of the sella, the clival bone, it's not necessary to remove at this stage when you're doing suprasellar tumors. Again, incisions depend upon what is the pathology you're treating. So whether you want to incise the sella as well as the suprasellar area, or whether you want to just incise that and then extend it down, again, depends upon the tumor or the pathology and the extent of the pathology. So you see over here, the superior intercavernous area, what you normally would do in craniopharyngiomas is you would bipolarize this, open the sella and the suprasellar area, convert it into a single sort of cavity, and then go about taking off the tumor, again using the same microsurgical techniques as you've already seen Vivek and a lot of other speakers talking about earlier. So again, all of this, you have to have a good exposure. If you do not have a good exposure, you're using the endoscope. During the course of the surgery, I'll have to take the endoscope within this cavity and give my neurosurgeon a good view of this whole area over here to determine the completeness of tumor excision. Again, a suction is going in and you'll have a third instrument coming in. So with 3 instruments going into this cavity, you better have a good exposure. And that's what all the endoscopic skull-base surgery is all about. So again, you see, as tumor removal progresses, I'm taking my endoscope deeper and deeper in. And that's the game played with the, understanding what the neurosurgeon really wants. As the instruments are going in, your endoscope is in, but as you go closer and closer, if my neurosurgeon has to dissect off this bit of tumor from over the vital structures, I need to give him a very, very close-up view of the whole area and go and show him laterally, medially, or wherever his instruments are going. So that's the dance or the ballet that you're playing with the neurosurgeon. So again, once all the tumor is removed, you see the endoscope is inside, the suction is inside, and of course you have the third endoscope also inside. You start looking into the third ventricle, and of course further on, if you look anteriorly and deeper in, you see the choroid plexus, you see the interthalamic areas, and you see, of course, the junction of the fourth ventricular aqueduct of Sylvius all over here. So all this is, you can get approach, and you can see it with the help of the endoscopes itself. So again, the tubercular transplanar approach in another case, you see over here, this is a case of, I'm sorry, it went fast through the scan, but that was the case of a tuberculum sellae meningoma. Again, we have published when tuberculum sellae meningiomas can be accessed by the endoscopic route versus when you would require another neurosurgical route to access these tumors. So this is a very simple approach. Again, I won't go into the full approach. I just go forward on this. Just going to move this a little bit here. Okay, so again, drilling, taking off the bone. Just like to show you the end point of this is after all the bone is removed, tumor is accessed, tumor is removed. Okay, so this is all the bone being removed. We'll go further on to the next slide. All the tumor is being removed over here. You can see all this tumor remnant bits over here. In tuberculum sellae meningiomas, the tumor would be facing us, and you would be, you would try to retain the arachnoid intact and try to take off the tuberculum sellae meningioma, leaving this arachnoid layer intact. Leaving the arachnoid preserves the vasculature inside. So here you can see the tumor was all in this area. We've removed it, CSF leaking out. And with a broad overview, you can see the optic chiasm, you can see the pituitary stalk, you can see the pituitary gland over here. You can see the arachnoid left intact in the suprasellar area. And we just dissect out this area very gently. This would be the region where you would find the superior hypophyseal vessels. And you need to be careful that you're preserving all the perforators, the superior hypophyseal vessels, all that come into this region, and not really go and tear it. And the dissection has to be very, very gentle. So again, for this, you see, you have to have a very good exposure to the transfenoidal, transtubercular, and transplanar route. So again, quickly, as you go further on, sometimes we get Rathke's cleft cyst, etc. I did not show you the previous movie, but in certain cases, you're able to see the anterior circulation. You can see over here, in craniopharyngiomas also, you can sometimes see this anterior circulation. You see the A1s, ACOMs, and A2s in this region over here. And all this is seen in the suprasellar or the transtubercular approach, which you do. Coming down again, transphenoid extensions. Coming down, I showed you the superior exposures. Coming down, you have things like clival meningiomas. Again, you need to drill out the bone of the clivus completely. And only when you drill out the bone of the clivus are you going to approach this tumor. So I will just skip this right now, the drilling of the bone. Okay, you need to expose from one carotid to the other. The base would be the sella, and inferiorly you would drill as much bone as you would require for the exposure. So now we have the advantage of using navigation to determine what should be the superior extent or what should be the inferior extent for these exposures. And once you do that exposure, you straight off have the tumor. And once you resect the meningioma, then you're obviously resecting the dura, and you see the basilar with its fanning out of PCAs, SCAs, and you have the third nerves, looking on either side of this. So you get a very wide exposure of the whole of the clival area. Of course, this is intradural surgery, but in some cases, you have simpler ones, which are chordomas, and that's more of an extradural clival surgery. So chordomas, again, your approach would be the same. I'm sorry, this is a little older video, and it's sort of cracking up over here, but you can see a lot of the tumor is being removed. And after you remove the tumor, you will still have a dura intact everywhere. So you'll see over here, the dura of the sella, the dura of the planum. The tumor was in this complete area. So you have the dura of the planum, sella, clivus, all kept intact. You see laterally the carotids, the vertical carotids. The picture is not very clear. I apologize for that. But you can see once the tumor is removed, you'll get a good clean picture of this. So again, you can do extradural clival surgeries, or you can do intradural clival surgeries. All the basic approaches, again, are transphenoidal surgery. So again, transphenoidal also used in angiofibromas. I think I won't go into the details of the surgery, but I'll just show you the relevant anatomy. This is an angiofibroma which is being removed. So just go into the end of it here probably. So you have a sphenoid sinus. You need to identify the extensions of the tumor. You will have a heard every speaker prominently, Dr. Brado, Dr. Jankiram, Dr. Satish, and so on others, so often they are stressed on, how to access the tumor going into the cavernous, how to drill out the pterygoid. This is the pterygoid wedge. You really have to make sure that the tumor is out. You really have to drill out this pterygoid wedge to make sure there's no tumor in there. Okay, that's the infratemporal fossa, and you're seeing that's the clipped the internal maxillary artery over here. That's the region of the choana, and you see over here again the sphenoid. So to access these tumors again, what you require is a forehand technique. Again, similar thing, a transsphenoidal exposure, understanding the whole anatomy. So sphenoid is almost like leading you to every structure. You start from the center, go far laterally, identify your pterygoids, identify your pterygoid wedge, identify your cavernous sinus, go laterally, whether the tumor is going into the, say, superior orbital fissure, whether it's going into the infratemporal fossa. I think the transsphenoidal exposure remains the cornerstone of success in all exposure in all these cases. So again, very quickly, I know I'm running out of time. I won't go too much into this. This is again a transsphenoidal exposure. Nishit, I showed you wonderfully how you go and do lateral sphenoid leaks. I have not really put in a video over here, but this is good enough to show you. This is not really an approach to the petrous apex. It's a chordoma, which is involving the clivus and going down to the petrous apex. And what I have done in this case is you can see the carotid over here. We have drilled out the clivus and we are going and removing the chordoma from, say, behind the carotids. So again, the sphenoid exposure is the main thing. You can remove tumors of the cavernous sinus. You can remove tumors of the petrous apex. You can do petroclival meningiomas. Again, the cornerstone of all these advanced endoscopic approaches are again the exposure of the sphenoid, exposure of the carotid, knowing where your carotid lies. This is the paraclival carotid. I'm going behind the paraclival carotid, going into the region of the petrous apex and the petroclival area, and then going on removing tumor. So again, you'll see that cavernous sinus oozing is nothing to be worried about. You would just go about, use a little bit of, hemostatic flow seal, and this cavernous sinus tumor at the end of surgery would probably settle down. So again, just to quickly summarize it, we have got a lot of videos, but the more videos that we put, it eats the time. And I know I had a very short time here, as all the speakers have. So just quickly summarizing, I think this is a fantastic slide by Professor Roten, which could give you all an idea of what the anatomy is. The sphenoid, of course, remains the center of the universe, as you all know, and you'll all have been taught. So again, the cella itself, the region of the clivus, you can go down even further down to the nasopharynx, tumors here, but you would start from the sphenoid, drill all the clival bone downwards to go laterally, either into the superior orbital fissures, the region of the cavernous sinus, the region of the Meckel's cave, again, the sphenoid and the identification of the carotids. I think these remain the cornerstone of all these expanded endonasal approaches that we are talking about. With this picture to leave you behind and to tell you that all this can be read further in various books. I think Professor Roten's book describes the anatomy the best. And again, there are a lot of YouTube videos around on the net, and all these procedures have been described well in various textbooks, various atlases. And I would exhort all of you all to go about, read this anatomy and decide on how you want to go further and expand your scope of surgery. So with this, thank you very much for this lovely opportunity to present this to the August gathering.
Thank you so much, Narayan, for spectacular photos and videos. Really a very good overview of all the transsphenoid approaches. I'm not sure if we are able to get all the questions because we're not seeing anything in the chat.
Nishit, I think this chat is basically we, all of us. So I don't think we're getting the delegate questions.
But the technical team is supposed to copy paste it into
they're supposed
this.
to, yeah.
So
Narayan,
hopefully they are.
Just one thing, could you, for the benefit of the younger people here, tell us how a dynamic MRI would help your insult before surgery?
How a dynamic MRI, sorry?
Would help while doing the surgery. If you have a dynamic MRI, how does it help?
Okay, so dynamic MRIs are very, very good. I use it primarily pre-operative. I don't use it intraoperatively.
No, I meant pre-operative.
Yeah, preoperatively. So preoperatively, you have a three-dimensional anatomy completely. You can actually follow every structure. You can even formulate the surgical strategy in your mind as to, how you really go about with various sections of the MRI. And if you study it, you can actually follow your instruments, what's going to come in each subsequent section, and, what structures you're going to get along the way. Formulate your surgical strategy. What, if you have, for example, vasculature, you even know which vessels are in your tumor, and you can actually decide all of this on studying various MRI films and dynamic MRIs. You would want to add anything on that, madam, if I'm not answered the question?
I think you've already touched on the vasculature, and of course you'll get the differential enhancement of the stalk and the pituitary, which will also help. Do we have any more questions?
So we can then head into our... No, I don't see anything on the chat, unless Jankiram wants to add anything. Otherwise, we will carry on to our next session. Request you all to stay on to help as moderators. So Dr. Narayan Jankiram has, of course, very, very close friend of mine, and he's one of the best surgeons I have seen operating. He's got fantastic hands, and it's been quite a pleasure to watch him operate and even work with him. Thank you, Janki, for being present with us, despite the fact that we know that you're not feeling well, despite that, for being here. And because we need to let him rest, we're going to request him to do the next talk, and I'll do the talk after he finishes. Janki, over to you.
So back again with my brother, Dr. Nishit Shah. So thank you very much for giving your slot to me. Of course, this is something which generally I don't like to impinge on the other slot, but since I want to go home and take rest, I requested Dr. Nishit to give a slot, and he was kind enough to do that. Well, without much ado, let me share screen, and the topic given to me is cavernous sinus surgery. It is cavernous sinus lesions. Well, cavernous sinus is one area which to me is a very, very beautiful area. Half an hour before, I just was operating on a tumor inside the cavernous sinus. In fact, I thought I'll do it live rather than to give a lecture. It was a fantastic case between the two carotids and dissecting carotids. Well, the cavernous sinus basically has got 4 compartments. So we should understand that it's got 4 compartments. And the cavernous sinus is actually, according to Lalligam Shaker, is a misnomer. It is neither cavernous nor is it a sinus. It's an extra axial collection of blood. So this is the first thing. So like cholesteatoma is a misnomer. Cavernous sinus also is a misnomer. Aldo Stamm book says it is the only area in the whole of the central nervous system which is the smallest area with the most crowded amount of structures. So these are all definitions given to cavernous sinus. So to me, I think cavernous sinus is something sort of, very, very interesting. And unless we understand the whole anatomy, which we have discussed already, the anatomy, it's difficult to, venture on to doing cases inside the cavernous sinus. Now, what's going to be my talk about? It's going to be around 20 minutes of just videos. There's no theory about it. Let's see this case. Now, this patient was given to me in Hanoi, and Professor Hay is a fantastic friend of mine, one of the finest neurosurgeons I've seen. Wonderful neurosurgeon. They have a 2,000-bedded hospital called Viaduct, and I actually used to head one of the theaters in neurosurgery. And we had around 25 to 30 residents watching every time we operate. This patient presented with 6th nerve palsy. And you can see here that an MRI, the patient was operated twice for a pituitary macroadenoma. given gamma knife also. And she desperately wanted to have a complete tumor removal because she's fed up of this tumor, 6th nerve palsy already. So there's a difference between a tumor which has already produced nerve palsies versus a tumor which has not produced nerve palsies. If it's already produced nerve palsies, then it's a little easier, you know, because you're not going to produce more morbidity. But if it's not, then we'll have to use the SSCP monitoring and all the other nerve monitors to check if you're not going to disturb the cranial nerves, because we always do functional neurosurgery. So we try to leave behind the tumor if there are no cranial nerve palsies. If there are cranial nerve palsies already there, and also if the tumor is secretory, then we might chase the tumor. Lesion was very, very fibrous. So how do you make out whether a tumor is fibrous or liquid? There are some very nice clues. Number one, look at the T1 with contrast. If you have something like a uniform enhancement, like a potato, it's called the potato sign. I call that a potato sign. It looks like a potato. Single good straightforward enhancement along with a T2. In a T2, you don't have that microhemorrhages, and T1 contrast gives you a potato kind of tumor. Then you know that this guy is going to have a fibrous tumor. Always in a fibrous tumor, I expose the carotid canal. You can see the carotid is almost in the middle. This whole cavernous sign is involved by the tumor. Imagine that's a stalk towards the left side, posterior pituitary is here, and you don't want to cause hypopituitarism in this patient. So that's a stalk, and that's the optimizer.
Sorry to interrupt you. We don't have a presentation.
What?
You've not started your presentation. Have you shared your presentation? Because we're not seeing a presentation.
Yes. I've stopped. I've been sharing for a long time now.
No. So we are not seeing your sharing screen. We were just seeing a blank screen.
Hey, Lakshmi, just check what's happening.
We could see you said share, and we could see your presentation, but you hadn't clicked on the presentation. Yeah, now we have.
Have it?
Now we have your screen.
I think okay, so patient with 6th nerve palsy, gamma knife given. So gamma knife is one area. We have a few articles in literature which say that it thins the carotid if you have radiotherapy. There are some articles which say that radiotherapy doesn't produce any changes in the adventitia. There's a little controversy regarding that, but I strongly believe that if you give radiotherapy, then there's some alteration, and you should be more careful in dealing with the carotid. So as I told you, fibrous pituitaries are potato tumors. You can see here the pituitary is going far laterally, and this patient had a 6th nerve palsy. And are you getting my presentation? Because I had already covered all that.
No, now we are seeing everything. No problem.
Okay, see that T2. That T2 is very important. Classical liquid pituitary in a T2 looks totally different. You have sort of, you see that iso intensity, but there is no microhemorrhages here at all. So that is very, very classical of a fibrous tumor. Of course, the diffusion weighted image is also very important. Now let us go on to the surgery. How did I go about it in a neurosurgical workshop? Okay, so here we are. I planned for a transmaxillary transpterygoid approach. I'm not going to deal with that. That's the posterior wall of the maxilla. Did a medial maxillectomy. And then you drill off the posterior medial wall of the maxillary sinus. And what you get into the pterygoparatine fossa. And once you get into the pterygoparatine fossa, the next step is you coagulate the IMAX, and then you identify the median nerve. So the median nerve is a standard landmark. Median nerve is the most important landmark to me for identification of the carotid artery. Now here we are, I'm using the Doppler here to check how the carotid is. And where do you make the dural incision? See the exposure which we have given. This is the V, that's a V2, this is the median. Sorry about that. That's the V2 and this is the median. That's the lateral recess created by us. That's the paraclival carotid. Always when you lift the dura, you can see that carotid going, dipping inside. That's paraclival carotid. And always when you have cavernous sinus extensions, try to drill till the level of the V2. And here we are. So I'm using the Doppler. And then where do you make the incision in the dura? That is very, very important. And that can be done with two important tricks. Number one is stay lateral to the median. Stay lateral to the median. Make the incision lateral to the median. Number two is you can use a navigation. So navigation is also one alternative. But to me, I believe more on anatomy. I just made that incision. You can see very, very clearly that I'm making it lateral. This is the median now here, making it lateral. Then you have what's called the acoustic knife. So we go across the carotid. So we go across the carotid. And once we go across the carotid, we will see that's the potato-like tumor. It's a very firm tumor. Imagine the patient has already undergone 2 surgeries and the patient wanted this tumor badly out. And I am super tense because I'm not in my home pitch. I'm not operating in India in my Royal Pearl. Actually, that again gave me a little tension. And then we do what's called the extracapsular dissection. That's the extracapsular. I think these concepts have been propagated in India by Dr. Nishit Shah and also Professor Amin Kassam. And so you see what we do is we go around the tumor, So we go around the tumor. And once we go around the tumor, you're not bothered about the 6th nerve. The 3rd nerve doesn't come here. It's the V2, the 3rd nerve goes far away, far up. So you see how I'm using my scissors. I'm not cutting through it. I know that's exactly where the carotid is going to come. I'm using it in the open mode and gently trying to cut a little bit and then bring it out, cut again. So these are movements which are very important for the juniors to know. I honestly believe that don't venture on to these surgeries as youngsters unless you've done cadaver dissections. It's not rocket science, but better you do a lot of cadaver dissections and then you venture on to such surgeries. You can see that's the carotid artery. Half an hour back, I was doing the same kind of dissection. In fact, we finished this case in 1.5 hours. And you can see here, that's the carotid artery. And then see, basically in the cavernous sinus, more importantly, the chondrite tumors produce more of carotid artery ruptures. Pituitary tumors gently can be peeled. Angiofibromas can be gently peeled, but be careful about chondrite tumors. So chondrosarcomas. You see the carotid very beautifully standing like a pillar there. And I have dissected the carotid, and that's actually the lateral cavernous wall. And that is made of a meningeal layer of dura. And then I'm going inside the sella and I'm trying to dissect the tumor. And I'm doing what is called the reverse elevation. This is called the reverse curate elevation. And you can see here, that's the 6th nerve here. In fact, that is the final result where I've completely removed the tumor from the sella and the cavernous sinus, the carotid standing like a queen. It's called the queen of skull base according to Professor Castelnuovo. Really big respect to that great gentleman who wrote a book on the carotid artery. And here we are. I'm now showing you what we did. You see that that's a normal gland. I preserved the normal gland. Very important to do functional neurosurgery. You don't want to take off the normal gland. And that's the final end result of this cavernous sinus tumor surgery. So the patient is doing fine. I am in constant touch with Professor Hay. In fact, next month, maybe, or in 2 months, we'll be going there again. And he's got a lot of cases for us again. Okay, let us now go on to this tumor. This tumor again is sort of a tumor involving the cavernous sinus. In fact, a massive involvement of the cavernous sinus. I'm going to show you that this patient also presented with a 6th nerve palsy. See, I choose my patients with if I do the cavernous sinus surgery, depending upon the cranial nerve involvement. Just don't go blindly because you have an ego to operate on the cavernous sinus. You don't have to. You can just leave that and come out because it's a non-secretory tumor. Why do you want to cause a cranial nerve palsy for a patient who doesn't have a cranial nerve palsy? That's not functional neurosurgery. So here we are. So there's no anatomy at all. This is a revision case. Create anatomy, create anatomy. The other day, in fact, Professor Sethi's conference, a similar case was done by us and absolutely no anatomy, and we started creating anatomy. In fact, that patient is doing very fine now. And you can see here that this is something which I think the juniors should a little avoid. Don't use punches over the carotid. And in fact, if you find that the petrous apex involved, so when you read the scan, you have to look for the petrous apex. And if you want to dissect the petrous apex, then you have to dissect the bone from the keratocondylar window. That's the keratocondylar window. I'm trying to dissect that bone out and see the carotid right there in the center. So now this patient, again, 6th nerve palsy patient, already operated, I think once or twice. Patient comes and says, sir, get this tumor out, please. And then what you do, you have to do something for that patient. And that's the median nerve, that's the carotid. Using my Doppler now. And you can see that once we have mapped it, I'm now, see, always use a carotid Doppler whenever you do carotid cavernous sinus surgery. So that's something which I always insist for all the juniors out there who are venturing on cavernous sinus surgery. And you can see here that I'm now trying to rise the endosteal layer of dura. And once I do that, slowly, see, already fibrosed because of the previous surgeries. And luckily, this patient had a little suckable tumor in the sellar compartment. Of course, it was not radiated, in fact, so it's good for us. Now is the question, where do you make the incision of the dura? This is something which is important. You make it lateral to the median nerve. That's the median nerve. I make it lateral, not too lateral because you might injure the V2. That's something which is to be taken into mind. And you see that I'm using the caustic knife to go across the carotid artery. And once I do that, I'm now taking my scissors. I generally do it. I like sharp dissection. I'm not for, fancy gadgets. As Professor Kassam says, the best tool to operate is the suction and a pair of scissors. This is what I learned from Professor Kassam. And I honestly believe I don't use CUSA. I don't use, fancy gadgets, nothing. I just want to dissect, and that's what I learned from this greatest ever skull-based surgeon this world has seen. That is Professor Amin Kassam. So here we are. That's the carotid artery. You can see that's the carotid artery. See how we've dissected the carotid. And a person who's doing cavernous sinus, see that behind the carotid you have tumor that's towards the petrous apex. You can actually do a transposition of this carotid. You can transpose it medially, laterally. You can actually play with the carotid. Be careful, huh? So that's actually the pre-op of the patient. The patient presented with acromegalic features. And the moment I completely removed this patient's tumor, completely resolved within a matter of around 5 days, the patient was like, absolutely different from what he was, even the facial features. And he was thanking me, and I thank you for watching this video. Now let's go on to a very interesting case, which was given to me again in Ho Chi Minh City. And they were actually contemplating on a lateral approach to this, maybe a pterional approach. I said, why pterional? We can do it endoscopic. And that's the median. I have now delineated the V2. I am now drilling off the bone, that's the maxillary strut, and everything is all anatomy done on cadavers. So I honestly believe that please do cadavers, cadavers, and cadavers. This is something which is very important. I think Professor Renuka Bradu and Dr. Nishitji are taking a lot of effort to train juniors in Bombay and in the IMAST or CMAST, I'm not very sure, to train them very well. Really big, applause for them. Here we are. Now what I'm trying to do now is I'm removing the bone medial to the cavernous sinus and exposing the carotid. See, let me tell you something. Whenever you want to operate on a patient, that's a carotid being mapped. Whenever you want to operate in the cavernous sinus, which is the most difficult and dangerous area which you will be facing, and that's the carotid. So what you have to do is to get the cobra first. This is something which I always believe, whatever surgery you do, try to get the most difficult and dangerous area. See the carotid now. I'm dissecting the tumor from the carotid. Get that which is going to give you the complications first. If you are not doing it for a thyroid, get the recurrent laryngeal nerve, superior laryngeal nerve. So the surgery becomes so easy. Yeah, whatever. Get the difficult and dangerous part first, and then you will not have any problem. That's a cavernoma of the cavernous sinus, and that was a complete removal. I mean, the neurosurgeons were very convinced. Now let us go on to, this is, I think, one video which I keep presenting in front of Professor Kassam or anybody from Pittsburgh. I think this is something unique which I've done. Maybe I wouldn't do it now. I shiver when I see this video. It's a 9th revision JNA and irradiated in various places, and then came to me, referred from Dr. Suma of Calicut. See that, the carotid is like here. I am scared to see this video, something like a scary video. That's a carotid. And this tumor, which is absolutely fibrous, encircling this carotid. And I think I've received some, big comments from the top notches in the world when I present this. You see how I'm cutting across. Today, when I see this video, I'm a little scared. You see that's the carotid. I should have done a BOT or a stent or whatever. But that time, Ilankandru Bayamaryadi we call. That is a share which has not faced too many complications, doesn't know the depth. The same way, I was fortunate enough to come out, but then I knew the anatomy. That is something which I was very confident about. And you can see how I removed this JNA. See the cranial nerves which are pushed, that's a FCL. I'm cutting off the cartilage of the eustachian tube. See what I did for this patient. Suma was actually, she called me and said, hey, Janakram, what did you do, man? This is something like, incredible. And I also felt, and now when I see it, I think, why did I do it? I mean, this is something which I wouldn't recommend. But anyway, this is my initial career in which I did this. Maybe I wouldn't do it now. Okay, so here we are. Meckel's cave is also a topic which has been given to me. So we have done around 18 cases, all given by neurosurgeons to me. And they were all contemplating on any other approach, like, I don't know, transpeat or something, all the different approaches. I said, oh, this is straightforward endoscopic approach. In fact, when I presented this in Barcelona in front of Professor Karau, who is my teacher, he said, you're bold, man. That just one word he said. And you see here, that's actually the tumor sitting right between the paraclival carotid and the horizontal carotid. And what did I do? So again, in a neurosurgical conference, in this I'm using the one which Dr. Nishitji always uses, the Colorado. And you can see the owl's eye appearance, and then I'm drilling off the transpterygoid approach towards the Meckel's cave. So let us understand that before you understand the Meckel's cave, you should be thorough about the anatomy of the quadrangular space. So there is something called the upper quadrangular space and the lower quadrangular space. And the V2 separates both, and you should understand that unless you are very conversant with the quadrangular space, which is the window to the Meckel's cave, and Meckel's cave is one thing which almost we were doing almost every week, 3 or 4 cases because of the mucor. Mucor involves the Meckel so often. So in fact, we are giving a book out, and you will be seeing so many mucor cases involving the Meckels, going to the posterior fossa, everything done endoscopic. So here we are, I'm drilling that bone. So, and the most important, please understand that the carotid is anchored here by 2 struts. What are the 2 struts? Above is the optic strut, and below is the lingular process or the sphenoid sinus. Unless you free both, the carotid cannot be transposed medially. So this is the lingular process. So my strain will be to remove the lingular process, and of course the optic strut cannot be removed endoscopically. It's not ideal to do anterior clinoidectomy, but even that has been done by us now recently in mucor cases. That is something which is a little bold. See, now I'm removing that canal from the carotid artery. And the Meckel's, the cavernous is all about the carotid artery. Of course, nowadays we do a lot more of, stenting or coiling, and a lot of interventional radiology has been included into our kitty. I am now doing the, but this was not done in Trichy. This was done in a neurosurgical workshop in a different country. So you can see that I'm now mapping the carotid. Okay, once I map the carotid, I'm going to make the incision. And where do I make the incision? Again and again, I say the median nerve is the mother for us to make the incision. Here we are, I'm making that incision, and you can see the V3 schwannoma. This is a very classical case of V3 schwannoma, and you have to do extracapsular dissection, and I will try to remove this tumor in toto, completely. And then a little bleeding, which will be stopped. And you can see navigation was used. Of course, the neurosurgeons there wanted me to use that to just for teaching purpose. And you can see that's the complete removal of that. We've done cases which are extending to the posterior fossa as well. So I drill this and then I go into the posterior fossa. So that's the end of my lecture. Let me see if I have, okay, carry home messages. Number 1 is use a Doppler or a navigation whenever you do cavernous sinus surgery. Also use SSEP monitoring, nerve monitoring, sensory nerve monitoring when you're operating on the 3rd and the 6th nerve. You don't want to produce palsies of nerves. Always have flow seal, surgery flow when you're operating on the cavernous sinus, because that's the one which will stop. It's called a magic flow seal, which will actually stop the bleeding from the cavernous sinus. However, we've used flow seal and also Surgiflow, and when you pack it, sometimes you might land up with a temporary 3rd nerve palsy. We have, I think, 6 cases, 6 cases of a temporary 3rd nerve palsy, which recovers after 3 months. Never use punches on the carotid canal, and do not use coarse diamond burrs or cutting burrs on the carotid canal. Study the perforators into the tumor, especially there are 2 important branches of the cavernous carotid. One is the meningohypophyseal trunk, and second is the infralateral trunk. You should be very, very clear in dissection. Do that in dissection. Do that in dissection. You have to dissect the tentorial branch. You should be able to dissect the inferior hypophyseal branch. All that you should be able to do. If tumor is very firm, better to leave it than to cause a nerve palsy. This is the most important carry-home message I want to say. Don't have an ego in the cavernous sinus. Cavernous sinus is not for people having a normal functioning cranial nerve. So during the COVID era, I think Dr. Nishit-ji, I don't know what to say about him. He is such a close friend, brother, philosopher. He is the one who opened the doors for me. It's nice that I can meet people like him, and I'm so proud to say that I'm his friend or his brother. Thank you so much, Dr. Nishit-ji, and I think I'm done. Any questions? I'm ready.
Narayan?
Yeah.
Yeah. Janki, a fantastic talk as usual. Dramatic and on the edge of the seat as usual. Compliment you for that, and thank you for driving home a lot of points as to when it needs to be done versus, rather than everyone attempting it in a daredevil manner. Thank you very much. Nishit, Dr. Renuka is also the moderator. Can she put her video on?
Janki, just one question, Janki.
Please.
Of course, you emphasized the...
I only ask questions to you, please. You're the boss. I am your student. So don't ask some tough questions. I'm not ready.
So you emphasize the importance of the Doppler, which of course we know is very, very important. What about ICG?
ICG, yes, I'm using it right now for mucor cases, but I think ICG may not be very much useful for the carotid. The reason is because what happens is when I inject the ICG, it stays for a very less time. It stays for maybe, maybe 5-6 minutes. That's the max it stays. But the problem is my tumor dissection takes a lot more time. It's not that I can finish the whole thing when the ICG remains. So I asked my anesthetist, can you give ICG again? He's a little chill. Oh, no, only once. That's it. So when I have a one time for a prolonged procedure, for mucor, yes, I can delineate and then quickly remove the osteomagnetic bone, do that. But I think for the cavernous sinus tumors, which involve at least a few hours of dissection, to me, I think the ICG may not be of great help. I think you can throw some more points on that.
No, I agree. Just to bring to notice for some members of the audience that things are changing, some new developments are happening, and what is important and not important. So Janki, thank you so much. We'll let you go and rest.
I think
thank
Dr.
you so
Madhu
much
want
again
to say something. Her mic is off. Madam, your mic is muted.
Janki, I see you don't use two suctions. You don't use a two suction technique usually. Why is that when everyone across the world is constantly harping on two suction technique? Why is it that you prefer to use scissors or what is your take on two suction technique for removal tube?
Wonderful, fantastic question. Actually, we use the two suction technique when we do intracapsular dissection. When the tumor is suckable, we definitely use only the two suction technique. But if it's going to be a potato-like tumor, there is no point in using a two suction because it does it.
So we go on to the next session, which is, I think Nishit's talk on transorbital is left. I'm sorry. Madam Renuka, you want to invite Nishit because you also got a large experience with transorbital approaches. You want to say a few words before and invite Nishit for his talk?
Definitely, I would. I'm not so sure I have a very large experience. I have some experience with transorbital, but Nishit really doesn't need any introduction. But still, as a formality, he's a senior skull-based surgeon at Bombay Hospital and Breach Candy Hospital, and maybe some other hospitals which I don't know of as yet. But he is, we keep talking about father of endoscopy. I think he's the father of pituitary surgery in India. I think he has the largest cases. And yes, with the new frontiers that we are touching upon transorbital surgery, I'm very keen to hear you, Nishit, on what you have to say about this.
Okay. Thanks, Renuka. So I think in the confusion of doing the CSF, I seem to have lost a few of my starting slides of the orbit. But it doesn't really matter because we can start from here. So just a few slides to take you through the anatomy. We're looking at the orbit from inferiorly and seeing the inferior rectus and the medial rectus.
Nishit, you need to share your slides. Your slides are not on.
Okay, so you're not seeing this?
No.
Okay, sorry. here. Just can you give me a minute? I'll just see if I can get the actual presentation on. Sorry, Renuka, if you have something to say, I'll just take 2 minutes.
So when transorbital surgery was being proposed, and this is in Dubai about 6-7 years ago, I had the fortune of being on the same panel as Casanova, and Casanova, of course, has done a lot of work on this. And at that time, I presented some transorbital work of my own, and it was great to have an interaction with him on that. And he was at that time still at the cadaver dissection stage of his work, but it was an excellent discussion. And since then, I've met a number of his colleagues and juniors, and do brilliant work. So I would like to give a nod to Casanova at the beginning of this talk. Are you ready, Nishit, or Narayan, do you have anything else to say? You're ready?
Yeah, just opening the talk.
Okay.
I think it got lost in the, okay.
There's also, of course, Darlene Love in South Africa, who's doing a lot of work on transorbital surgery.
Okay, I'm ready. Let me just share here. Okay, sorry, I'm sorry about this. Okay, so I hope you have a screen now. So we'll talk a little bit of endoscopic orbital surgery. And I've done a lot of these surgeries with Dr. Dev Pujari and Dr. Sunil Shah, apart from many other people. So when we look at orbital surgery, of course, there are traditional approaches, and then many things have changed after endoscopy. I won't spend too much time with anatomy because I think we already covered a lot of this earlier, except to say that for us, the important parts are the optic nerve and the superior orbital fissure. And when you come in medially, you can't cross this. So then you have to come in superiorly or laterally, and which is where the other approaches sort of came in. Again, just few quick slides for anatomy. What is important is the superior rectus, superior oblique. And you know, of course, that the anterior ethmoid artery will come between superior oblique and the medial rectus as it leaves it. A lateral view, again, just to show lateral and the superior recti, and then the lacrimal vessels. The medial, which for a lot of us endoscopic surgeons was very, very important, showing relation of the recti muscles, the anterior ethmoid, and the carotid artery at the orbital apex with the optic nerve taking off here. And then, of course, the inferior. So you're seeing it in a three-dimensional perspective. Coronal view, which everyone's familiar with, again, to show the recti, the end of the orbit with the optic nerve. Right. So just quickly to go through, again, some anatomy on a cadaver. We're using an eyelid incision, something which Castelnova popularized and which Renuka also has been doing a lot of. So you take a small eyelid incision, elevate the orbital periosteum. The big advantage of this incision is you can go medial or lateral. For example, you're at the superior orbital fissure here, coming from above. And if I go medial to that, I'm at the optic canal area. So I can then see the same thing from the nose where an ethmoidectomy has already been done. And if you then go ahead and decompress the orbit as you would with an orbital decompression by removing the lamina papyracea, then you see the more internal structures. So now we're going to sort of also take off, that's the orbital periosteum being taken off, so that we get a good view of what is happening inside. Above is the anterior ethmoid artery, which we will cut so that we can move the orbit a lot better. So that's the artery being cut. Orbital fat. Medial rectus will come into view once we remove this fat. So that's your medial rectus. And this is your common corridor, right? Medial rectus and inferior rectus. Here you see superior oblique and medial rectus and the anterior ethmoid that would come between the two out. And this is something you'd see also on your CT scan. And if you're lost, this is what you look for as to how to find your artery. You can follow that artery back and see that it gives off the where the posterior ethmoid artery comes off at the back. And further back, of course, from there will be the ophthalmic artery itself. So that's the posterior ethmoid as it would come off the ophthalmic. And further back, you can follow it all the way back to its origin from the internal carotid. Inferior corridor there, which is our most often corridor, which is our easiest corridor to get into to remove tumors inferomedial to the optic nerve. Then, of course, you can go around it on a cadaver. It's a lot easier because your orbital apex becomes quite narrow. And you can then go to the superior orbital fissure and see the third nerve as it were coming out of that fissure. Just cutting the muscles a little bit here again, so that we have a better view inside to see the optic nerve in there. You see the branches of the third nerve coming from lateral to that and supplying the muscles. So the third nerve supplies the muscles in the posterior-medial aspect.
Nishit,
sorry, carry on.
I just want to ask Narayan, I'm getting an intermittent break in your presentation that the slides are going. Is that the same thing happening to you, Narayan?
Yeah, I think that's because of the internet speed. The video is moving a little bit jerkily.
No, and intermittently it's going off screen.
No, it's there. It's on screen.
Yeah,
okay, so that's only my thing. Okay. Yeah. Okay.
You're on screen.
Maybe the
Wi-Fi.
Wi-Fi.
That's all.
Okay, carry on. Yes, we're able to.
So that's the ciliary ganglion at the origin of the third nerve. And we're just looking back to see the fourth nerve as it supplies the superior oblique. And then coming out again, that's the optic nerve and its relation to the carotid artery. So just to give you a little bit of an idea of a medial approach, superior approach. And now we can also look at a lateral approach. And this is, again, you can take an eyelid incision and come laterally, or you can take a straight lateral incision as well from the corner of the eye there. And use that to address, basically what you're looking at is a greater wing of sphenoid. So if you have greater wing sphenoid meningiomas, or even if you want exposure of anterior or middle cranial fossa, this lateral orbitotomy approach works very well from an endoscopic route. This is something that was done earlier as a non-endoscopic route. So we finished the incision. You can see that little lateral incision. On this cadaver, we didn't have permission to go more lateral. So I had to stop here. And then again, you have to elevate the mucoperiosteum. You use a retractor to keep the orbital periosteum. If you don't have a tear in the periosteum, it helps so that you don't get fat prolapse. And as you go down, you will see the meningeal branch. And just under that, you will see the superior orbital fissure. So this is coming in from a lateral approach. That's the meningeal branch and the start of the superior orbital fissure. Again, so depending on where you want to go, up or down, and this will be based on navigation, you can start drilling the bone there and expose the dura of the cranium. So you can see now that we are drilling on this bone, and sometimes the bone can be very thick, especially if you have a meningioma. So once you finish drilling of the bone, we're taking off a little bit of bone there of the lateral process. You can come, like I said, a lot more laterally to zygoma and drill a lot more bone. And once you have clearly defined the area that you want exposed, you can then incise the dura and address whatever you need to intradurally. So you would almost be at the sylvian fissure, at the junction of anterior and middle cranial fossas. And depending, as I said earlier, you can go up or down, lateral or medial, depending on pathology. So this is a very nice, elegant exposure using a lateral approach endoscopic. And from inferiorly, of course, you can come via the maxillary route and complete a nice 360 sort of approach to the orbit from all different aspects. So now you have a good view of the middle cranial fossa from and transorbital aspect. So this works well. Right. So what are the common pathologies that we worked with? Neoplasms, of course. Also some malignancies, which have gone towards the orbit. Inflammatory tumors, bony problems. And we have used these various approaches, including, so now often, as Renuka mentioned, Darlene Lover of South Africa has been popularizing the transcaruncle approach as well. And it can be used instead of a transethmoid approach or the Lynch incision. We can also do the similar things from a medial approach. So enumerating the various approaches here. Okay, so we'll just do a few examples. A big osteoma there, not just encroaching on the orbit, but also going a little intracranial towards the anterior clinoid process. So the way we want to do this is, of course, you want to do the ethmoidectomy, identify frontal and maxilla, because those are your two landmarks that you really want to see in the periphery. Then you want to start drilling the osteoma in the center and core it out so that when you come to the periphery, it should be mobile and it should sort of flake off easily. And if you can do that, you can actually preserve the mucosa on the periphery. So you'll see here, I'm sorry, anyway, right, there is a little bit of stutter. At my end, I apparently have a speed of 100 Mbps, so I don't know why it's happening. But it should be okay. So you can see how that thing is being flaked off, and yet the mucosa under that it can be preserved. So once you get a lot of that decompressed, then the whole part from the orbit comes out because it's extra periosteal. And in a way, it was not good for us because it came out in such a big piece that we had to do an intranasal drilling to separate it. And then we had the optic nerve in view. That's the orbit. And we had to take that clinoid process out so that we could free the remaining part. So that's what you're seeing being done. The last bit, that's the optic nerve. And that's the last clinoidal part coming out. So now the whole optic nerve is decompressed. A bit of the dura is exposed at this area, but there's no CSF leak. So if you're careful and use navigation, it's quite easy. We then go into the orbit, and the first time we saw something like this being done was in our workshop in 2011, when we had Amin, Karao, and Danny, all three operate together. So we had 6 hands, not 4 hands, 6 hands remove this schwannoma from the optic nerve. And that was really something. At one point, I was the 7th hand irrigating. So there were that many hands actually doing it. So this is the patient that I did with Sunil. And of course, we had help from our fellows as well. So similar sort of tumor, but it's a hemangioma in the inferomedial aspect of the optic nerve. The way we would do this is ethmoidectomy, open the maxilla wide, identify the frontal. Then you want to take off that middle turbinate so that you can communicate ethmoid with sphenoid and have a really complete view of the entire area. We go ahead and do an orbital decompression, take off the lamina papyracea. Again, it's good to have a binostril view so that you can use, there's no other way for us to get 6 hands in to retract the muscles. So rescue flaps on both sides as the carotid artery there. So decompression all the way to the orbital apex. The lamina is opened completely. You then, also it's a good idea. So I'll skip this part where we just get the binostril approach going. It's also a good idea when you're going to do a lot of mobilization in the orbit to drill the anterior ethmoid artery and cauterize it so that you're not worried about it snapping when you try and move the orbit. So we've just cut the anterior ethmoid artery there and just taking off the last bits of bone, both superior, inferiorly, and at the apex to have maximum exposure. Once that's done, we can take our incision in the periosteum. So we'll take a couple of incisions so that we not only reflect the periosteum, but we can actually take out the periosteum. We don't want things that interfere with mobility of instruments. So that's reflected back and the fat is cleared. So now we have a clear view of the middle and the inferior recti muscles, and we can take our plane between a corridor between them. You see already 4 instruments in the nose with the endoscope. So everyone is sort of retracting the muscles, whilst the main surgeon is using suction and dissection to get the hemangioma out. So we are in the corridor, inferior medial rectus, and trying to get that tumor out. Stay as close to the hemangioma as possible because you will have vessels and branches of nerves, especially as you go posteriorly. And then what Castelnuovo did was also interesting. He would sort of freeze it using cryo and use that as a retractor to pull it out instead of forceps. And also it would sort of make the lesion a little more solid and easier to dissect. We were going with what we had seen with Amin. And so we just followed retraction and dissection. And as we did more and more, you can see we are getting towards the back end now of the hemangioma. So this is a very nice way, but it does need a little view of the optic nerve at the back once we sort of get the hemangioma out. It does require coordination between a set of people that have worked together for a long time. So it's not easy to be doing this as your first, second case. Everyone needs to know what their role is, and there's no clashing of instruments as you do this surgery. So just cautery at the pedicle, take it out, and then we can make the final cut and remove the hemangioma. Once it's out, you really don't need to do much in terms of reconstruction. You just put a small piece of Surgicel in there. So final look at the cavity, at the optic nerve there. And this patient, of course, did well. He did have a little bit of paresis of third nerve for a month, but it recovered after 1 month. And just wanted to end with this little clip since we had all this talk of Mucor, where, you know, being in a private hospital and having a different set of patients who were very keen on preserving the eye at all cost. And so we were in a situation where with Mucor in the orbit, we still had to try and preserve the eye at the patient request. And so this was one such patient where you see there's Mucor in the orbit. We've finished with the ethmoidectomy. And when we look at the orbit, that's the maxilla, mucosa has been stripped off. The lamina was actually intact and looked normal. So we just decompressed it. We took off the bone over it. We exposed the orbital periosteum. And you can see that looks normal as well. Looks completely normal. So we did have navigation, so we knew exactly where we had to go. And once it was all fully exposed, we could take an incision over the periosteum. And you see, immediately when I took the periosteum incision, I see slough. I see the mucor within it. So it sometimes is not necessary that you have to have this sort of contiguous spread, and you can have microvascular spread into more distant areas. We've also noticed with Mucor a lot of perineural spread through neural channels and neural canals into adjacent areas. So once we had a good view of that Mucor in the orbit, we could go ahead and try and decompress and remove as much of it as possible. We did use forceps, and the last bit sort of, we had to use a coablator. Through-cut forceps also were useful because we were trying to save what is uninvolved or normal looking tissue. So I'll just go a little quicker here, just to show that we did chase the mucor all the way till we were seeing what looked like normal muscle at the back. And actually, to our surprise, this patient did quite well. We did have 1 or 2 follow-up surgical views of his nose, little touch-up of whatever residual slough we saw. And he went home with his orbit and vision completely intact. So it just shows that if you do have a little bit of time and the patient is very keen, you can save the orbit and eye in situations where otherwise it might have been easier to just take the orbit out. Okay, so just thank again the Department of Neurosurgery and Ophthalmology, with whom we've done a lot of work for their support. And of course, IAOHNS. Thank you. Sorry, I'm just going a little quick to try and make sure that we don't run behind time. Renuka can give us some thoughts because she's been doing a lot of work as well.
Nishit, actually, just 2 points I'd like to make, especially if they're both related to mucor. And one was, and this I actually got these insights from the oculoplastic surgeon I worked with. One is, we always thought that if you have ophthalmoplegia and decrease in vision, we automatically assume that the eyeball had to come out. But what he told me is that ophthalmoplegia and decreased vision do not necessarily mean that the nerve itself is involved. Sometimes because of congestion, because of edema, you can have an external compression of the optic nerve, and therefore can have loss of vision. And so he said the criteria which we use is not so much clinical as we use MRI to see whether there's actual contrast enhancement or loss of contrast enhancement, and based our decision on actual involvement of the disease and the nerve, the clinical signs. And I have seen reversal of ophthalmoplegia and vision in patients whom we saved the eyeball. So that was one thing which we learned in this mucor thing. And the other thing that he told me was that there has been a trend in some surgeons to actually remove everything of the orbit from the muscles and everything, but leave the eyeball intact. So that it's not just a medial decompression like the one you showed, it very elegantly shown, but actually remove almost everything in the contents of the eye orbit, but leave the eyeball behind for cosmesis. And what he said was, when you take off most of the to the eyeball, and at the end of it, not immediately, but within few months, you will have an extremely painful contract, phthisis bulbar, and very painful. And therefore, he said, if it comes to that you need to remove a large amount of tissue, it's better to take out the eyeball as well to prevent this painful eye and then final exenteration at the end of a few months. So these are the 2 things that we learned from mucor and the orbit. Any other points of view?
Nishit, you're muted. You were saying something, you're muted.
Sorry. Yeah, I don't think we're seeing any questions. So, Narayan, if you want to give us some of your thoughts.
I think it was a fantastic talk. And of course, there are a lot of things, advances in transorbital surgery. We're talking, it started off with only the medial approach, but now there are a lot of lateral approaches. And I think Professor Castello was the proponent for starting these lateral approaches to go to the middle cranial fossa as well. But, eventually, if you hear him talk, he says that, at the end of so many cases, we feel it's not really worth going to the middle cranial fossa or the temporal lobe through the orbit. So obviously, you are looking at refining the approaches, you're looking at refining the indications. But yeah, it holds a whole lot of promise with these superior brow incisions or supra-orbital incisions that we go and do various surgeries. So they've divided pretty much into a medial, lateral, superior and inferior compartment, and based on the lesion, we decide what approach we should take. So it's not just purely endoscopic transorbital, but you should know all the approaches surrounding it.
I think it's surgery in evolution.
Yeah, which is so exciting because we initially started with the endoscope thinking it's a diagnostic instrument and we'll never end up doing any surgery with it. And now we are doing surgery which we could not have imagined possible.
Absolutely.
So it's nice that people around the world are coming up with different things. So I think it's
interesting arenas.
It's interesting. Yeah, we've gone so much intracranial and intradural, both up and down, that the orbit does represent a new, very exciting frontier now, yeah, for surgery.
I may just share one personal experience. We presented our work on transcutaneous orbital endoscopy and published it in the journal Orbit. At that time, we looked through literature and there weren't, we couldn't find another article in literature at that time. But it caused such a hornet's nest and, such a controversy amongst the oculoplastic surgeons about the endoscopic approach that there were letters to the editor, and I spent a lot of time answering those letters to the editor. So, so it was a quite a chastising experience in the initial year or so. But then it settled down, as all controversies ultimately do.
Okay, so I think with that, we can head into our final session for the day, which is on tumors. Prathamesh is supposed to co-host this. I don't see him. Is Prathamesh there? I don't see him on the list.
No, sir.
So yeah, so maybe I can request you all to stay on. Narayan and Renuka. And we can start our talk with Dr. Rakesh Katna, who is actually also an ENT surgeon, also from Tata Hospital, a very young and brilliant surgeon doing very, very good work. He has trained with Prathamesh actually at Tata and learned a lot from him. And Rakesh covers a lot of hospitals across Mumbai. And he's helped so many people, and he's really our go-to person as far as oncology is concerned now. Rakesh, if you can have your video on and unmute yourself,
so for
then
people
we should
who
be
don't know
ready to have
Rakesh, I think for some people who may not know Rakesh, Rakesh is a growing guy, and I give you my personal experience. I've worked with him at Leelavati, and I think among the young guys, he's really good at his work. And thank you, Rakesh, for being around. And it's the decision making that matters, and he does exhibit a level of maturity when the decision making is concerned.
Thank you very much, sir. Thank you, Dr. Nishita and Narayan, sir. It's been an honor to be here presenting this talk also and getting all these praises from the stalwarts. It is considered Dr. Prathamesh Pai, who was my mentor in Tata Hospital for the oncology work. And a lot of then I learned when I joined Bombay Hospital working with Dr. Nishita and Dr. Pujari, sir. So it's like in a journey where we started with routine head and neck, routine oncology, then got into skull-based and skull-based oriented oncology work. So I again thank you very much. So I have a talk which I think is already pre-recorded. So can we go with that? Or shall I share my screen?
Sure. Can the organizing committee give us Rakesh's talk? Yeah. Before they start, we are happy to have Prathamesh. If you can have your mic and your video on. Prathamesh was with me at KEM Hospital when he was a resident. I would say that he's one of the most brilliant surgeons, internationally acclaimed surgeons that we are very proud to say is from Mumbai, head of the unit at Tata Head and Neck Department. Prathamesh. Okay, I think once Prathamesh is logged in, we'll get back to him. Technical committee, can we get Rakesh's recorded talk started? Sanchita, can you help us with this? Dr. Rakesh has sent his recorded video already. Yeah, sure. Prathamesh, are you on? Okay, Rakesh, I think your talk is started.
Yeah. So good afternoon, everybody. And in this third session of Symposium on Tumors of the Nose and the Skull Base, I, Dr. Rakesh Khatna, will be presenting on the benign tumors of the nose and the skull base region. And thank you very much to the organizers and the moderator of the session, Dr. Nishit Shah, and other organizing committee members also to give me this opportunity. So I'll proceed with my talk that's on the benign tumors of the nose and the skull base region. So when we talk about the benign tumors of the nasal cavity, these are the diverse group of disorders, the lesions, and endoscopy, which has helped not only the diagnosis and better management of these lesions better than before, but also ensures that when we are treating them, they have a shorter hospital stay, patient has faster recoveries and reduced morbidities. So more, according to the WHO classification, there's a huge list of tumors of the neoplasm which arise from the sinonasal area and the skull base area. More than 80% of sinonasal neoplasm generally are from epithelial origin, and 25% of these are benign tumors. So we have not only the epithelial neoplasm, but also mesenchymal tumors, salivary gland type tumors, soft tissue originating tumors, and the tumors of bone in the cartilage area. So when we talk about the benign epithelial neoplasm, they generally include the squamous papillomas, inverted papillomas, adenomas, and other miscellaneous rare lesions. In mesenchymal tumors, we generally have ossifying fibromas, fibromyxomas, and juvenile angiofibroma. And then salivary gland type adenomas, they generally include pleomorphic or the monomorphic adenomas, myoepitheliomas, and oncocytomas, which are rare tumors but can present in the nasal cavity. And soft tissue tumors, which include your myxoma, the vascular tumors like hemangioma, hemangiopericytoma, and nerve sheath tumors like neurofibroma or the schwannomas from the area. There are some tumors which arise from the bone and the cartilage area as well, like giant cell lesions, giant cell tumors. Most commonly what we see in our practice or we will see is like osteomas, and then chondromyxoid fibromas, osteoid chondromas, and ameloblastoma, and sometimes chondromesenchymal hematomas. So imaging and biopsy, they form an integral part in diagnosing the nasal masses. So they are the must for the diagnosis, and major importantly to differentiate between the benign and the malignant lesions. And why that's important? Because our whole management, whether it's surgical, non-surgical, but all the approach can be planned when we know whether we are dealing with a benign tumor in the nasal cavity or a malignant one. So in radiology, I'll not go into the details. We'll see in some subsequent slides, but CT and MRI are the most common investigations that are generally used in adjunct to each other in almost all the lesions. Diagnostic nasal endoscopy and biopsy is must, except when we are dealing with vascular lesions or angiofibromas. But generally, endoscopy gives you a picture how far extensive the disease inside is apart from the radiological imaging. And biopsy, whenever feasible, that also provides a roadmap whether what should be our approach and differentiating between a benign and a malignant lesion. So now commonly benign tumors, which we'll see in this talk, which we'll discuss, will be inverted papillomas, angiofibromas, that will be taken up in the next talk of the session, and then fibroosseous tumors like osteomas. We'll talk about hemangiomas, the vascular lesions, the nerve sheath tumors like schwannomas, and orbital and miscellaneous other tumors. So looking at radiology, the pathology can be graded as inflammatory, the benign, or the malignant. The radiological features in these three are different and gives us a clue that what kind of pathology we are dealing with. Generally, CT and MRI, as we discussed, are used. So when in CT scan, which is generally to see the bone involvement, in benign lesions, generally a remodeling of the bone which happens. When there is a destruction, you are in more favor of a malignant lesion rather than anything. Then an MRI, again, intermediate kind of signal and sometimes bright with obstruction, which is seen in the malignant lesions, and inflammatory lesions generally are more brighter. In fungus, it's more dark. But in benign tumors, it's intermediate signal which we see. And when we put in the contrast, it's a homogeneous contrast which is taken up by the benign lesion, but it's almost always a heterogeneous contrast which is taken or homogeneous in the
malignant one, and especially when dealing with inflammatory lesions, the contrast is more at the periphery rather than at the center. Squamous papillomas, one of the most common papillomas, they originate from the well-differentiated ciliated columnar epithelium or the respiratory epithelium with various degrees of squamous differentiation. So generally, they are classified into three categories: exophytic, oncocytic, and inverted papillomas. Squamous papillomas, they generally arise from the nasal septum, the exophytic types, and their treatment is generally conservative endoscopic surgical excisions with cauterization at the base. Most common what we deal and the difficult to treat one are the inverted papillomas. These are seen in 40 to 70 years of the age. They have an endophytic rather than exophytic growth infiltration into the mucosa, and they arise most commonly from the lateral wall of the nose and the septum. Male preponderance is there, and they cause locally aggressive tumors, so they cause local destruction of the adjacent tissues. 10% of these papillomas, why it is important to treat? Because they undergo malignant transformation into the squamous cell carcinoma. Generally, it could be a synchronous malignancy also, or otherwise metachronously in up to 1/3 of the cases. Wide surgical resection is the main treatment, and this can be done endoscopically. So we have a cross-staging system. There are various staging systems for inverted papilloma. Generally, which is most widely used is cross-staging system, which has stage 1, 2, 3, and 4. Stage 1 has inverted papillomas confined to the nasal cavity. Stage 2 involving the ethmoidal sinus, medial, and the superior part of the maxillary sinus. And stage 3, well, all the paranasal sinuses are involved, but still confined to the nose. And stage 4, when it's not confined to the nose or it's a malignancy synchronously, that is staged as stage 4. So inverted papillomas generally have an association with HPV 6, 11, 16, and 18 types, and also an alteration in the tumor suppressor gene P53. And the prevalence of the malignancy in the metachronous state is associated somewhere between 3.4 to 9.7%. Historically, the lateral rhinotomy or the open approaches like sublabial degloving and along with needle maxillectomy was used to make a wide excision of these tumors. But there, in the last few decades, it's been proven that the recurrence rates between the open and endoscopic approaches, there is no statistically significant difference. So there's a good paper by Lawson et al., which there are more than 170 patients. They compared the recurrence rates and found out there is no statistical difference in the recurrences when you do it whether open approach or endoscopic. Especially, we have very good results in endoscopic approaches in cross stages 1 to 3. We can use a frozen section if synchronous malignancy is suspected at the same time or the margins are doubtful. So this is a typical presentation of an inverted papilloma, mulberry-like appearance, which bleeds on touch. Generally, they are vascular tumors. Here it is arising from the lateral nasal wall and the maxillary sinus area. You can see vascularity. We are using a shaver or a microdebrider to debulk the central part of the lesion to be able to see the maxillary ostium and the surrounding structures. So you can use a coblator, you can use a shaver or microdebrider, comfortable and things available in your theater. This is after taking out the anterior margin to proceed with the medial maxillectomy. So the anteriorly uncinectomy is performed, and after that you can see the remaining part of the inverted papilloma. Now we start with taking out the medial lateral, the inferior turbinate. So this is cutting down the inferior turbinate to facilitate a good medial maxillectomy so that we have a wider access to the lesion. So here, after performing a medial maxillectomy, we are going inside the maxillary sinus. Simultaneously debulking, this is part of the medial maxillary wall only, which is being taken out. Here you can see the maxillary sinus. The floor of the maxillary sinus and the lateral wall, if you can see over here, is free. There is no involvement here. So the inverted papilloma, as we said, discussed, was commonly most involving the medial wall of the maxilla and the superior wall of the maxilla and going posteriorly. So this is the posterior most extension of the disease, which is going into the superior wall and then extension into the ethmoids. and then most anterior and posterior ethmoidectomy was performed. The superior limit of the disease identified in even the mag here, bipolarizing the ethmoidal artery. There you can see a little extensive little tumor remnant which is sitting up in the frontal sinus region. This is post-excision. So frontal sinus did not have any tumor, but most of because of the obstruction, the inspissated secretions were there, which was cleaned. So again, a full anterior and posterior ethmoidectomy was performed to make sure that we are not leaving back any residual disease back in the nasal cavity. And that should be the aim of when you're treating or dealing with an inverted papilloma, because the local recurrences are frequently seen if you are not doing a complete excision. This is the sphenoid sinus area post full clearance. Then comes our fibro-osseous lesions. The various types are osseous dysplasia, which could be hereditary and non-hereditary also. Then sometimes we have fibro-osseous lesions, which is classified again into conventional and the juvenile type. Juvenile type is more aggressive as compared to the conventional. Fibrous dysplasia, which could be monostotic or polyostotic. Generally, fibrous dysplasia happens in children and typically regresses at puberty. And radiologically, these lesions, as we see in the images, they're characterized by the ground glass appearance. More than 75% or more than 3/4 are monostotic, and they involve sometimes they involve the entire facial skeleton also. But whenever the polyostotic form is associated, it's generally with McDonnell-Bragg syndrome, which also involves a precocious puberty and capsular spots. And they have, as we discussed, they have high spontaneous propensity for the spontaneous regression. So surgical intervention is not recommended until unless it's symptomatic or there is a major facial deformity which is increasing. Ossifying fibromas, thin eggshell-like bony wall and hypodense center is there. In contrast to other tumors, they can be locally destructive. So a complete surgical excision is generally recommended. Then we have most commonly seen osteomas, bony lesions in the sinus and the paranasal sinuses area. They are commonly found in the frontal and the ethmoidal region. Incidence is 1 to 3% of the general population. Less than 5% patients are generally symptomatic. More common in the male population as compared to female. They have an ivory osteoma kind of appearance on the CT scan, which is a compact, dense ossified lesion attached to any bony sinus wall. So generally, treatment is not required. Only if there is a facial deformity which is happening or compressing the critical structures, then you require to intervene surgically. Then aneurysmal bone cyst, which is also called as ABC, osteolytic bone lesion, characterized by several like blood vessels or filled non-endothelial spaces of the various diameters. So there's, here you can see extensive lesion which is expanding the walls of the maxillary sinus, involving completely the nasal cavity, including the septum and both the sides paranasal sinuses. So here are a few images where the surgical resection was done, which was a piecemeal, and then you have multiple times you have to drill out the residual bone where you're getting a good dense bone, then you have to stop it. And these are vascular also, so you have to use your coagulator or bipolar for the vascular control. Post-op picture here, full clearance of the cavity, no residual lesion, but yes, wide but large nasal cavity post-surgery. Sometimes we see these kind of lesion aneurysmal bone cysts when they expand more anteriorly, so they are not amenable for the endoscopic resection. So here the open surgery is performed, better approach rather than the endoscopic one for the obvious reasons. So this patient had a lesion coming from the maxilla involving the lateral wall of the nose, middle wall of the maxilla, and expanding into the subcutaneous space in the skin. So whole excision was done along with the free flap, and ALT thigh free flap was put in for the reconstruction. Then paragangliomas, they are neuroendocrine tumors which generally originate in the adrenal gland, generally which is called as pheochromocytoma. But in head and neck, they comprise 3% of extra adrenal tumors. They are very, very rare in the nasal cavity. Generally involved areas are middle turbinate and the ethmoid sinuses, but they are vascular lesions. So this is a paraganglioma arising from escutcheon tube area. Here you can see well circumscribed lesion. You can see the posterior extent, the escutcheon tube. That's the choana here. and it's attached and it's going inside. A partial inferior turbinectomy was performed so that the access to the tumor is better, and you can use from the single nostril only, you can introduce more instruments for the dissection. Coablator was used as the paraganglioma generally present with the history of more vascularity. So to control the bleeding, coablator was used. After identifying its all attachments, cut was taken on the lateral nasal wall superiorly. So majority of the tumor was like free, but the stalk was attached to the ET area. So as we see, there's vascularity, but again, with the help of coablator, that is predominantly vanished. So complete excision was done and the base was then cauterized. And this is complete excision of the tumor. Now the important thing to look out for here is that how deep, this is the remaining part of the tumor which is at the base, because it was removed piecemeal, and then the base was bipolarized, and with the help of coablator again, hemostasis was done. So only important structure way here, if you have an if you can use your navigation system, because carotid, the internal carotid artery will be closed over here, so it will be a great help. Or otherwise, you can use your Doppler, carotid Doppler also for identifying the correct location if you don't have the navigation system. So taking out the remaining part of the paraganglioma, and after that the cavity, there's exposure of the cartilage of the station tube, and then the cavity is filled with the Surgicel in the gel form. Then we deal with capillary. Sometimes it have hemangiomas, which is broadly classified into capillary hemangiomas or the cavernous hemangiomas. Capillary hemangiomas are generally soft, pedunculate with sessile tumors, more commonly seen in the anterior part of the nasal septum. They present with recurrent epistaxis, or again a local excision with a cuff of surrounding with the perichondrium, and the cauterization of the base is only what we require. Cavernous hemangioma, they're generally rising from the lateral wall of the nose and the turbinates. And treatment generally is surgical excision if it is smaller lesion, or otherwise you can use cryotherapy or ablative therapy as well. So this is one hemangiomatous sinonasal polyp, which was this patient was admitted with history of hemorrhagic shock after massive bout of bleeding, was admitted in the ICU, stabilized first, and then on MRI it was diagnosed to having an angiomatous sinonasal polyp, which was bleeding. After that, he was taken up for the surgery. This lesion we can see attached to underneath the inferior turbinate, attached to the middle part of the maxillary ostium area, and posteriorly attached to middle turbinate. After assessing it, the middle septal part was free, and even the choana was free on inspection. Then we started with cutting of the inferior turbinate here to get an access again. So partial turbinectomy was performed so that we can have more space to go in and use our instruments while using a uninostril approach only. So this is cutting of the inferior turbinate. And then attachments superiorly from the middle turbinate was removed, again using a coablator. And then went laterally, did an uncinectomy, opened up the lateral nasal wall and joined the two incisions to go into the maxillary ostium. So you need to perform a medial maxillectomy. Again, difficult to do because the tumor is there. So you go behind the tumor here, but there was a space between the lateral nasal wall and the mass, and we could maneuver the tumor more anteriorly. Here you can see. Again, the tumor was in a large size, so piecemeal removal was done, because frozen section has confirmed it to be a benign tumor. This is the operative maxillary cavity, middle maxillectomy done. Some part of the tumor in the choana, which was removed. And a small fragment here at the anterior wall of the maxillary sinus, more so on the floor of the maxillary sinus. which was again taken out with the help of the coablator. So then hemostasis and wash was given after the procedure. Then sometimes we hemangioperiscytoma, they are also one of the type of the vascular neoplasms. They are very rare, 1% of all vascular tumors, and exhibit very low malignant potentials, and effective management generally for them is wide surgical excision only with clear resection margins. So this is a hemangioperiscytoma arising from the right, posterior to the right ethmoids. Hereafter, middle turbinate being pushed medially to create a space. An uncinectomy was performed. We'll just rush through. So anterior and posterior ethmoidectomy was done to reach the tumor. So after all the sinuses were clear, then at the end, yeah, this is the tumor posterior base, and which is going into the sphenoid ostium over here. So again, submucosal dissection was performed close to the bone so that the complete excision of the tumor can be done. The ethmoidal artery was bipolarized. Superior attachments after that cut down. Again, submucosal dissection performed. And the last few attachments, which was attached to the medial part of the posterior part of the septum, medially. Septal branch being bipolarized, and then tumor was taken up, removed fully. This is a post-operative.
Hello.
All the mucosa are gone, and hemostasis was achieved.
The
The nerve sheath tumors, which is relatively rare tumors, but most common are neurofibromas or schwannomas. They are 4% of all head and neck schwannomas. Generally arise from the branches of the trigeminal, anterior ethmoidal nerve, or the nasopalatal nerve, if more anteriorly. Generally, except surgery, none of the other treatment works. And if it is creating a problem, patient generally have an obstruction, and sometimes epistaxis can happen. But generally, surgery is the treatment of choice. They can rarely transform into malignant nerve sheath tumor, which is more in the neurofibroma as compared to the schwannomas. So this is an example of a schwannoma arising from the right nasal cavity. Here you can see the tumor, middle turbinate, lateral nasal wall, the septum here. Again, for the access, we tried to open up the middle turbinate into half and to save the middle turbinate. So Parsons window was created again. Maxillary ostium was opened up for the access and the better instrumentation from the lateral side. Here you can see ethmoidectomy was done, and then the sphenoid sinus over here. Now the tumor attachments, this is sphenopalatine crest, and the sphenopalatine artery, the branch was identified here, which was bipolarized. So either you can use bipolar, which is generally used for the sphenopalatine artery, or you can identify, take the vessel, and you can use clip also, which sometimes is being used by the laparoscopic surgeon. So you can use that Liga clip also, though it is a little difficult to use because of the access to that area. Then the medial attachments taken up from the septal side. for the complete removal of the disease. Again, a submucosal dissection was performed because it was badly adherent to the bone over here, along with the septum of the right side. So using a cobblator, again, subperiosteal dissection was performed and the tumor was large enough so that was pushed into the choana and was taken through the oral cavity. So this is a post-operative hemostasis being done. Then we had recently one sporadic hybrid enschede schwannoma, which is a rare combination of neurofibroma and the schwannomas, and we are putting for the publication as well. So these lesions are very rare. Unfortunately, we didn't have the complete video for the surgery, but endoscopic excision, again, it was attaching to the middle turbinate, sphenoid sinus, and the lateral nasal wall. Endoscopic excision was performed along with the help of the cobblator. Sometimes when we have chordomas generally they are considered low-grade neoplasm which display a locally malignant behavior. That means they are aggressively at the local area, destruction of the local adjacent tissue happens and they have high local recurrences rate. So this chordomas generally are very soft appearing lesions. So we started from the midline, took at the center part and then the wall of the lesion, which was taken out completely because they have a very high recurrence rate. So you need to take out the wall and then drill out the base. So here the medial cut and the laterally the capsule was completely removed. You can see the posteriorly is the sphenoid sinus here. And the lower attachment is at the clival area. This is going into the nasopharynx here. Again, a complete removal. But the story does not end here. You have to completely remove all, burn the mucosa posteriorly, and then you have to drill the base. Sinus mucosa of the sphenoid sinus was also removed, though it was not involved. And this is the post-operative picture. Your sphenoid sinus, sella and suprasellar region, and then clival area. Going till the upper nasopharynx. So the take home from this is that one thing, this triad, that imaging, the diagnostic nasal endoscopy and biopsy whenever feasible should be done to identify preoperatively or before the final management that what kind of lesion we are dealing with and what our approach should be. So that provides not only a roadmap, but also gives like the approach also helps out in the better outcome for the patients. And as we know, these are diverse lesions. They are not very commonly seen. The histology generally rules and dictates our treatment choices. So we should be in contact with the surgeon should be in touch with the both radiologists and pathologists. And if you require, get the slide review on the pathology also before ruling out or going in for any further treatment. Endoscopic clearance is generally as good as open approaches, which has been shown by multiple publications in the last few years also, that the recurrence rates is same whether you are doing an endoscopic as open approach, but obviously you need to choose your patient wisely. And generally these endoscopic clearances in these tumors, they helps in not only reducing the shorter stay, reducing the stay for these patients, also giving lesser morbidity, better control rates as compared to the open access approaches also. So with this talk, I'd like to thank again the organizers, and thank you very much for your patient listening, and we'll proceed with the next talk. Thank you.
Hi, Rakesh.
Yes.
Prathamesh, good to see you finally.
Hi, Nishit. Sorry, I was in the other hall. They had next sessions going on there. Just joined in.
Okay. So Prathamesh, you can take over.
Talk. Yeah, Rakesh, that was a very nice talk and very crisp videos. So the common mistakes that we find the our colleagues doing in practice. Would you like to give them some message regarding assessing these cases on imaging?
Yeah. So thank you very much, sir. With this point, first thing as we had initially in the talk also, I mentioned that imaging as a diagnostic nasal endoscopy is a must for before treating or before starting to embark on the treatment part of these patients. So you better to have the investigation in the form of a CT scan as well as an MRI. These lesions, generally, this is an intricate anatomy of paranasal and the skull base area. You need to have clearance about your bone involvement. So get down a CT scan. Plus, you have to have an MRI to rule out where the soft tissue extensions, the secretions, what is the correct extension. The CT scan, if you are using a navigator, then you can do a navigation-based CT scan also. But still, I would recommend that you do a proper contrast-enhanced CT scan along with an MRI, which is a must for all these patients before starting. And if possible, if patient is not bleeding, it's not a vascular lesion or something, always do a diagnostic nasal endoscopy first to see what your imaging is correlating with your nasal endoscopy examination.
Right. Coming to these vascular lesions, which you talked about, the paragangliomas and even chordomas tend to have a lot of bleeding. What precautions you will take and what kind of planning do you do prior to your surgery?
So again, when you are dealing with the vascular lesions, so you have when your MRI, that definitely most of the time it tells you about the vascular anatomy about it. And if you require an embolization, then you can proceed with that if it's a major vessel which is supplying to the tumor. If it's a smaller size tumor, generally, then you don't require embolization. Yes, but you keep your blood ready, keep your anesthetist informed about it before embarking, and it is always better to do with your team rather than you embarking alone. And if preferably in these patients, if you can do, these are like videos which are showed by very small, you can courtesy to Dr. Nishit Shah, sometimes I have taken. But when you're a large lesions, try to do a binostril forehand surgeon technique, which gives you a better access in terms of instrumentation. And Coblator definitely has, which I had started using last like 4-5 years back now only, but it has definitely changed a lot of things with the terms of the bleeding. It definitely helps during the keeping the intraoperative field very clean.
Right. So you do find that the Coblator has made a major difference in your management.
Yes. Yeah.
Okay. So that would be your recommendation to consider using a Coblator device when you're dealing with vascular lesions.
Absolutely.
What's your experience with using the Surgiflow and all hemostatic agents?
So Surgiflow and the other hemostatic agents, when we are doing the transsphenoidal for the pituitary, generally we are using for the bleeding from the cavernous. So whenever you have venous bleeding, yes, the Surgiflow helps very much. But when you are dealing with an arterial, again, it's your anatomy. You have to pick up the lesion where the artery is bleeding from. So you have to very, very strong on your anatomy part to correctly identify the source of the bleeding and then take care of it. You can use a bipolar, that gun bipolar, which is a very, very good instrument in holding because it's small size. Sometimes we have issues with a large maxillary vessel, especially in the angiofibromas. Then some cases I've done with Dr. Nishit also at Bombay Hospital only. Then we use a harmonic, which we use in laparoscopic to seal that vessel, and liner clips also. But yes, Surgiflow is more for venous bleeding rather than the arterial.
Right. Nishit, are there any questions in the chat box?
Not seeing any questions, Prathamesh, so we can go to the next talk.
Sure. The next talk, would you be introducing Nishit?
Renuka. No, you introduce Renuka.
For the next talk, we have Dr. Renuka Bradu, who actually deserves a wide applause for her dedication and bringing about a revolution in management of the angiofibroma. And she is here today to talk to us about the angiofibroma grid and how we can use this classification for the surgical steps and prognosis. Over to you, madam. Dr. Bradu.
Renuka, you're on mute.
Thank you,
Good afternoon,
Prathamesh.
madam.
Nishit, I've already recorded my talk, so maybe you can ask them to give it to the organizer.
Okay. Can the organizer start, Dr. Renuka Bradus? Yeah, okay, excellent.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizing committee, Dr. Gautam Count and Dr. Nishit Shah for inviting me to share my views. I'm going to talk today about the angiofibroma grid. It's a system of classification that I have formulated, and I would like to discuss this a little bit in detail. There are a number of classification systems for JNA, and some are pre-endoscopy era, some are post-endoscopy era. So if there are so many classification systems, why is it that we need another one? So the ones which are most commonly used now are the Androflisch-Radkowski, which were pre-endoscopy, and the UPMC and Dr. Janaki Ram's classification, which are post-endoscopy. So with these four specifically being there, why do we need another staging system? There are certain lacunae which exist in the present staging system. Not that these lacunae exist in each and every system, but in various systems, there are various lacunae, and I'm going to go over that in brief. So most of the classifications are based on the premise that the larger the tumor, the more difficult it is to remove, which means that if you have in the pterygopalatine fossa, it is easier than in the infratemporal fossa, and so on and so forth. But this is not necessarily the case. Very often it can happen that the tumor is so small, but the region in which it is much more difficult to remove than a larger tumor. For example, look at this tumor. It's quite small, but the region in which it is involved is the greater wing of the sphenoid. If the region is involved, which is not only more difficult to remove, but it also has a higher rate of recurrence than, say, a tumor which is larger and in the infratemporal fossa. And so to stage this as a smaller tumor above this, which is a larger tumor, would not be quite right. The lacunae in the present system are also that it is confusing. When you see the staging system, it is difficult to remember the details. And the early ones, of course, are before the pre-endoscopic era, and they really can't be relevant today. All staging systems are not standardized. So stage 3 in one system is very different from stage 3 in another system. And therefore, it does become a little difficult. Now, most systems talk about the region that is involved. You know, if the pterygopalatine fossa is involved, the intratemporal fossa is involved, but they don't talk about the route of spread of the tumor. So it is possible that a tumor occupies a certain area, say intracranial or pterygoid fossa, but the route of spread is not mentioned. And because you don't mention the route of spread, very often the surgical steps for these tumors, though they lie in the same region, but their surgical steps are very different depending on the routes of spread. And so it's very important that not only do you know the region involved, but in what way did that region get involved? What were the areas of spread from where that region was involved? And like I said, the routes of spread decide the surgical steps. So if it's an intracranial tumor, the surgical steps will be depending on which method, by which method they have, the tumor has spread intracranially. So the many ways in which a JNA can spread, these are only a few of them that I've put up. But as you can see that the tumor can spread intracranially by this way, then by the middle cranial fossa this way, the middle cranial fossa in this way. So knowing which of the ways it has is spread is very, very important. These are the different modes of intracranial spread, so many of them, and each of them will have a different surgical step, a different instrument, and different way of delivering the tumor. So it's very important to know where the tumor is and how it has reached there. So this is a tumor which has reached intracranial through the orbital apex. And this is one which has reached intracranially through the greater wing of the sphenoid. And like I said, the way you'll approach these two tumors will be very, very different. A lot of the classifications do not take into consideration the relationship of the angiofibroma to the internal carotid artery. And this relationship is like this. The tumor tends to wrap itself around the internal carotid artery, and therefore a greater detailed subclassification of the JNA with the internal carotid artery is required. And not only does the angiopharma come in contact with a particular part of the carotid artery, it can be in contact with any one of these carotid arteries, the parapharyngeal, the intratemporal, the foramen lacerum area, paraclival, paracellar, and paraclinoidal. And therefore, just saying that the tumor, is abutting or encasing the internal carotid artery is not enough. The classification should give an idea as to which part of the carotid artery is involved, so that you know the relative risk, the surrounding structures, what are the critical structures around it. So the staging system must mention what part of the carotid artery is involved by the tumor. A lot of the classifications do not, in fact, most of the classifications do not mention the pterygoid fossa extension. We all know that the tumor spreads laterally through the pterygopalatine fossa and then to the intratemporal fossa. This is in front of the pterygoid base, but it can also spread to the area behind the pterygoid base, between the two pterygoid plates, that is the pterygoid fossa. Now, it can spread by to the pterygoid fossa by two routes. One is through the pterygoid base. So this is the pterygoid base on the normal side. This is the eroded pterygoid base, and it has spread inferiorly between the two pterygoid plates into the pterygoid fossa. Or it can also spread from the nasopharynx through the sinus of Morgagni into the pterygoid fossa behind the pterygoid. So this is the pterygoid fossa behind the pterygoid plate, and you can see the tumor has entered here via the nasopharynx. I'd like you to keep this picture in mind, because I'm going to talk in a little bit more detail in the later half of my presentation. So remember, that's the two routes by which it involves the pterygoid fossa. Now, we always talk about intracranial and extracranial tumors, but there is a third entity, and that's called intraosseous tumors. So you see this. So there's an intracranial tumor, an extracranial tumor, and what is called an intraosseous tumor, or rather I call it an intraosseous tumor, because you can see that the angiopharma has the propensity to expand compact bone and erode into the marrow spaces of the cancellous bone. And therefore, this is neither intracranial nor extracranial, but intraosseous. And it is very important that system let us know, the staging system let us know whether there is intraosseous spread, because the recurrence rate of these tumors is higher than it is with extracranial or intracranial tumors. So having discussed those lacunae, let's look at the angiopharma's grid. So first of all, it is not necessary to memorize it. So you understand that if there are so many classifications and if you memorize them, the chance of remembering them without confusion is difficult. So all you have to do is actually look at it like a visual analog scale. So you don't need to remember these things, whether it's severe pain or this is a pain scale or a worse form. You just need to look at these pictures and you know exactly what kind of pain the patient is. And so also the angiopharma grid is a system of staging where you don't need to remember anything, memorize anything, or commit anything to memory, but you just need to look at it, and it's very simple once you realize how to use it. So now this grid consists of 9 rows and 9 columns. Okay, it is based on the findings of the contrast enhanced CT scan, and if needed, an MRI scan. We do MRIs in angiopharma with contrast when you have an intraorbital or intracranial tumor. And therefore, if you've done a contrast enhanced CT scan and a contrast enhanced MRI, you will use both. If it's an extracranial tumor where you use only the CT scan, then you will only use the CT scan. And it is based on these findings, which means it makes it pretty objective. So there are 9 rows and 9 columns. And the columns, the first column mentions the region involved by the tumor. That means it is involving the nasal cavity. So for example, these are the regions involved: nose, lateral spread, orbit, pterygoid fossa, so and so. So these are the main regions involved. And the second column gives the short form of that region. So nose will be remembered as will be denominated by N, lateral spread by L, orbit by O, and so on and so forth. So this is the second column. And then the remaining columns from left to right are the different sub-regions involved. So if you have the nose involved, that's N involved, then you can have it in the nasal cavity or maxillary sinus, sphenoid sinus, or nasopharynx. So from left to right, these are the sub-regions which are involved in the region nose. And so on and so forth for each of these regions. So this is the intracranial region. These are all the sub-regions which are involved. This is the orbit. These are the sub-regions involved. So there are 9 rows, each depicting different subregions progressing in difficulty from left to right. So the ones in the first column are relatively easier to deal with. So for example, if you take lateral spread, pterygoid palatine fossa is easier to deal with, and then progressively it becomes more and more difficult to treat the tumor. The grid is divided into 5 different colored zones. The light green is smaller tumors which are surgically much easier to resect. The dark green is tumors that are a little more difficult. Orange zone tumors are with intermediate level of difficulty. Red zone tumors are large tumors with extensive spread, which can be difficult to access and therefore need a greater degree of expertise. And then the last one is the gray zone. This gray zone is of tumors which encase more than 50% of the internal carotid. And the reason it's in gray zone is because there has a very narrow risk benefit ratio. It can lead to removal of this tumor, can lead to serious neurological sequelae. And therefore it's in the gray zone where the surgeon decides whether to remove it or leave it behind. Therefore the gray zone. And therefore, like I said, these are the zones. And so these will be the most easy tumors to remove. And the red will be the most difficult, and the gray will be whether you remove them or not. So this is how the grid is fashioned. This is the short form of the grid. Okay, so the same thing, each subregion is given a letter, and the region, as the region was given a letter, the subregion is also being given. So this is nasal cavity, maxillary sinus, sphenoid sinus, and nasopharynx. You don't need to have the short form because it may be difficult to remember. You can download the full form of the grid like this, the entire form from the net. It's available. There's also a YouTube video explaining the grid on YouTube. If you just Google Bradu and grid, you'll get it. Now, how do you use the grid? So a contrast enhanced CT scan is performed in all planes, axial, coronal, and sagittal planes. We use the you can use the CD. You can also use the plate. Sometimes when you're trying to see things multiple windows at the same time, it is better to have it on plates as well. Contrast enhanced and MRI would also be done for the intracranial and intraorbital tumors. You need to take a printout of the grid from the net, or you can make one and then just Xerox it. The region which is involved, each region is studied on the scan, and if the tumor is present in that region, that representative square is shaded. Depending on the number of patterns of squares shaded, the tumor is divided into light green, dark green, orange, or so even if the entire tumor lies in the orange zone, but only one square of the red zone is shaded, then it becomes a red zone tumor. So let's start looking at it region-wise. So let's see the first region. The first region is the nasal cavity, that's the nose. Sorry, the first region is the nose, that's N. And if it involves only the nasal cavity, you will shade this square, the NC, nasal cavity. If it involves the maxillary sinus like this, you shade this square, maxillary sinus N. If it involves the sphenoid sinus, you shade this square. And if it involves the nasopharynx like this, you shade NP, the nasopharyngeal square. The next is the lateral spread, and this is lateral spread anterior to the pterygoid base. So lateral spread anterior to the pterygoid base is L. If it just involves the pterygopalatine fossa, then the PPF square is shaded. If it involves the intratemporal fossa to a limited amount and as a single nodule, then you shade this square. If it involves the intratemporal fossa to an extent which is almost going up to the mandible and it has multiple lobes like this, not a single lobe, then it becomes IPS plus. If it progresses even further and goes into the parapharyngeal space, so this is the oral cavity, going into the parapharyngeal space, then you shade PP. And if it goes into the temporal fossa, like this, then you shade PS. Now, if you take the full grid, you don't even have to remember these short forms. So this is how it will go in lateral spread, anterior to the pterygoid base. How does it enter the orbit? How do you subclassify the regions of the orbit? So if it is just entering the inferior orbital fissure, like a very small bit, then it is IOS plus. If it involves the inferior orbital fissure in a large way, it has gone extended right into the orbit, then you have IOS plus. And if it has gone beyond the inferior orbital fissure into the superior orbital, this is the superior orbital fissure on the normal side, this is in the superior orbital fissure on the disease side, and then you shade SOS. So this is how you grade the degree of involvement of the orbit progressively from left to right. And you can see if it's a very small involvement, it's a green zone tumor. And if it involves it significantly, IOF and SOF, it becomes an orange zone tumor. The pterygoid fossa is denoted by PF, and like I said, it is the lateral spread behind the pterygoid base into the area between the two pterygoid plates. Now, the important thing in this is the pterygoid fossa is involved, but here we are seeing by which mode does it spread into the pterygoid fossa. This is very important. And like I showed you earlier, if it has involved the pterygoid base and then gone inferiorly into the pterygoid fossa, then it has gone through the pterygoid base, so PB. And if it has gone from the nasopharynx through the sinus of Morgagni, then it has actually gone spread there through the nasopharynx, and therefore you will shade NC. So in this subregion, you're actually seeing how the pterygoid fossa is involved by which route. M stands for marrow space. These are intraosseous tumors that I spoke about. They're neither intracranial nor extracranial. They're within the marrow space. And how is the marrow space involved? Which region of the marrow space is involved? So if it involves the clivus like this, you shade C. If it involves the Vidian canal, so this is the normal Vidian canal. If it involves the Vidian canal, then you shade V. If it involves the foramen rotundum, so it's gone all the way up to the foramen rotundum, then you shade FR. And if it has gone beyond the foramen rotundum, it's gone beyond Vidian canal, beyond foramen rotundum, and into the greater wing of the sphenoid, like this, then you shade W. So this is the way you will talk about marrow space. It's very important to designate this marrow space, because these tumors, you need to be absolutely certain that you've done a very good skull-based drilling, and that you also remember that these tumors have a higher rate of recurrence. So anytime you see M or marrow space, the prognosis is not guarded. You have to work harder to make sure that the tumor doesn't recur. And yes, you may want to discuss that with the patient in his consent. Now, intracranial, I already showed you how many different ways it can involve. It's denoted by the letter I. So if it goes through the orbit into the cavernous sinus, you shade the shade O. Rarely, it may go through the sphenoid roof. And if it goes through that, then you shade SR, sphenoid roof. If it goes through the Vidian canal backwards up to the paraclival carotid, you shade V. If it goes through the foramen rotundum like this, below the cavernous sinus into the middle cranial fossa, you shade FR. If it's very unlikely that if it goes through the lateral wall of the sphenoid, well, not so unlikely, you can get it pretty often, not pretty often, fairly frequently. Then if it goes through the lateral wall of the sphenoid, then you shade sphenoid lateral, so SL. If it goes through the greater wing of the sphenoid, like this, so it involves the greater wing and then goes intracranial through this, then you shade W. And if it goes through the junction of the greater wing of the sphenoid and the pterygoid and the lateral wall, that means at the level of the foramen lacerum, you shade sphenoid, lateral wall, and wing. It's very important to know which route this is spread by, because according to that, the tumor will either lie extradural, interdural, or intradural. And therefore, the level of risk of removing this tumor changes depending on whether it is extradural, interdural, or intradural. And that you get from this classification. Now, we are discussing the carotid. The carotid gets involved either by abutment, that means less than 50% involvement. And if the carotid is involved, these are letters which denote the different parts of the carotid. So if the carotid is abutted again by the paracellar area, you shade S, the paracellar carotid. If it is along the area of the foramen lacerum, you shade FL. And if it is along the parapharyngeal, that means extracranial, and near the parapharyngeal carotid, you will shade PP. Now, you can also get more than 50% involvement of the carotid. And this is what I said, that they are the gray zone tumors. And if the carotid is encased, you put CE, carotid encasement, more than 50%. And if it is involving the paraclival carotid more than 50%, then you shade C. And if it is involving the paraclinoidal carotid more than 50%, you shade CS. So stellar, paraclival, paraclinoidal, foramen lateral, and parapharyngeal part. So this is the gray zone tumor. If there's any aberrant behavior, that means the tumor doesn't behave like it normally does, then you have no, there's no aberrant behavior. And yes, there is aberrant behavior. And if you shade the block yes, then you have a place here to write a note as to what is the aberrant behavior of the tumor, so you remember it intraoperatively. So either, for this case, the tumor has undergone cystic change. It has gone through the roof of the cribriform plate into the anterior cranial fossa, which is not very common. It can also go through the infratemporal fossa, not through the pterygopalatine fossa, but through a lateral recess of the sphenoid. So these are all aberrant behaviors, and you will shade yes, and you will write a note as to what is the aberrant behavior. Once one masters the grid, one knows the grid, it is possible to represent it in a series of alphabets. The region involved is mentioned as a capital letter, and the sub-regions are involved as a subscript. So for example, the tumor in the nasal cavity, the region is N, and if it has spread to the sphenoid sinus and the nasopharynx, then it is N, involving the nasal cavity, nasopharynx, and sphenoid sinus. So this is how you will write the note that is in tumor. So let's look at these tumors. This is an orange zone tumor. These are the areas involved. And so the nasal cavity is involved, sphenoid sinus, nasopharynx, PPF, IPF, and the inferior orbital fissure. And you can denote it like this. The nasal cavity, the sphenoid sinus, nasopharynx, and N, L, PPF, IPF, and O is inferior orbital fissure. So this is how you can denote, with the number of letters, the entire involvement of the tumor. And it is possible with these letters to actually imagine the tumor. So if you don't have the plates in front of you, you just have this, you can imagine, yes, it's a nasal cavity, it's in the sphenoid, it's in the nasopharynx, it's gone laterally up to the IPS. And yes, it has involved the orbital, inferior orbital fissure and the orbit to a significant amount. Let's do another one. This is nasal cavity, nasopharynx, lateral spread, and involvement of the pterygoid fossa through the nasopharynx. So that's the tumor there. And this is how you will write it. The nasal nose region is nasal cavity and nasopharynx. The lateral spread is ITF up to the IPF. The pterygoid fossa is involved through the nasopharynx. This is how you would write this tumor. And so we come back to how the grid, as I've explained it, and let's see what are the advantages of it. How does the grid compare with the rest of the system? So it's an objective method. It is described on the tumor radio imaging. So there is no subjective bias at all. So what I read and what someone else reads will be the same. If you were, another staging system, you may have some gray, like some dubious areas where you are not sure, and you may have a different reading than someone else. It describes each region in detail into sub-regions, and not only does it describe the sub-region, it describes the route of spread, and the surgical steps are based on this route of spread. There's involvement of the marrow spaces of the cancel bone. Cancel bone is a key factor in determining the recurrence, and row 4 describes this involvement very specifically and in great detail. It can be used for preoperative planning. So in my theater, when I'm starting a surgery, the resident will show me the grid, and I look at it so I know what regions are involved and how I need to go about it, what surgical steps. It helps the surgeon track his own learning curve. So, you can start with doing only green zone tumors, then gradually progress to orange zone tumors, red zone tumors, and then of course the gray zone tumors. So it helps you track your own learning. And a discussion or second opinion on the tumor becomes easy if both surgeons have the tumor mapped on the grid, even though the second surgeon does not have access to all of it. So suppose I want to consult with someone in Indore or Delhi, I can send them the grid. I mapped the grid, I've shaded the squares, and I just scan the grid and send it to them, by email or WhatsApp. And then it's possible to have a discussion about this tumor, discuss various surgical steps, even though the second surgeon doesn't have all the plates. So that can happen. And in case of residual tumor, when you left behind tumor, you can do a post-operative grid and map what is the residual tumor remaining. Now, the last bit is about force of sum of vectors. So there is in angiofibroma, it's very necessary to understand vectors. One force is the inertia of the tumor. Force two is the direction in which you're pulling. And this is the final resultant movement of the tumor. So you need to understand how vectors work in angiofibroma. So I want to show you this. It's a surgical video of the pterygoid base involved by the pterygoid fossa involved by the pterygoid base. So you see that this is where the two pterygoid plates are. This is the pterygoid fossa involved, and it's gone from the pterygoid base. So it's necessary to use a small instrument, and you have to apply a pull, direction of pull upward. If you don't apply this direction of pull, you can tear the tumor. So this is how you would deal with a pterygoid fossa tumor involving the pterygoid base. This is a tumor involving the pterygoid fossa, but from the nasopharynx. So this is the nasopharyngeal component of the tumor. You use a much larger forceps, like a lux forceps. Hold it, and you pull it medially. So the direction of spread is not upward, but medially. And you see that the entire pterygoid fossa extension comes out. So it tells you exactly how to move the tumor. I'll skip, or maybe I can show you this. This is an intracranial tumor. This is intraorbital. So this is the orbit through the lamina paprica is removed, and this is a tumor being removed. And there, the direction of force is applied infero-medially. So you can see how infero-medial direction of force is applied to deliver it from the orbit. And if you go to this part, it's the same tumor, but now we are delivering it, so it's delivered from the orbit. Now we are delivering it from the cavernous sinus. And instead of an anterior inferior push, we are now applying a direct inferior push. So this is how you would remove the tumor. If you don't apply tumor, so this is coming out of the cavernous sinus, you get a glimpse of the carotid over here. That's the carotid there. And so the direction of pull is very important. And therefore, I'd like to thank you for your kind attention. And it gives me about 5 minutes, 4 to 5 minutes for questions if you have any. Thank you very much.
Thank you, madam, for that extensive, elaborate grid description. And I'm sure we need to ensure that more people apply this grid to the management of angiofibromas. Having done a few of these, I realized that there are problems in assessing. The radiologists seldom understand what you would want, and it's very important that we have a good dialogue with the radiologist. And as per your grid, we would need to document where exactly the lesions are so that it will facilitate a complete removal. My one question to you was, with this grid, would you be able to develop an algorithm towards how we would want to start off and end?
Start off and end the surgery? Or start off and end a career?
The surgery.
Oh. Okay, so just a little insight. You know, when I first started, I did the first case, I thought it was a bit of a fluke, because the second case went downhill and I had to open up and operate. But then as time went by, it was possible to replicate those steps. And then other people were able to replicate the steps as well. So like thyroidectomy, like stapes surgery, angiofibroma surgery can also be replicated by a set of steps. But the real, so where you would begin would be, there are now various techniques available. The modified endoscopic dentures, I do a 4-port technique. But wide axis is the primary thing. So the first thing is never touch the tumor till you've got a really wide axis. Now, why wide axis? It depends. It doesn't mean necessarily that a wide axis means maximally destructive. You can have a wide axis by preserving normal structures as well, especially if you remember that this is a young boy whom you're dealing with. So there are ways of getting a very wide axis, not only visually, but also for your instruments to be able to come from different trajectories rather than parallel to each other. So if you manage to get access where, like a laparoscopic surgery, you can get instruments in some different trajectories, wide apart trajectories, that is what we're looking for first. And you don't touch the tumor till you've got that access. So that's where you really begin, with access. And where you end is with skull-based drilling. So when you take out the whole tumor, you should be, whether you take it out in toto or you take it out in planned piecemeal manner, just tugging at it, but you say, okay, I'm going to remove this portion of the tumor, then I'm going to go for the next portion. So first I'm removing the nasal cavity, then I'm removing the infratemporal fossa bit. So if you do a planned piecemeal removal and you put the tumor together, you should be able to map that entire tumor to the CT scan or MRI to make sure that you've got each and every extension out. So you should be able to correlate your tumor specimen to the imaging. And once you've done that, so that would be your second last step. And the last step would be that everywhere where there is exposed bone, especially cancellous bone, to make sure you do a very, very good drill out. Especially people forget the palatovaginal canal. So, they remember the foramen rotundum and the Vidian canal, where the angiopharma goes through like noodles, like little noodles into those foramina in the canal. But they often forget the palatovaginal canal. So you need to drill out that canal as well. So that's where you end with a lot of drilling of the scalpel. And yes, a very, very regular planned follow-up for at least 4 years.
The question I asked you was, madam, because since you're given color coding to the grid, is there some way that you would advise us to begin with, start from the gray section, go to the orange section, or, I'm just thinking aloud. Is there some way that if I have a tumor which is going from the yellow zone to the gray zone, is there some way I can actually plan my resection, understanding the zones, the vascular involvements, the marrow space involvements, and then proceed in a planned way?
Yeah, so two things, two ways I describe it. One is depending on the experience of the surgeon. So someone who has got a perfect understanding of the sinus anatomy and knows how to get vascular control endoscopically. Those are the people who should start with the green zone tumor. So until you've learned how to control blood vessels endoscopically, I would suggest that you you take help while doing angiopharma surgery. But once you've got that, then the green zone tumors are perfectly possible. Maybe 10 cases later, as you understand this vectorial concept that if I pull in this direction and the tumor is pulling or is in inertial in this direction, will move in a third direction. If you start understanding that, then the orange zone tumor. And then with a significant degree of expertise and of course, lots of discussions, then a very high level of expertise. If you feel that, the chances of giving neurological complications is fairly high in a young boy who's walked into your theater and expects to walk out, then you may actually take that decision to actually leave behind, say, the size of half a pea of tumor behind and watch it. Either do gamma knife and ablate it or just watch it and see whether it grows back. So this is the consent which is taken beforehand from the patient. So this is as far as experience is concerned. And the way the grid would be used is, suppose I have something which says IOS, which means single lobule, not very extensively going all the way up to the mandible, then I would do just a routine, transnasal approach, endoscopic approach. But if I have something which says IOS plus, which means multiple lobules going all the way about to the mandible, then I would do what I call the 4-port technique. So I create accessory ports on either side of the frontonasal fossa of the max. That's why I don't do a modified endoscopic dentures. I don't remove the nasolacrimal duct. I don't remove the lacrimal. I don't cut the nasolacrimal duct. I don't touch the anterior facial skeleton at all because it's a young boy and angiopharma is never attached to the anterior facial skeleton. So I will work around the frontonasal fossa of the maxilla and the lacrimal system and create ports in the canine fossa and in the buccogingival surface. So there will be 4 ports, which allows me to go progressively laterally under vision and give me a perfect dissection space without removing.
Communication issue with the chat. So I'll ask Narayan to
just
take charge.